the endoscope surgery here, so we could so many cases for endoscope surgery for the patient. Especially thanks to Professor Irismetov and Dr. Professor Shaturushinov. Thank you so much. And Dr. Shomansuruk, the Shaturushinov, and Akor also, thanks. And especially the Mr. Oruju, you organized good the conference. We will organize more the bigger size, the qualified endoscope society in the near future. So include all the Central Asia. Anyway, this time I hope it will be a good chance for you to learn the endoscope surgery, and then for the academic exchange each other. Welcome to Uzmiss again. We will start. Thank you.
Thank you, Professor Lim Kang-tek. Now I am pleased to invite Dr. Morujon Erismetov, the Director and Head of Department of Traumatology and Orthopedics at Republican Scientific and Practical Medical Center of Traumatology and Orthopedics of Uzbekistan, to give a welcome statement.
Assalamu alaikum. Здравствуйте, уважаемые коллеги.
Dear colleagues, dear ladies and gentlemen, dear friends, dear participants of today's event. It is my pleasure to welcome Professor Lim, who for the first time visited Uzbekistan and who has started conducting endoscopic surgeries for the first time in Uzbekistan in spinal surgery. And I would like to express my sincere gratitude to Professor Lim, who has trained our specialists, who have nurtured our specialists, because at the moment our specialists are conducting these surgeries on their own. And you know, whenever you are starting something new, there always be some resistance, there will always be some obstacles and challenges, but hopefully I'm very pleased to announce that in our center for the third year in a row, these endoscopic surgeries are conducted at a very large scale, and on daily basis we are having around 7-8 surgeries conducted. And I am pretty sure that these conferences which are held here under leadership of Professor Lim, Professor Shotor Sunov, and Professor Shomansur, they will contribute to developing endoscopic vertebrology, and at the end of the day, it will render its assistance to our patient, to our people, to the population who is suffering this disease. And of course, I would like to wish the best of success and luck to the participants of today's conference and the successes in all of your endeavors.
Let's see the video.
2023, Uzbekistan embarked on a comprehensive journey of healthcare reform, driven by the aim of enhancing medical services and promoting academic excellence within the field. Central to this transformation was the Republican Center of Traumatology and Orthopedic Medicine, which emerged as a beacon of progress, achieving remarkable milestones across various fronts and setting new standards for patient care and scientific advancement. Patient care and surgical excellence. Throughout the year, the center experienced an unprecedented influx of patients, with a staggering 97,270 individuals seeking medical attention. Among them, 11,155 patients underwent successful inpatient treatment, experiencing full recovery under the care of dedicated medical professionals. The surgical department also saw a significant rise in activity, performing a total of 10,158 procedures. These surgeries encompassed a wide spectrum, ranging from routine interventions to complex orthopedic procedures, highlighting the center's expertise and commitment to delivering high-quality care to patients in need. Academic contributions and scientific achievements. In addition to its clinical success, the center made substantial contributions to the field of traumatology and orthopedics through academic research and publications. Over the course of the year, the center's staff authored more than 100 scientific articles and presented over 400 dissertations, enriching the global body of knowledge in the field. Under the auspices of the center's academic council, 15 dissertations were successfully defended, showcasing the depth of expertise and scholarly rigor within the institution. Technological advancements and innovative procedures. One of the hallmarks of the
Center's progress in 2023 was its adoption of advanced surgical techniques and technologies. New procedures, such as arthroscopic surgeries for knee and shoulder joints, minimally invasive plating osteosynthesis for long bone fractures, and total hip arthroplasty with short stem implants, were introduced. These advancements allowed for improved patient outcomes and shorter recovery times. Notably, the center achieved a significant milestone by successfully performing groundbreaking surgeries, including on toddlers. For instance, the correction of spinal deformities in a toddler marked the first time such a procedure had been carried out in Uzbekistan, underscoring the center's commitment to pushing the boundaries of medical innovation and improving the lives of its youngest patients. International collaboration and professional development. The center's reputation for excellence extended beyond national borders, attracting attention from leading experts and institutions worldwide. Through strategic partnerships and collaborations, the center facilitated the exchange of knowledge and expertise. This led to 32 specialists undergoing training programs in countries such as India, Russia, Italy, the USA, China, and Turkey, further enhancing their skills and contributing to the center's global network of collaboration. Infrastructure upgrades and enhanced facilities. To support its expanding scope of services and accommodate growing patient demand, the center underwent significant infrastructure upgrades in 2023. A modernized facility equipped with state-of-the-art medical technology was inaugurated, featuring advanced diagnostic and surgical equipment, specialized units, and a modern operating theater with laminar airflow systems. These investments not only enhance the quality of care provided to patients, but also position the center as a leader in the region, capable of delivering world-class healthcare services to the people of Uzbekistan. Looking ahead, a commitment to excellence. As Uzbekistan looks to the future, the Republican Center of Traumatology and Orthopedic Medicine stands poised to build upon its achievements and continue its mission of excellence in patient care, research, and education. With a dedicated team of healthcare professionals, state-of-the-art facilities, and a commitment to innovation, the center remains steadfast in its pursuit of improving the health and well-being of the Uzbek population.
Thank you. Let me invite next our Honorable Dr. Shadhaidar Shatursonov, Head of Vertebrology Department at the Republican Scientific and Practical Medical Center of Traumatology and Orthopedics of Uzbekistan, to give a welcoming speech.
Assalomu alaykum, hurmatli
Dear friends, dear participants of today's Congress, dear ladies and gentlemen. It's my pleasure to greet all of you, dear participants. And first of all, I would like to express my sincere gratitude to our close friend, to our teacher, Professor Lim. Once again, on the behalf of Uzbek spinal surgery domain, I would like to express my sincere gratitude for the great contribution to our vertebral surgery, to our country's development, to our patients' quality of life. Thanks to your kind assistance, vertebrology and vertebral surgery in Uzbekistan adopts new methods, introduce new methods, and our patients are getting high-skilled professional medical assistance. Upon your kind permission, I would like to express my sincere gratitude with today's state of the art spinal surgery and endoscopic surgery in Uzbekistan. If you will look through the surgery of spinal endoscopic surgery in Uzbekistan, as in other countries of CSC and former Soviet Union, we are involved in spinal surgery for a quite long time, but we have started this operation since 2010 after installing EasyGo systems. So we started with EasyGo in 2010. And we have conducted several surgeries together with Professor Sattarov, and you can see the results, that the results were quite nice, and they have been progressing at a steady pace. And in 2012, thanks to our friends from Ukraine, from Kharkov Center for Vertebral Pathology, and I'm actually the one who has graduated from this center, and academician Korsh was our the teacher actually, and other of our teachers helped us to work on spinal endoscopic surgery. And we have been invited to Uzmiss, International Society for Minimal Intervention Spinal Surgery. And thanks to recommendation of our friends from Ukraine, in 2012, Uzbekistan became the member of Uzmiss. And in 2012 in Zurich, in Switzerland, we had a meeting, annual meeting of Uzmiss, and we have invited the leadership of Uzmiss to Uzbekistan, and Professor Hansogul visited our country, leading the delegation, and we have started to develop spinal surgery in Uzbekistan, and we have been proactively taking part in all the Uzmiss conferences, including the one in Japan in 2014, in Indonesia, and we have been starting our cooperation with French, German colleagues, I mean spinal surgeons, and we have been proactively introducing the methods of minimal invasive spinal surgery procedures. You can see the Uzmiss directory, and we can see that at the moment we have the delegation from Turkey and our friends from Turkey, Mehmet Zeluli and others, Ali Fakhri Ozer. We have started cooperating with them and introducing state-of-the-art technologies of spinal endoscopic surgeries in Uzbekistan. And you can see that in Uzmiss, Turkey, we had the Professor Dastandol. We can see Professor Anthony Eng, who is the founder of spinal endoscopic surgery, and we have the Dr. Antonello also in this picture. And together with our spinal surgeons from Turkey, with our colleagues, we have been in close cooperation with them, and as a result, we have managed to develop a spinal surgery in Uzbekistan. Together with Professor Khuday Berdiev, we have been proactively taking part in conference in Turkey, and with the president of Uzmiss, Hansobol, we have been taking part in various conferences. We had a meeting with Swedish professors. So they have been training our Uzbek surgeons to conduct minimal invasive spinal surgery operations, and they have a lot of interesting materials on pathological anatomic incision, and our friends from Japan, Akiva Dezawa from Japan, who invited us to visit Uzmiss, Japan, and we have learned new technologies and new methods. And Professor Hijikata, who is the founder of Miss all across the world. And here you can see in Sapara, we have Professor John Choi from California University. We have professors from Germany, South Korea, Son Holi. In Japan, we had a very nice interaction with them, and our colleagues from Turkey, Professor Mehmet Zalali and Professor Hajan Nazarov. We have been practically taking part in Uzmiss, Turkey. And, we had indeed a breakthrough in development of spinal surgery in 2015, 2016, starting from our joint operation with our Korean friends, especially Professor Lim. And together with Professor Lim, by now, our friends, especially our young spinal surgeons, are getting trained by Dr. Lim in South Korea. And in 2015, we have started cooperation, and we have diplomas awarded by Dr. Lin. We are closely cooperating with China, and we are the partners in spinal surgery with China. We are showing you some pictures from the surgery table. And Uzbekistan at the moment, in terms of spinal endoscopic surgery, we are working based on the PCLD methodology of Dr. Lin. Why not PLD? What PSLD? We would like to tell you that this is the most efficient methods and the most, I would say, result-oriented methods, and it's widely accessible methods, in our opinion. At the moment in Uzbekistan, we have several companies which is the best with the best equipment is Arment, which are providing very good Olympus, Max Moore, Karl Stolz, Richard Wolf, and we are widely using the tools for surgery. Over 90% of operations are conducted based on the methods of Professor Lim, because our surgeons are trained under Professor Lim, and we do things that intralaminar access and stenosis, both in cervical, especially in cervical department, and also in thoracic department and in lumbar department, in our opinion, is the most efficient and fruitful. And from organizational point of view in Uzbekistan, we have managed to arrange spinal endoscopic surgeries in Republican Center of Traumatology and Orthopedics, and also in Profmed Service, a private medical clinic under the leadership of Umar Afrafshanbek, who is the organizer of today's conference, one of the leading organizers, I would say. And I would like to express my sincere gratitude to him. And he has organized a previous conference last year, and thanks to his efforts, we are conducting this Uzmiss conference and the spinal surgery operations annually in Uzbekistan under the chairmanship of Professor Lin. The same surgeries are conducted in M Clinic private hospital at the Jeksoft and the Shohmet Center, which are private medical clinics, and they are proactively introducing spinal endoscopic surgery methods in Uzbekistan. And in most of the provinces of Uzbekistan, would it would be Antijan under the leadership of Professor who I believe in Farhana province, and in Farhana province, I mean, they are having very nice conditions under the leadership of Dr. Umarov, and this is, by the way, is affiliate branch office of Prof Service clinics in Surkhandarya in the Now district, in Samarkand province, in Sirdarya, in Khwarezm province. In all of these provinces, I mean, out of 13 provinces, 10 provinces of Uzbekistan have already embarked on spinal endoscopic surgery. So you can see, according to the statistics which is showcased on the screen, in 2019, we have managed to conduct only 54 endoscopic surgeries in Uzbekistan. Majority of them had a transforaminal access, and in 2020 we had only 35 due to COVID limitations, and in 2021 we have managed to conduct around 300 surgeries in total, and in 2022 we have managed to skyrocket the number up to 2,000 of operations a year, and in 2023 the number doubled and reached 3,500 surgeries. So it's quite, high indicator when we are operating and discussing it with our colleagues, both would it be from Russia, EU, Indonesia, Russia, China. All of them say that it's quite a significant number, because to conduct endoscopic surgeries at such a high level and with such feasible results, all of them is only thanks to Professor Lim and his wonderful team, because he's training our young surgeons, and for them this is the mission of their life, to conduct such surgeries, endoscopic spinal surgeries, with such a high results. And I'm pretty sure that this year we will get much more operation surgeries done. And now we are at the early May, and we had already conducted over 2,000 of surgeries. Mostly we are focused on lumbar department, and also now we are developing endoscopic surgeries in the cervix department, also based on operations of Professor Lim, and on thoracic department, around 5% of surgeries are for thoracic department. We're talking about human resources, so potential at the moment. We are proactive, having around probably 30 surgeons who are proactively conducting surgeries in spinal endoscopic surgeries, and most of them are trained in Korea under the leadership of Dr. Lim, and we are planning to send our young specialists to Professor Lim to learn even more and to get a higher level of their professional excellence. Thank you so much for your kind attention. I will not take much of your time. I would like just simply tell you that, and availing myself of the opportunity, of course, we are planning to organize official at the government level the society of Miss in Uzbekistan under the leadership of Uzmiss Institute. You know that Uzmiss is under the aegis of SICO, and so Uzmiss and our country are planning to have this society to be organized, and it will enable our conference to reach even a brand new level from the quality point of view, to break through to the new levels of spinal surgeries, because you know that we have a quite high indicators on spinal surgery demand, and the treatment in the demand for minimal invasive treatment is quite also high, and the population of Uzbekistan totals 37 million people, and we have a quite high also indicators on spinal surgery demand. So we are planning to develop new methods. We are planning to introduce them in Uzbekistan, and I'm pretty sure that our conference will enable us to upgrade the level of spinal surgery in Uzbekistan. Once again, thank you so much for your kind attentions, and wishing
Thank
you
very much for
successes
that.
in all of
This
your
concludes
endeavors.
our opening ceremonies. Now, I'd like to finally thank for opening the program for our two-day program, Professor Lim, Professor Erismetov, and Professor Shotursunov. Let us start our conference. I am Dr. Ijam from the Philippines, and I am moderating the first session. The first part is a talk from our honorable speaker, Dr. Lim Kangtek. He covers the topic of precise strategies and techniques for successful endoscopic spine surgery. Dr. Lim.
Thank you. I will talk about how to perform the operation for successful endoscopic spine surgery with the strategy and the technology. We are all the home endoscope because you are very like the endoscope. It's my new hospital. If you have a chance, please visit my hospital again. So we have so many cases in Korea and my fellowship. So back to the basic, I think that the endoscope surgery main purpose is could be the decompression, not the fusion surgery. So we could decompress to avoid the big open the fusion surgery. So we can, and then I think we need to change the terminology because not internal lamina, because interlaminar means just the small, the old endoscope instrument, just without any the bone work. We can do it just we call the discectomy in case of L5S1 disc. That's why we need to change the terminology, not interlaminar, the posterior approach, and the foraminal approach. So we have to change to the paraspinal because landing point is different. In case of a narrow space of foraminal space, foraminal stenosis, there is no convergence triangle. So we need to create the space for the decompression. That's why we need to change the terminology first. It's very important. You know very well about this. The dermatome is first the correlation between dermatome and the lateral finding is very important. Right? As the beginner, as when I was beginner, also my mistake. So patient visited with my hospital with the weakness. So MRI shows L4-5 of the stenosis, right? But there is no any evidence to the patient have the weakness. So I performed the bilateral decompression with endoscope, but the post-operative no any improvement. Why? It's my mistake, my misdiagnosis. The main problem was a thoracic lesion. It's calcified, the ligament flavum compressed the spinal cord. That's why I have to perform the endoscope decompression again. So it's very important to the correlation between the MRI and the symptom is very important. It's my mistake when I was a beginner, right? And sometimes the patient will have like this fuse the transverse process to the iliac crest. It's a Bartolotti syndrome. Patient have the L4-5, the stenosis symptom was L5 dermatome pain. The problem is not only the L4-5 and also the foraminal stenosis. It's a double correction syndrome. In case of L5 dermatome pain, we need to check Bartolotti syndrome. So many cases of the very common, the foraminal L5 foraminal stenosis is right, Bartolotti. And so what do you think about is the small disc? Some doctor will perform the transforaminal PLD, doctor trying to only remove this disc, but the problem was the stenosis. The before operation, I recommend you should check the CT scan to know the disc is calcified or not. So it's calcified, the disc. That's why we don't need to remove this one. Only the bilateral decompression like this. You know. So we can do the multiple level with one skin port in endoscope surgery, jumping technique in lumbar and sliding technique for multiple level in cervical level. I'll talk about this. So as told, the landing point is not interlaminar space, so the lamina, and then first after the reach to the uppermost ligand flavum, we have to remove the ligand flavum as a piecemeal resection. Some doctor trying to remove the envelope like a butterfly. It will make the big mistake. Sometimes it will happen the big damage of a facet joint, or during the removal of the envelope, the ligand flavum, it will happen dry injury, because in case of a severe stenosis, there is a adhesion, severe adhesion between dura and ligand flavum. That's why I recommend first the ligand flavum from the cranial part as a piecemeal resection. Like this, uppermost ligand flavum, and you can remove this, and the contralateral side also. And in case of this patient, the upward migration disc, right? But the patient have a tropism, the body is the left side of tropism. So that's why if you want to remove try to the left ipsilateral approach, it will happen damage the facet joint. That's why, right? And then facet joint direction is like the vertical direction. So if you want to try to the approach left side, it will happen damage the facet joint. That's why my operation strategy is contralateral side approach like this. Post-operative, no any damage of facet joint. It's one of a strategy. So if you want to learn more, please visit the hospital. And it's the cervical region, right? The patient have the tropism, the left side. So symptom is left side. Do you want the left side approach? No, it's a wide space right side. So I recommend the right side approach. Right? It's one of the strategy, the post-operative. And the paraspinal approach. The first time I told you that we need to change the terminology. Why? First, most of the spine doctor trying to the landing point has to the first SAP, but SAP is one of the facet joint. That's why we need to preserve as much as we can. First, the landing point is a transverse process, and then we need to find the root first, and then pars decompression, and then annulus. And then SAP resection should be as much as we can to preserve a facet joint. It's quite different between the foraminal approach. That's why we need to change the terminology, not foraminal approach, then with the paraspinal approach. And about the water, the pressure, we use the water pressure from the 40 millimeter mercury to the 80 millimeter mercury. There is no any brain problem during the operations. So, okay. And it's my endoscope. So the 2016, the Maximum the spine the company expected my idea we could release this new endoscope system. With this endoscope, we could any operation, cervical, lumbar, anterior, posterior, and fusion surgery. I will talk about this. It's very the optimized system, optimized size. So length is 113, and has the durability, short endoscope, and the sealed the gap between the lens, the body with the gold, so will guarantee the durability. So we can use the 1, 2, 3, 4, 5 of the millimeter calcium punch. And the small, the 8 millimeter out-diameter endoscope, we can use in even narrow the space of the lamina. Except from the stenosis patient has the like a hypertrophic facet joint, right? The small endoscope, 8 millimeter, is more useful for this patient to reach to contralateral side also. So with the endoscope, we can do posterior decompression, transforaminal or the paraspinal approach, and especially now most of the patients suffer from the back pain has the hernial disc and the stenosis, both, not only disc, because we are becoming aging society. So we need to solve this problem though. At the same time, not only discectomy and foraminal decompression. And the lumbar, with this endoscope, we can do fusion surgery. And we can use this endoscope for the cervical lesion, posterior decompression for the cervical paracentral disc remove, and the foraminal stenosis, foraminotomy, and the spinal canal stenosis. And we can do endoscope HDF. Okay? So now we are here in the central disc and for myelopathy. And we can apply this endoscope for the high cervical lesion, C1 lesion also. Okay. And I think this endoscope surgery looks like a video game to find the enemy, the target point, without any damage of the normal anatomical structures. So in narrow spaces. But we know how to decompress the narrow the spaces with endoscope. So this the patient have L4-5 stenosis as a grade 1 stenosis, but stable. That's why most of the patient, most of the doctor trying to recommend fusion surgery. But the patient have a stenosis, not back pain, only leg pain. That's why we can do first decompression, like this. How was the CT scan, pre and post operative? No damage of facet joint. We can preserve facet joint. That's why post operative 1 year, no instability more, stable. So it's very important because we can preserve facet joint and the posterior ligament complex is very important to maintain stability, like the main cable in suspended bridge. And one of the advantages of endoscope, uniportal endoscope surgery is after skin incision, just 30 seconds, we can do laminectomy because any muscle manipulation required. So we have to preserve muscle and the facet joint, posterior ligament complex. That's why my operation time for lumbar bilateral decompression is 20 minutes. For cervical posterior decompression, 30 minutes is enough. That's why we can do 3 level in 1 hour. And then next day, patient can go home. And we use the two-hand surgery with 2 fingers, right? Very stable. So during the cervical operation, it's stable. Happen no damage of the spinal cord. Two-hand surgery, the uniportal endoscope surgery, right? And the high-speed drill, I recommend that. Oh, no sound. Excuse me, no sound. Okay. Yes, I use the NSK. Yeah. Yes, okay. Thank you. High-speed drill. And in case the pre and post operative, 1 level pre and post operative. In narrow space, we can do bilateral decompression. Post operative CT scan shows no any damage of a facet joint. Right? And the 2 level pre and post operative. 2 level with 1 skin port. Right? And sometimes a contralateral approach for the foraminal decompression. And the 3 level, right? Pre and post operative axial view and sagittal view with 1 skin port. one skin port, we can do 3 level. How to? First, the middle L4-5 and the 5S jumping technique, and then L3-4. With one skin port, we can do 3 level. Bilateral decompression. It's a 1 hour operation. And 4+2 operation. First, the patient have a 4-level central stenosis and 2-level the foraminal stenosis. It's 4-level with one skin port we can do like this. 2-level, one skin port we can do foraminal stenosis, decompression. So just the 2 skin port is required with endoscope. Right? Patient have a 6 drainage, but patient can go the next day. Surprise! It's the role of the endoscope surgery now. Right? It's my paper about multiple level jumping technique, Lumba. Okay, and the fusion surgery we can do the unstable spine. We can do endoscopic fusion. So we can do the bilateral facetectomy, and with so after bilateral facetectomy we can do create the lumbar lordosis, and the surgical reduction is very nice. But like this, small skin scar 1 month later. But there is no any damage of a posterior ligament complex, just a skin port, right? But I think there is a scary moment always as beginner. Sometimes dura tear. So we can use the Tacosil cylinder, fiber cylinder patch. I recommend use this. So many cases in my operation, the dura tear during the operation. But I never tried to open the repair the dura. So you can use a Tacosil. It's my paper about how to use a Tacosil in case of the dura tear. Okay, so then you can do in case of the bone bleeding. So you can use the compression cancellous bone using the calcium punch compressed. You can stop the bleeding. And then, so sometimes you can, it's a contralateral side space. To see the more detail, you can try to the duroplasty, shrinkage dura, and then you can see more contralateral side anatomical structures. And the cervical, so you can do the one level posterior decompression, and the 3 level, how to. So we have been doing the big laminoplasty for cervical, the multiple level, right? But we can do endoscope surgery. It's like this. One skin port is a sliding technique, pre and post-operative, and axial view is post-operative, like this. How to? The first, middle, and then it's the surgical site, each level is very close to each other. That's what we can do, use the sliding technique. So it's a sliding technique, right? With one skin port, we can do 3 level. We don't need to perform any big open surgery like a laminoplasty. As a video, it's a 3-4 and spinal canal decompression. 4-5, 5-6, right? You can do 3 level spinal cord decompression with one skin port. It's a low robot endoscope surgery now in Korea. You can do it. Try. And the 4 level pre and post operative. The same, with one skin port with the sliding technique. So you know very well the Nicola Paganini, right? He created the wonderful music. How to made the multiple new technology like a double, triple, double stuff like this. Or to make a new endoscopy operation, we require new technology. Right? It's one of the jumping or sliding technique. Or the like the physical technique. So with that new technology, you can do it. So in this group, you can find the good technology for the cervical region multiple level. Okay, pre and post-operative. And the post-operative 1 year, there is no any the kyphotic change because there is no any the posterior ligament complex damage. Right? How was the big operation like the laminoplasty? 1 year, 2 years later, you can see kyphotic change. Right? But endoscope surgery multiple level, no kyphotic change because you can preserve posterior ligament complex. It's the laminoplasty for multiple level. Right? You can avoid this big operation with endoscope surgery. It's a very important cervical muscle to the motion stability. Endoscope surgery, you need to put just a small damage of a muscle, but the open surgery, we have to sacrifice to big muscle, posterior ligament complex. That's why the possible 1 or 2 years later, you can see the kyphotic change. And the myelopathy is a bit the calcified disc, CT scan. So how to, my plan is resection of this calcified lesion with endoscope. We can do it. Post-operative MRI, CT scan shows quite enough decompression, pre and post-operative, and with a small skin scar endoscope. How to, first we can insert the needle in disc space, and then serial dilator, and then endoscope system we can do. So, and the endoscope we can do anterior approach HDF and the spinal cord posterior decompression. Everything we can do. Everything. So this male patient have a 34 posterior calcified ligament flavum and anterior disc myelopathy. The first we can do posterior decompression first, posterior decompression, and then we can do anterior HDF at the same time. The preoperative actual the AP distance is less than 5 millimeters, but postoperative like this 15. First the posterior decompression, and then anterior HDF at the same time. You can do endoscope, only endoscope. So that's why my plan is we'll organize an international endoscopic cervical surgery society. We can do the useful the endoscope surgery for cervical lesion. So please join us. I will organize this the new society. And next month June, I'm going to Spain for the CATA workshop there. I will introduce endoscope surgery in Europe, and October we'll organize the endoscope surgery conference in New York with Dr. Data and Professor Kim. So please join us. It will be a good chance to learn the endoscope surgery and with the exchange, academic exchange. Please join us. The conclusion, the endoscope surgery system will provide good visualization, and we can preserve a facet joint and the posterior ligament complex. And we can do multiple level, multi-pathology with one skin port. That's why we can avoid the big open surgery. And the infection rate is very less because we use a lot of the water during the operation. Now, endoscope surgery, spine surgery is the must, not an option in spine field. That's why you should learn, especially young surgeon. If you do not endoscope surgery, it's very difficult to survive as a spine surgeon in the near future. That's why you should learn endoscope surgery. Okay, thank you so much. It's first time learning the endoscope surgery have a still learning curve, but you should overcome. Always in our life, difficulties are just a process that must be overcome in our life. So I will help you. I will teach you everything. So we can meet each other again, and next year in Tashkent, and share the information is very important. Please visit my hospital, and Accor also. It's so many cases. You can learn the endoscope surgery in Tashkent, and Shomansro also, Kandimop also. And they can do everything. Thank you so much.
Thank you very much, Professor Lim. I am pleased to invite our second speaker, Dr. Sukhdev Datta from USA, to talk about two-level uniportal discectomy with foraminotomy, the USA experience with follow-up.
So thank you so much for the invitation, and thank you so much, Dr. Lim, for inviting me to be here. I want to just share my experiences and some of the challenges that I faced learning endoscopic surgery and implementing it in the US. Like Dr. Lim said, I had visited him last year, and it ended up being a big experience for me. He kind of encouraged me to actually try to popularize this in the US, and we were very successful in doing a workshop with Dr. Lim and Dr. Kim last year. I'd like to invite everyone to come to the meeting this year in October 25-26. I'll give the information at the end of the talk. So I decided I was going to talk about my experience with multi-level uniportal foraminotomy, and it's my single surgeon experience. These are some of my disclaimers. I have my own private practice in New York, and I also formed a nonprofit which is called the American Society for Endoscopic and Minimally Invasive Spine Surgery. We'll be holding conferences every year, and the idea is also to teach endoscopic spine surgery, especially in USA and the North American region. So just to give a little perspective on my travel and my experience in the endoscopic world, initially it was very challenging to do endoscopic spine surgery in the USA, specifically as everything in the USA is regulated by insurance and by coding issues, and there was as such no coding for endoscopic spine surgery, so it was very difficult to initially do it. I also had a lot of trouble because the endoscopic surgery itself was not popular in the US. I had to go outside to kind of get the experience. So initially I traveled to a lot of places, including 10 years ago I worked with Dr. Lim in Korea. So I visited Korea multiple times. I visited Germany. Following this, I also had to be credentialed in facilities in the US so that I could do the procedure myself. And then obviously there were also some issues in terms of getting credentialing and how do you become a champion then? So the idea behind becoming a champion is to kind of follow through on the road and try to do as many cases as you can, go to conferences, learn from your peers. So that's what I did. And now I have tried to actually teach my peers. I have started doing workshops for pain physicians and also other interested spine specialties. Hopefully that will lead to this becoming more popular in the United States. So my case series, I've done multiple cases at different levels, and total unique cases that I've done is 365 cases. There's a little bit more male population than female population, 208 males and 157 females. Different levels, I have focused mainly on the lumbar spine. I have one thoracic case that I did, but most of them were in the lumbar spine. In terms of single level cases, most of the cases were at L5S1 or L4, L5. In terms of multi-level foraminotomy, My commonest two-level foraminotomy levels were L4, L5, and L4, L5, L5S1. As you can see, there were 91 cases of L4, L5, and L5S1 that was done. Most of these L4, L5, and L5S1 cases were done transforaminally. There were some where interlaminar work was done, but it was not the stenoscopic surgery. It was primarily interlaminar discectomy followed by single level foraminotomy at the level above, and sometimes at the same level, depending on where the pathology was. So in terms of the case series, I have the longest follow-up is around 10 years. There were some complications. One of the complications that was identified was a dural tear during the surgery that was repaired. The cause of the dural tear was a large extruded disc at the L5S1 level on the left side. This tear was identified during the surgery. We don't have the things that Dr. Lim showed. We use SurgiFlow to kind of close the tear. Unfortunately, the patient needed to have a second surgery with a second physician later on. There was one case of a headache that needed a blood patch. After the blood patch, the patient had an uneventful outcome. In the 365 cases that I've treated, there were 4 cases that went on to get fusions. 2 were done endoscopically, and 2 were done with a transforaminal route. One patient had left leg weakness that developed. This left leg weakness developed, this patient was a redo surgery. The patient had a first 2-level discectomy before and subsequently ended up re-injuring herself and needed a second discectomy. During the second discectomy, there was a lot of fibrosis identified. The radiofrequency was used at a higher level because of the scar tissue identified, and that left to left leg weakness, which persisted for almost 4 months, and after that the patient recovered. So mostly in my series of multi-level foraminotomies, there was good outcomes. Majority needed no further surgery, just the discectomy and the foraminotomy was enough. Mean follow-up period, like I mentioned, was from 1 year to 10 years. So these are some of the cases that I did. This was a 59-year-old male with 3 levels of disc herniation, severe foraminal stenosis, kind of shows the technique that I use. This is a transforaminal technique which goes over the needle placement initially, followed by use of trifines. So I basically show how I'm using this to do the foraminotomy with the use of trifines. This is another one which is pretty severe foraminal stenosis using a foraminotomy using the trifines at the L5S1 level. And this is just showing the drill being used for a foraminal decompression through the transforaminal approach. And this is another one where there is multi-level stenosis, and this was a 3-level surgery that I did. Here, again, it's a transforaminal approach, and basically the first level is kind of decompressing the disc. The second level is trying to open up the foramen as much as you can with the drill. And here it shows the discectomy part, followed by using the drill. And much more clearance after the use of the drill. And finally, visualization of the nerve root. And obviously these decompression, you need proper size Kerrison punches. Unfortunately, in the US, this has been a major impediment. I am the availability of just one size Kerrison punch. I'm hoping after this conference I'll be able to obtain the right-sided punches. This shows decompression at the end of the surgery, quick video. So finally, just want to invite everyone to what's going to be the second meeting in New York. This website should be good for registration probably by next week. I hope to see everyone there. Thank you so much.
Thank you, Dr. Datta. Our next speaker is Dr. Dun Hong Yang from South Korea, and he covers cardinal tips and tricks for easier full endoscopic lumbar interlaminar approach.
Thank you, Chairman. Great to see you here far from my country, and everyone came from many other places. So, lovely conference and great work here. So today I want to present about adding cardinal steps for optimal laminectomy and how to make a maximal structural preservation. And this is my career. I cannot use. I worked several years in foreign countries in West Africa and also in Southeast Asia. Thanks to the great dedication of some pioneer of endoscopy, now we are in the next generation endoscopic eras. But still we got some concern, how to get a better popularity, how to lessen the burden of the learning curve. So that's why we need a step-by-step, peculiar, and endoscopy-specific guidance is needed to provide better information to beginners. I got 3 topics to share: unique features of full endoscopic approach, achieving optimal laminectomy, and preventing lateral location and facet violation. First, unique features. 2-plane concept. The operation monitor displays 2 planes of the operation field. The first was a fixed plane. That is surgical anatomy of the patient. The location, orientation do not change with the turning and rotation of endoscopy. And second plane is moving plane. That is endoscopic frame itself. It is a relative field of endoscopy. So location, direction, and the viewing angle are changed by your manipulation. So instead of tracking endoscopic moving plane, just follow a fixed plane to get better anatomical orientation in the field. So you must remember you're watching a part of an entire fixed plane. Just try to imagine the whole anatomical structures, even though they may not come in your sight. Second feature is eccentric working view. So it's better to get some laser pointer here. I cannot find the pointer. Okay, look at the picture. In the picture, optic channel is below and the working channel is above. And the optic channel has an angle, optic angle. So it is a slight angle through the working channel. And the the instrument from the working channel goes straight to the target. So in the center of optic site and the instrument will meet in a certain distance. That will be a most comfortable working distance and working space. Endoscopic maneuver. The spine endoscopy has a mobility offering great freedom in approaching to the target. The two unique features are rotation and sliding. The rotation, this is needed to overcome the eccentric endoscopic view. Look at this video. I am trying to advance on root retractor to make a view to the target. But because of the eccentric working view, the view is blocked. But by the rotation, we can see the target. And another rotation, we can see the target in different angle. This is the magic of rotation. So continuous rotation of endoscope is essential to avoid the blockage and maintain an adequate route to the target. Second maneuver, the sliding. This is needed to maximize the movability of the endoscopy. Endoscopy is not fixed, can go down and up, can go down and up. It is great freedom, and sometimes go back and forth. The endoscope can provide great accessibility and freedom to the target. And second topic is achieving optimal laminectomy. We need to focus on endoscopy-specific anatomy, not general anatomy. So, for the facet angles, facet width, facet hypertrophy, and joint laxity will be important. And for the lamina angle, interlaminar space length, and groove lamina is also important. And the width of lateral recess and shape of spinous process are also important. I like three-dimensional CT images. It is very useful to imagine whole anatomical structure before operation. This is a modified endoscopic anatomical landmark for laminectomy. For the cranial, I recommend the thinning point of ligament flavum instead of end point. And for caudal, this is very standard description. The top margin of lower lamina and the point of inner layer of ligament flavum, this will be very standard. And for medial, I don't recommend ipsilateral spinolaminar junction. That is once a very popular landmark. Instead of that, I recommend the central gap between both sides of ligament flavum, midpoint of spinous process, and sometimes contralateral spinolaminar junction. For the lateral landmark, facet joint is also not reliable. I recommend lateral recess junction. A major confusion and doubt during the drilling of lamina is estimating the shape of facet joint and predicting lateral extension of laminectomy. So I told that the outer margin of the ipsilateral spinolaminar junction is not constant and reliable landmark because it changed too much because of patient anatomy. And the facet joint is also not a reliable landmark. That's why I recommend the lateral recess junction and the width of lateral recess. Lateral recess junction. This is a junction between lateral margin of lower lamina and the beginning point of the lateral recess. And after this landmark, the lateral margin of facet joint is located and is a very common point for laminectomy for traversing route. When the lateral recess junction is uncurved, you have reached a milestone. So at this point, you can get confidence in navigating endoscope and how much you go further to get the lateral margin. And second is width of lateral recess. This is a distance between lateral recess junction to the medial pedicle margin. It is generally accepted as a safe area for the medial facetectomy, but the extent is different from patient to patient, different from the anatomy. Sometimes it is short, and sometimes it is long. In a short with lateral recess, after removing some ligament phlebum outer layer and exposing the raw lamina, unearthing a lateral recess junction is enough to locate the traversing root. Further lateral recess junction removal will be not necessary. So, after removal of ligament phlebum, we can get to the lateral dural margin without any more bone removal. So, facet joint can be preserved totally without any damage. In a cases of long with lateral recess, a certain degree of lateral recess cutting will be necessary to get the lateral dural margin. After drilling of the bone, after locating the lateral recess junction, I am removing and cutting the sum of bone to approach to the lateral dural margin. We can see some pad layer in the lateral dural margin. So approach can be done with very safely. So by locating the lateral recess junction first, the excessive medial facetectomy can be avoided. When you compare with direct drilling the medial facet from the facet joint capsule. The last topic is avoiding lateral landing of endoscope. Yes, sometimes endoscope is too big because endoscopic diameter is fixed, but patient anatomy is not. So in a steep angle, the small unstable lamina, they got smaller tolerance for laminectomy and medial facetectomy. And in hypertrophied lateral protuberance of spinous process will inhibit adequate lamina exposure. In such cases, we need a medial skin incision and the endoscope landing. But the big obstacle is hypertrophied lateral protuberance of spinous process. Look at this picture. The ideal endoscope landing will be a blue circle, but because of hypertrophy, the lateral protuberance, actual landing will be in red circle. In these cases, excessive facet violation is inevitable. But by flattening the lateral protuberance of spinous process, optimal medial location of endoscope is possible without any damages. We know that this is not a new technique. This is a very common technique in microscope discectomy, but become forgotten in endoscopy. Look at this picture. In the left side, this is a before flattening. In the endoscopic view, the part of facet joint is visible. And after flattening, facet joint is not visible anymore, so safe laminectomy is possible. So, this video, this is before the flattening. We can see the facet joint in the endoscope field, and withdraw the endoscopic tube and find the spinous process, drilling and cutting. And after that, advance the endoscope again. Now we can see, we don't see any facet joint. So we can do the laminectomy safely without any damaging facet joint. To summarize, remember two plane concept. Rotation and the sliding maneuvers are privileges of full endoscopy. Try to utilize a modified landmark for optimal laminectomy and identify lateral recess junction before medial facetectomy. And flattening the spinous process is a key for avoiding lateral bending. Thank you for listening.
Thank you very much, Dr. Young. Our next speaker is Dr. Hikmet Ulug from Turkey. He speaks about step-by-step full endoscopic transforaminal approach. Let's all welcome Dr. Hikmet Ulug.
Hayırlı Tonk, good morning. It is great honor for me to be here, and I thank all members of organizing committee for this kind invitation. Today I will talk about the very basic rules of the transforaminal endoscopic surgery. Following my approximately 15 years experience, first and most important stage is needle placement. It is very important stage. So, we can place needle anywhere in the foramen. But most important thing that the needle tip should always touch the dorsal annulus. This is the basic of the transforaminal surgery. This is my operation. Generally, I am beginning with local anesthesia. And then needle placement. Please do not try to reach to the target in the first attempt. This is very important rule. And I am going on and look at this. In epigraphy is okay, but in lateral graphy, the needle tip is outside the foramen. At that time, sorry, this is AP and this is lateral graphy, and necessary adjustment should be vertical. After that, more vertical entry now, and result, epigraphy is okay, but in lateral, we are inside the disc space. AP and lateral. And in this situation, necessary adjustment should be horizontal. Why? Because we are here. We have to do this type horizontal approach. And last approach, now, look at this. Everything is okay. In epigraphy, in epigraphy, and this is a correct position because we are here. Just needle tip is touching only annulus, and our target is medial pedicule line. Needle tip in epigraphy is on the medial pedicule line. Next step is discography. Next step is discography. Discography is not mandatory, but I am choosing to do discography because you can differentiate degenerated nucleus pulposus from the normal tissue. This is discography. First, the needle is inserted into the disc space, and then we are using indigo, carmine, gadolinium, and serum physiologic mixture. 2 and 3 cc is sufficient. Following discectomy, next step is guiding rod placement. First, guide wire is inserted, and then the needle is pulled out, and the guiding rod placement. And let's go to the operation. Guide wire is inserted into the disc space. And I am doing skin incision in this stage. And then the needle is pulled out, and the guiding rod pushed in with twisting motions. This is also important. And when necessary, guiding rod can be hammered inside the disc space. If it is my application that if my target is medial pedicule line, I am a little bit going to beyond of the medial pedicule line, because when I put the cannula, the guiding rod is coming back. That's the reason. Next step is cannula placement. Open end should face ventrally until it reaches the foramen. After that, cannula is rotated dorsally and pushed into the foramen. This method prevents exiting nerve injury. And now, open end should face ventrally until it reaches the foramen, and then rotate dorsally rotation and pushed into the foramen. This method prevents exiting nerve injury. This is very important trick in my opinion, and during the operation. After that, I am on the target. Our target is medial pedicule line. And last stage is placement of the endoscope and operation. And surgical tools, of course, and we are beginning the operation. So, placement of the endoscope again. If your needle placement is correct, when you place the endoscope, you can see needle hole. Also, upper half will be foramen and lower half will be disc space. This is correct needle and cannula placement. Now, question is, how should we choose the entry angle and entry point? Answer is depending on the location of the herniation. But before that, we have to know something about endoscope. Generally, our endoscopes has field of view changing between 70 and 90 degrees. So, field of view and manipulable area is different. What it means? We can see whole area, but we can manipulate only this area. For this reason, our entry angle and of course the needle placement is very, very, very important for transforaminal approach. So, if we use entry angle greater than 30 degrees, only the nucleus pulposus can be removed. You cannot reach the dorsal epidural area or dorsal annular area. To reach the dorsal annular area or epidural area, we have to use entry angle more horizontal, between 0 to 30 degrees. Also, of course, we can do some levering movements to increase our horizontality. So, if there is non-migrated intracanal herniation or pure foraminal herniation, we have to use horizontal approach. As horizontal as possible, we have to use horizontal approach. A short example, left paramedian and central also disc herniation. And our plan is forming based on the retroperitoneum. In this case, our target is medial pedicule line. Retroperitoneum allows us only 24-degree entry angle and far away from the midline, 17 centimeter far away from the midline. This is our needle entry point. And needle placement according to our preoperative plan and our cannula placement and operation. Look at this. Firstly, we are removing the only nucleus pulposus, herniated nucleus pulposus, but the compression is going on because there is hard tissue, hard annular PLL complex. At that time, removal of the nucleus pulposus is not sufficient. We have to cut this hard tissue for decompression. And look at this, we can explore until midline from the ventral side, whole neural tissue. The basic trick is exact horizontal approach. And postoperative image, you can see that there is sufficient compression until midline. And if we apply these rules, also we can operate cases like this. This is recurrent herniation following microdiscectomy. We can operate this pathology using the virgin anatomical area. And if there is extraforaminal herniation, some change can happen in and around the exiting nerve. But most important change is displacement of the exiting nerve. This is very important. Exiting nerve can be pushed in cranial, dorsal or lateral directions or any combination of these. If we use entry angle less than 30 degrees, there is risk of the exiting nerve injury. For this reason, particularly if there is dorsal displacement of the exiting nerve, we have to use entry angle greater than 30 degrees. Most steep approach. So, look at this. This is extraforaminal herniation. There is displacement of the exiting nerve root. At that time, our target is mid-pedicular line, and this is our preoperative planning. Look at this, 47 degree entry angle and 7 centimeters. And according to this, our needle placement, mid-pedicular line, and our cannula placement. And the operation, this is exiting nerve. I am removing something. At that time, after that, we can see ganglion, circumneural sheath, whole exiting nerve, but still there is a herniation, and we can retract the exiting nerve doing the rotating movement of the cannula. At that time, we can remove, and we can see whole normal anatomical structures. And pre- and post-operative image. Okay. If we apply this rule for extraforaminal herniation, also we can operate cases like this. There is double crash over L4 nerve root, L3 for paramedian, L4-5 extraforaminal herniation. In same session, in same incision, we can operate this. And this is postoperative image. Okay, if there is migrated herniation in last issue, if there is migrated herniation, 3D imagination is very, very important preoperatively. During the operation, we are using X-ray for navigation. For this reason, we have to transfer to MRI image to the AP X-ray image, because we are doing this type of movements during the operation. Surgeon should imaginate the 3D should make 3D imagination in his mind. This is very important. So, for this case, this is needle placement, again cannula placement, and the operation. Look at this. I am doing navigation. Herniation is here. And then I am finding the sequestrated herniation tissue, again navigation, and I am removing it. And at the end of the operation, we can see that L4 corpus surface and L4 exiting nerve root. And this is postoperative image, again postoperatively. And if we apply this rule, also we can operate huge migrated herniations like this, and postoperative axial and postoperative sagittal and coronal sections. And look at this 5 centimeters piece. As a conclusion, good MRI and preoperative planning based on MRI is essential. Particularly take time to place the needle. During the operation, every surgeon should try to make the correct position based off the transforaminal surgery. Do not coagulate, cut, push, or pull any unrecognized tissue. And get an early postoperative MRI and watch on surgery videos. Thanks for your interest.
Thank you, Dr. Hikmet. Our next speaker is Dr. Bong-Soo Kim from USA. He covers the topic nuance of percutaneous pedicle screw fixation in the USA.
Thanks to organized committee and chairman, Dr. Lim. It's a great my honor to be here in beautiful country in Uzbekistan. Yesterday dinner was great. It's very delicious food. I enjoyed. I'll be coming out soon. Okay. So I'm a neurosurgeon. I'm one of the spine surgeons in the Temple University, Philadelphia. I met Dr. Lim 10 years ago in Indian meeting. Since then, we are a good friend. Today, I'm going to talking about needle changing gear. So far, we just discussed the endoscope. Yeah, endoscope for decompressions. Now, if you need a fusion, you need some technique placing percutaneous screws. Why we care about the percutaneous screws? Minimally invasive surgery is less tissue trauma, right? If you look at the pictures, you can do tubular retract and endoscope with one incision. You can do 2 levels very easily, up to 3 levels. If you're obese patients, much easier to do 3 levels. Using tubular retractor and endoscope, you can do minimally invasive surgery, right? If we do damage less tissue, less blood loss, and obviously less post-operative pain, and it facilitates faster recovery and mobilizations. What are the principles? Feasibility. Its anatomy is feasible to MIS fusions, and the locations, right? How we precisely localized where we put the instrument. The most important thing is good X-ray imaging during the case. Right? Another one is surgeon should be properly trained. That's why you can place the proper instrumentations. So before we do surgery, always we have to prepare well, right? Make a plan A and plan B, something happen, right? So first step is properly evaluate preoperative MRI and CT scan. Each patient has a different anatomy variations, so you have to properly understand anatomy of patient and properly choose implant size. When you do multi-level fusion, particularly trauma patients, whether you can use multi-level step incision or single linear midline incisions. In order to understand the anatomy, most important anatomy is a pedicle. The pedicle is a strong cortical cell, that's a very strong bone, right? And inside the cancerous bone. So that's why you need a proper size of screws. If the larger is better for pull-out strength. Pedicle size vary significantly patient by patient and throughout the spinal column, right? In general, transverse width is smaller, less than pedicle height. So if you look at just CT, without CT scan to X-ray, you place the instrumentations, there's a good chance you can make a mistake size-wise. In general, this is when I teach my residents what's the angulation of each spine. L1 is a little less angle medialization. In general, there's a 5-degree increment as it descent caudally to sacrum. So this is usually I give my resident approximate angulations. So how we choose the length? 100% length in the bicortical is very strong plus strength. However, if you do bicortical, there is a chance you can get a vascular injury, right? This is a devastating. Patient can die from this injury. So you need to properly, properly decide what length of screws. I usually properly 80 to 90% screws, close to cortical, but not bicortical. 80% is a very strong length of screws. When you do MIS fusion, most important thing is good X-ray. Right? I call it true AP view. Plate superior to plate, and then pedicle should be contacting end plate, and then sprint process is a center between the pedicle. I prefer to rotate the patient, not rotate the X-ray. That's why you can get the good orientations. Another one could be used through lateral view. End plate is flat. Right, posterior cortical, the line is a single line. Also, pedicle should be superimposed only one, not double, right? This is a true lateral view. You can get the proper instrumentations. Another view you have to learn how to do is a beam, pedicle view, in-face view. You rotate a periscope. Beam is the line of a pedicle axis. You can see the medical border of the SAP along with the medial border of pedicle. That is a good X-ray angle. So when you do step incisions, where you put the skin incision, in general, 1.5 to 2.5 centimeters lateral to lateral marginal pedicle, depends on patient size, right? And also depends on what level you're doing. If a low level, like L5, you need more lateral than L2 level. Right? Also, more obese patients, more lateral step skin incisions. This is when you do open surgery, there's two techniques in general, right? The Weinstein technique is more lateral, like a facet joint and transverse process junction, that's the entry point. And Roy Camille is more medial. You can use more both technique when you do MIS technique. If it's a large pedicle, you can use a Weinstein technique. A small pedicle, you can use a Roy Camille technique. That's why before you start the MIS technique, you need to know how to do open surgery. That's a better way to decrease the complications. First step will be place the GEM-CD needle. In general, the entry point, left side is 9 o'clock and right side 3 o'clock. When you start, a small gentle tapping, about 2 or 3 millimeters, penetrate the cortical bone. Look at the X-rays, the left side of the X-ray. So the first time when you see the after penetrating, you will see that kind of the X-ray with the GEM-CD needle through AP view. And then you need to advance the GEM-CD needle, right? If you do lateral view, it should be GEM-CD needle parallel to pedicle and parallel to end plate. That is a proper placement. When you put the advanced, the AP view, your tip of GEM-CD needle should not be close to the medial border of the pedicle. So usually my recommendation, this is my technique, how I do, 50% to the 3/4 distance from lateral to medial across the pedicle. That is not touching, not damaging pedicles, right? Sometimes you cannot get the proper location of a trapeze, then use some other GEM-CD needle. You get the tip of a GEM-CD needle, the red ring, right? The right one is usually uses center pointed. However, when you want to change some angle or needle the distance, you can use the beveled one. You can more driven more further. So once you put the pedicle with the GEM-CD needle, you have to put the KY, right? KY placed through the GEM-CD needle. I prefer using tapping, just using a clamp and then a hammer, so 1 centimeter each time to prevent any complications. And lateral view, KY should be midpoint of a vertebral body in order to make any mistake and complications. Then we place screws, right? Take it out, the GEM-CD needle out. That time, there's a chance the KY come out together, so you have to very carefully take it out. And then place the dilator and putting tap. We prefer to stimulate screws, okay, less than 8 milliampere is safe. Then we screws over the KY. X-ray guide, of course, right? Even normal anatomy or a young person, yes, usually we don't have any problem. However, we get the trouble. When I teach my residents, you have learned the principle, then it's always troubleshooting. Every single case, you have to change, so modify your techniques. Hypertrophy joint, yes, very difficult to do. However, you can overcome easily. However, a skeletal bone is really difficult to place the KY on screws. This kind of situations, even the KY is difficult to place with the tapping technique. So I prefer using sharp KY or thread KY using motorized drill. again, thread going into the bone easily. Same thing is very carefully, the 1 centimeter each time. When you look at the video, after I done, my resident replaced the K-wire. It's very hard bone. Even the pushing real hard, it's not going well. So this kind of situation is not easy to put the K-wire and screws. Another situation is small pedicle. This case, it was the burst fracture by a fall. He has a L3 burst fracture and mild kyphotic deformity, right? The CT scan shows only 4.5 centimeter pedicle width. The smallest penetrating screws, you can use MIS technique, is 4.5 centimeter in the market. You can do AP and lateral view. You can place the TMC needle safely. That'd be great. However, sometimes it's difficult to show small pedicle. Then the pedicle view, the rotating C-arm. Look at the pedicle. Then you place the center through the pedicle with the TMC needle and K-wire. Then you just shape. Once you put the screws, you can see that the right side CT scan in kyphosis is corrected. When I do this burst fracture, I try to do less than 24 hours, or at least 48 hours, in order to using ligament laxity, pushing the bone fragment away from dura. If you do early, that is possible. So without the decompression, you can place the percuted screws only to correct the kyphosis. So now is X-ray, we do MIS technique, right? And then problem is we expose too much X-ray. So now there is a spine robot using placed pedicle. So this is interrupt CT scan. You bring the interrupt CT scan. It takes only 2 minutes to rotate. So we can do up to 8 levels, right? To bring in this, during the case, if you feel uncomfortable to putting pocket and screws because of anatomy, we place the reference antenna and then bring in the CT scan. Once you get the CT scan, interrupt CT scan, and then transport to the workstations, that's very simple. You just bring in the location of the proper level, and then you can change the angle, you can change the size, length, okay? You can do multi-level very easily. In 2 minutes, you can do at least 6 level. Once you put the screws, and then you can reconfirm the alignment with the left side. So the screws head too wide, each one. You cannot put the rod appropriately. So that's why you'll need to look at the alignment. So you can adjust each screws. I prefer when you do a burst fracture, the index level shorter screws. There's a short screw, right? And then to increase the biomechanics. Once we measured and then you planned, then we use place the screws, right? So this is not like an AI-driven automatic robot, not a real robot, right? This is a shared controlled. The surgeon controlled plan, right? Screws length, what angle, and then the machines, a robot giving you a steady angle. You can place. You can do like a drill to place the screws. You can see there's a left side bicortical screws easily without any worry about damaging vascular structures. While to the right side, you can place the pelvic screws with a high-speed drill. Of course, you can do MIS proscope guides or open surgery putting screws. However, robot helping you. Another problem is the robot. I'm trying not to use a robot during the training with my residents. When you do like driving the car, when you all folks you can drive a manual, but now you cannot drive a manual. Everything is automatic, right? Same thing happened to this robot. If you trained all robot, you cannot put the pocket screws with a proscope guide. One of my surgeons, my co-worker in orthopedic spine surgeon, she was trained all navigations, so she cannot put screws, pocket screws without any navigation. So that's I'm worried about training. However, definitely this help, okay? a difficult case, a scoliosis case, or very small pedicle, a distorted anatomy, a robot is really helping. Okay. Then how accurate these percutaneous screws? Many of the articles shows much better than open surgery, right? Some article shows robot pedicle screws less than the navigation screws. However, I believe the robot screws much higher accuracy. Up to 2 millimeter violation we consider as a non-clinical because the 99 patient has no symptoms. So this is the criteria. Even the less than 2 millimeter violations, around the 2 or 3%. Right? This is acceptable. Right? So how we put the rod is many people can do the MIS technique, right? This is a spondylolisthesis grade 1. There's a 6 millimeter spondy. So put the bottom one, the tightening screws, right? Then there's a gap between rod and then upper level. Sorry. So you tightening upper level, you can pull back. I'm sorry, I'm about to pull back the upper level to reduce the spondy. Now it's reduce the spondy, right? So there's the left side, there's a spondy grade 1. The right side is that reduce the spondy. So percutaneous screws is safe and accurate. This is essential to the MIS. You want the MIS fusion, you have to master the percutaneous technique, right? Important thing is that you need to get the proper CM and then properly interpret the CM images. In order to that, you must be trained properly these techniques. If you're trained well, much less complication, much higher accuracy of placing. Most times the complication can happen is the K-wire things. When you put the Jameson needle, we place K-wire. You thought the K-wire, the Jameson needle is angled medially, but there is a chance K-wire is a little outside. When you place K-wire is not going through the pedicle, going outside. If you place, without the notion to continue to place K-wire, there's a good chance peripheral organ injury can be complicated case, right? But this is one you have to be careful. Thank you.
Thank you very much, Dr. Bung-Soo Kim. This concludes our first session. You will have a short break for restroom break because we don't have much time and so many lectures, very interesting lectures are in later on. So maybe a short break for just restroom and you can take coffee, you can bring it here. I'd like to call on our next moderators for the next session, Professor Shatursanov and Professor Huday Berdiev.
Начинаем нашу следующую секционную работу. Первым слово представляется доктор Гаранчук из России. Пожалуйста, регламент 7-10 минут. И надеемся, что успеем вовремя закончить нашу работу. Спасибо всем.
Уважаемый председатель, коллеги, позвольте представить вашему вниманию.
Let me, first of all, report my speech from the first St. Petersburg Medical University. And Assalamu alaikum, since we are here in Uzbekistan, and our report will be dedicated to uniportal endoscopic surgery of lumbar spine under degenerative diseases. And we have been discussing the step-by-step procedure of the surgery. I mean, the speakers before me. And of course, I will try to focus on general issues. Well, the technologies are developing, and I think that it makes no sense to discuss the relevancy of this issue. We had over 4,000 of publications since 2000 with the first publication of Sebastian Rutten. We had over 4,000 of publications. So it means that it's very important and then relevant technology, which is methods which is used under degenerative spine diseases, and we can have transforaminal and laminar access. Well, which types of accesses is more important? We can see that if we will go down to the sacral, interlaminar access is more preferable, because you are having more gap, more foramen to ensure better manipulation. And of course, the foramen is expanding, and transforaminal access gives a better opportunities for conducting surgery based on stenosis and herniation. We sometimes refer interlaminar access, and the more we go to foramina, the transforaminal access is more feasible. And of course, we have the special algorithm to make decision based on certain type of pathology, based on conservative treatment, and it depends also on endoscopic technologies, which are becoming more and more preferable. And sometimes we can have this inter body fusion. We can have also changes and recurrent changes in the area of open endoscopic surgery, hypertrophy of ligamentum flavia, and the stenosis, and based on placement of percutaneous incision, it depends on intrachannel component of stenosis. More we go cranius, cephaloid, or caudally, I mean the sequester of the disc herniation, we can reach it because our incision should be not on the level of the disc, but above or below it. I don't think that it's necessary to discuss the position, and here these slides are also quite obvious for us. Based on the placement of the herniation itself, we can use different curettes, we can use Kerrison punches, and etc., which will help us to fix the screw. Also, we can use this endoscope, and it depends on also whether the surgeon is right-handed or left-handed man, and the access, I mean the point of access, all point of entry will also change. So we are going to show you now the probably some videos and pictures to show you the ectomy of ligamentum flavia and removal of sequestered herniation of the disc. So everything happens in the channel, in the tube. You can see these are the standard procedure. And in case if you can see that this herniation is available, we can of course reach it and take it down when you have take the sequestered part of herniation out. I guess this is the most pleasant moment of the whole surgery for all the surgeons. And you can see we are also trying to remove the cysts of as we're removing these cysts, and also sometimes it's difficult, by the way, to differentiate them from dural sac, but anyway, we are trying to do it. And we can also have so-called contralateral approach to decompression in case, of course, if it is required. We are removing the ligamentum flavia from the other side, contralaterally, I mean, and we see that there is no compression. Then we are conducting this compression. We are touching dural sac, and so this is the way we undertake our procedure. So you can see here, these are the parts of the cysts, and so you can see that with doing such a small incisions, you can get such important and big parts of the herniation. We will not be discussing now foraminal access, which have been highlighted before, but you can see that indeed for us it is very important to touch this I would say the margin of ilium, and we have different techniques of transforaminal access. Previously, we have been using so-called S-disc. At the moment now, we are reaching foramina, conducting decompression, reducing stenosis, and then we are penetrating inside. So it's like not inside out, but outside in. So the most important benchmarks from anatomic point of view is that our access to outgoing and incoming route, and we need to I mean, I'm showing it on presentation, and our colleague from Turkey explained it gradually, step by step, in very detailed manner. And based on the, I would say, level of location of herniation, incision area also will vary. And I guess the most remote part also depends on the herniation location. And you can see here, I mean, you have a quite huge foramina without sequester migration, and it might be located, I mean, physically, it might be located quite far. So it might sometimes require quite huge foraminectomy to reach the place. Let me show you a short video of transforaminal surgery. And you can see that we have quite a high resolution visualization. And now we have conducted decompression, and we have received very nice results. And we have also reached the structures of above and below located parts of vertebra. And the photos before and after surgery, you can see no herniation, and it's quite nicely fixed after.
Моментов еще, когда мы готовились
Probably there are some also items which I would like to mention. Actually, were trying to discuss both monoportal and biportal surgeries. Talking about monoportal surgery, you can have a decompression from just an entry point, but these tools which we are using, they're quite delicate, they're very thin, and of course, they're quite expensive. And talking about biportal access, its disadvantage is that we are having two probably entry points, but all of the opportunities of endoscopic surgery gives us a better opportunity. So we are using this channel only for visualization, which gives a better quality and better visibility. And for the other incision, we can conduct our surgery maneuvers and we can conduct the same operations as we do it under monoportal access. And now I would like to probably come up with a certain calculation, but look at these endoscopic spinal technologies in this probably calculation. You can see that if we are talking about sequestration or monoportal surgery, it's quite nice. But if we will start with stenosis or recurrent herniations or multi-level stenosis, decompression and stabilization, of course, it becomes more and more preferable to have biportal using two points of entry. And yes, of course, it might be a bit higher, I mean, the cost, but it will produce a better impact, in my opinion. And of course, each of the technology, each of the, I would say, it depends also on the opportunities of each surgery. But monoportal, of course, it gives you one incision, biportal gives you two incisions, but anyway, it will give you a better opportunities to reduce the financial, I would say, burden. And that's all probably from my side. Thank you so much for your kind attention. Yes, thank you so much. Colleagues, in case of any questions, you can feel free. Otherwise, we can keep them for our Q&A session. And from my own, I would like to mention that talking about stenosis, of course, intralaminar access is the best way in case of stenosis. Yes, you're absolutely right. If we have this central stenosis, it's better to have, of course, such a central intralaminar access. Thank you so much, and we do hope that we will cooperate with surgeons from Russia in future. And now I would like to give the floor to Mr. Abduhalikov from Uzbekistan with his speech. Dear colleagues, dear chairman, it's my pleasure to welcome all of you at the Spinal Endoscopic Surgeons Annual Conference, and my report will be dedicated to intralaminar discectomy, how we as a beginner can start these operations. First of all, I would like to ask you, dear audience, how many of you are practicing open access surgery? Please kindly raise your hands. This lecture will be more feasible probably for you because we will be discussing, I guess, something which might be interesting for you. And talking about intralaminar surgery, spine surgery will give you a chance to conduct a surgery on big surgeons while having 6 millimeters incision. You are having a patient who overweight plus 130, 150 kg, and you cannot have open source microsurgery discectomy. You will not be able simply to conduct it, or you will face a lot of challenges and difficulties. And here we have a lady patient who weighs over 140 kgs with the weight of 160 centimeters, and she received quite nice results obtained. And look how it looks on the video. Our patients who couldn't practically walk because of the neck pain, because of the back pain and neck pain, leg pain, we have been helping them, and you can see as a result, they can now move easily. They cannot practically walk, and they are complaining over severe pain. And now look, after surgery, they are very happy and satisfied with the results of surgery, and they are moving with no limitations. So how you can start these operations? You should first of all buy the equipment. It depends on financial, I would say, status. On the financial status of your hospital, whether they have or not the opportunities to procure that equipment, and I mean, from the financial, I would say, conditions. I have been using quite a cheap equipment from Olympus, and actually it was quite nice results which I have obtained. And the toolkit is quite, you can see, comfortable and convenient. We have the equipment by Max, I mean the toolkits. We have optic equipment with 5-7 millimeters working channel, and Kerrison equipment, Kerrison toolkits for 3 millimeters, I mean toolkits and Kerrison punch, and all the respective type of equipment. So how and with what should we start? First of all, we shouldn't start doing over, I would say, complicated
на уровне L5S1
surgeries. We should start with something which is quite simple, and we should also have this herniation of discs, and it is quite nice for intralaminar surgery. So the position is a prone position, and we have collected this.
Ноутбука со всеми срезами пациента. И самая важная часть довольно...
So for our doctors, sorry, it was unstable connection. Yeah, I mean, it will depend on how you will approach. That's where the cannula should be installed a bit lower than I would say vertebral arc of the a bow position, and it will help you to and you can see how we are placing this cannula in proper manner. Mostly, I mean, slim patients, they do not feel the need to having anterior and posterior. I am trying to find this midline. I am trying to place the needle, and then I am doing these incisions. I'm installing this cannula, and then I'm starting the operation. What is the most important is that
Хирургически они помнят.
not forget that all the doctors which have been involved in microsurgeries, first of all, we are doing this. First of all, we need to find this arc, then ligamentum flavia, and then we are touch several surgeries. So first of all, you need to do incision, then we will place the cannula and trying to touch the place of access. You need to feel the bone with the tip of the needle. And in case if we have our irrigation system, but in case if you do not have it, you can use two probably drainage, which will help us to resolve the drainage issues. I am having this white system stand, and also of course recording event. And at L4, L5 level, we had a patient with quite a huge herniation. I would like to show you the video from the surgery. First of all, we have installed our endoscope, and then you will have such a picture. These are soft tissues. You should identify, first of all, the arc of vertebra. You need to remove these soft tissues. And you can see that using this Kerrison punch, I'm touching the arc. I have identified the arch, and I am removing the part of arch. What is arch? Arch is the above located, a part of above located vertebra, and some of us are using different techniques of removing ligamentum flavia. Some of them are using scissors, some of them trying to remove upper margin of ligamentum flavia. For younger patients, I'm using punches with 2 millimeters, which will help us to resolve the issues with durotomy with the minimal damage, and it will be less than 0.1%. And we are moving with very slow movement, at very slow pace. We have identified the lateral margin of the root. We have identified the location of disc. Then we are taking a picture for us to have clear idea. We are doing coagulation of epidural veins, because in such a, when you remove such a huge part of flavia, you might face a problem with bleeding. Then we are opening posterior longitudinal ligament, and we are removing part of sequester. Now we are getting sequester, and simultaneously we are removing such a huge sequester, and you can easily see, clearly see the root, and you can clearly see nothing in the disc itself. So the MRI results, pictures of this patient 1 day after the surgery, but clinically you can see that all these negative symptoms regressed in the patient. So within 10 minutes, I will not be able to embrace and train all the doctors with my experience. But in India, we have Dr. Mumshi, who has a course, and we are teaching in this course from Uzbekistan together with Mr. Shomasur Shotorsunov, my mentor. We are teaching this course, and this lab has state-of-the-art equipment. They have a lot of materials, I mean, for studying, and you can easily also do it on dead men's bodies. So intralaminar surgery can cause a huge interest, and we have a lot of people interested who are gathered around our surgery tables, and we are showing you from the beginning till the end how the surgery is conducted. And here we have bars. So with bars, you also can use a lot of equipment and techniques. And also I can tell you that each doctor who is practicing open surgery can easily start endoscopic operation, and it's not the future, it's our today's life, something which happening today. And Uzbekistan is one of the countries of the world when endoscopic is proactively developing, and we are ready to share our experience on how to conduct endoscopic surgery. Thank you so much. Yes, thank you so much indeed for your interesting presentation. And indeed, he's one of our young representatives of Uzbek spinal surgery. And we hope that you will be working proactively in this manner. And now we would like to give the floor to Dr. Kelmakov Vladislav from Russian Federation, please.
Здравствуйте, уважаемые коллеги, уважаемые нейрохирурги.
Dear colleagues, dear neurosurgeons, and those who have dedicated their lives to endoscopy. And I am from Russia, and I am from Novosibirsk Traumatology Institute and clinics of 5+ here in Uzbekistan. And my report will be dedicated to differential endoscopic treatment of degenerative disease of cervical spine. So if you have heard a very interesting report by Mr. Klim, he interestingly highlighted the treatment of cervical spine. I will probably add some more nuances to the treatment of this disease, of these lesions. And whenever you're conducting any surgeries on spine, the key issue is to, of course, release the nerve structures, remove compression, and improve quality of patient's life. So we have several approaches. You can make it endoscopically, you can have open access to the point of destination. So first open surgery was conducted in 1944 by removing the arc of the vertebra.
Эти операции делаем уже эндоскопически.
And now we are doing these two types of surgeries in endoscopic manner. And you can see indeed how cell phones are evolving. So you can see the evolution of the surgery also. The full endoscopic cervical foraminectomy, we are starting removing herniations from posterior access. These techniques is advised to the patients with lateral herniation with no myelopathy. It is quite a simple technique where you can easily use you can find the so-called V point and I would say access, the stages of this access are here. With reamer, you are opening this foraminal channel. You will find this dural sac, and you are removing this herniation, or you can do decompression of bone structure by decompressing nerve structures. So these are clinical, I guess, example of how we have conducted this operation. Unfortunately, we do not have CT scans of the patient, and now you can see the video. And I have now listed all the stages. I mean, we have drilled up to the V point, and you can see that we have managed to reach the root and touch to the herniation, and we have improved the patient's quality of life by means of decompression. Of course, it is not easy always to reach the sequester. Sometimes it is quite challenging to reach it, and then sometimes you need to use a kerosene punch to remove it. Here you can see the MRI after surgery, and very small incision. Decompression has been achieved. The surgery with all of this anesthesia
На следующий день пациент
took just 1 hour. A patient lost only 10 milliliters of his blood, and next day he was taken to outpatient care. And
передним доступом удаление грыж диска.
All of a sudden, you so-called anterior access, we are having so-called osteofilter. Sometimes you need to have this stabilization. Sometimes you do not need to have it. Now it is performed only in endoscopic manner, and you can have two types of access. You can get the access from the arc, or from disc, sorry, or from body of the vertebra. You can have a small incision. It will not require fixation. It helps easy recovery and systems of stabilization. And of course, it will let us to release the patient in a very short term. We are doing it in standard manner. I mean, we are moving this artery in medial manner, and pharynx is moved or laterally or medially, and then we are putting endoscope and removing herniation of a disc. So should we do it, I mean, in case of centrally or paracentral herniation of discs? In most of cases, this herniation is quite soft. So here we should not, I would say, I mean, we do not have a chance, we do not have even a room to use this kerosene punch. It's quite nice clinical example of how we're using this soft herniation. We have myelopathy. Our patient suffers from myelopathy, and as this operation has been conducted, and you can see that the symptoms of myelopathy simple, I mean eased, and as a result, we can have a quite nice clinical outcomes. And another also sample is, I mean, our patient also suffered from myelopathy. We had through over the disc access, we have removed the herniation, and as a result, we have managed to achieve decompression. Also endoscopically, we can fix and we can implant. I mean, we can fix the implants for the patients who have a certain instability, and this ACDF has been very nicely shown by our Chinese colleagues as steps of surgery, surgery, and of course we are getting a general approach. We are using bore, and also we are using drills to enlarge the foramen, and also using the same manner we can remove a posterior longitudinal ligament and achieve even a better decompression. And we are showing you now a nice clinical example. I mean, our patient has herniation of disc, and these are CT scans. And we have also interoperational CT scans of installation, of insertion of implant. And also you can see some other surgeries, CTs from the surgery. And you can see that there's ossification of longitudinal posterior ligament, and you can see that it will be a bilateral decompression, and it will help us to get intralaminar access and improving and I would say enlarging this intralaminar entry point. And the authors of this article are using for these purposes quite a huge endoscope with 10 millimeters. And we are using, and for this surgery, we also, by the way, went for the same endoscope who gives us a better visualization, and we can use more and more instruments. And this is the patient with so-called OPLL. And you know, in open surgery at the moment for laminoplasty, we are doing it, but further, what should we do? We must face a problem with the, I would say, wound itself, with the incision itself, and in the long term, we might face kyphosis or muscle atrophy, which will produce adverse impact on the patient life. So, of course, ossification of ligamentum flavia is also, as I would say, the situation where we need to go for laminoplastics, and we can also have a surgery with endoscope, and we can also engage some other, I would say, parts of vertebra which we need to remove. And now we would like to share you the example of the patient with hypertrophy of posterior ligamentum flavia, but we do not have any functional MRI here. And in case if you have functional MRI, especially in terms of flexion, you can see that we had conducted endoscopic decompression by means of a posterior access. And here we will find this V point, and we will find the points of access. It depends on the skills of the surgeon. I guess here we are opening this foramen. We are removing the part of this spinous process, and you can clearly see that we are doing it up to the end of ligamentum flavia, and we are removing all these end blocks, then coagulation of the veins, and decompression has been totally achieved. So this is the correction performed by us. Up to the point where we remove the ligamentum flavia. So this is the CT scans, and you can easily see in this post-operational space, and you can easily see that the spine is now put in its normal regular position, and we have regressed all these negative symptoms. So all of these 4 methods are used depending on the clinical manifestation. And if you have some radiculopathy, or if you are facing some myelopathy, which was caused by lateral herniation of this or central herniation, or ossification of ligamentum flavius, so all of these 4 methods can be successfully used differentially based on the pathology patient is suffering from. Thank you so much. Thank you so much for your presentation. And we have a lot of nuances actually in cervical spine. It's most, I would say, difficult, probably the domain of the spinal surgery. I would like now to greet Novosibirsk School, and together with Professor Simonovich, we previously been conducting these spine surgeries, and we would like to greet Professor Mikhailovsky, Professor Erich. We have been previously communicating with them. We have been exchanging visits, and we are wishing you the best of luck in all of your endeavors. And now let us proceed, please. We would like to call on stage Timur Dushanov.
Assalamu alaikum. Especially for those who came here from far away. So I'm Timur Dushanov. I work as an associate professor at Central Asian University, and also as a practicing neurosurgeon and spine surgeon at ProfMed Clinic. So today's my topic will be focused on the beginners. As I've completed my first 100 cases, starting from the, I moved from the skull base and cerebrovascular surgery to a full endoscopic spine surgery. And I want to emphasize what is needed to eliminate or minimize the amount of complications, and also to reduce the complication to 0 for your first 50 or 100 cases. So uniportal full endoscopic surgery, it is the same as the stenoscopic spine surgery. Of course, the benefits are the less tissue damage, the reduced reduced pain post-operation, the quicker recovery time, the low infection risks, and also the less intraoperative injury due to the high definition visualization. And also the overweight patients are not the problem. Actually, my first 2 patients were overweight, over 120 and 135 kilograms. So when we think about this course, like I have not failed, I've just found 10,000 ways that won't work by Thomas Edison, or by success is going from failure to failure without a loss of enthusiasm. So it is not applicable for medicine. We know that. So as a surgeons and neurosurgeons and spine surgeons, orthopedic surgeons, we know that the failure is not an option to us. So as a jet pilot, the Formula 1 driver, the neurosurgeon or orthopedic surgeon, we don't have the right, especially for the patient. So how to start in order to minimize the major complications in your first 100 cases, and also do not, of course, the main, in order to have the success, we have key points. I will be focused on the key points as the step-by-step guides and so on, already discussed. So first is the that we should aim that we should not have complications first 50 or 100 cases. It means that the time is not what we want to think about. So the priority is quality. So even if it takes like 3 hours, 4 hours. Actually, my first cases was like 3.5 hours, even 4 hours. So, but without complication, it is the better way. So then you can reduce the amount of time which is needed. So, and also, especially the developing countries, do not broke the scope, first 100 or 50 cases. So you can manage that later in your practice. And also need a minimum of necessary equipment. We will talk about in the next slide. Know which patients to operate. This is the key. I call this like super selective surgery. So you can minimize your complication in the first 100 cases. And also, if possible, you should have senior colleagues and mentors to manage the intraoperative and postoperative complications like the revisions or bleeding or any kind of issues. I was fortunate to have my colleagues like Dr. Akhrar Yakubov, Rustam, Dilmurat, Kanzimov, and Jahangir, and so on. So it was not a problem in the first place in the beginning. So what we should focus is that we should be very super selective when we pick our first patients. And what we need is a very basic minimum of equipment. It is a scope, of course. It is the keratan rongeurs. Even 2 rongeurs is enough for you, like second one and third. Then the pituitary forceps, the working sleeve, the obturator, the root retractor, and 1 nerve hook. So it is enough. And also, of course, the bipolar coagulator and 3-liter saline. So in the start, you need basic tower, the endoscopic tower, basic C-arm, and also the long table for the nurse and the waterproof drapes. So how to select the patients? First, I think it should be like L5 to S1 primarily because the interlaminar window is large, paracentral herniated disc, which is not really caudally or rostrally sequestrated, not sequestrated, and also large interlaminar window. The age should be like from 25 to 50 years old, so you will not have calcified discs, and also you will not have this very fresh herniation in young individuals like I've operated in later cases like in 15-year-old patients. It is very difficult to operate in very fresh discs, which has many parts, healthy parts to it. Usually it is traumatic herniations. And also you should not have revisions in the first place, of course, and also do not pick revision cases. It is for later on, and also no complicated cases like with comorbidities, with calcified discs, like multiple levels and so on. So, and also you should avoid the huge wide base herniations also. At first, I will show you, we'll discuss one patient with huge herniation, one of my first patients who had a little bit of temporary complication. So, and also you should avoid the calcified herniation and also calcifications and osteophytes. So preparation is key. We should have the recent MRI so we can go to the surgery with very recent images, like 1 month prior to surgery. The CT always needed to be done. You can skip the CT part if you are more experienced, but for first cases, you should definitely have the CT so you can assess the calcifications, you can assess the interlaminar window, the degrees of the angle of the spinous process, and so on. And you should have all of the images on the larger screen or computer while you are operating. So first 10 or 30 cases you should do, I will emphasize this, with general anesthesia to young ones, because when you explain to the patient that you will operate, you are not going to be like a very fresh spine surgeon which will do first cases. So it will take a lot of time, 3.5 hours and so on. And for example, spinal anesthesia or the local anesthesia will put a very great pressure on you when you're doing the surgery and the patient is listening to everything. So treat the patient and not the MRI. This is also a very important part. If there is multiple levels, you should concentrate on one level, which is causing the symptoms. For example, one level, L4, L5, it is in another side, the L5S1 in different sides, so you can concentrate on one which is having the symptoms and leave the other one for the future. Of course, you will explain to the patient. So before the surgery, of course, you should not forget the shot of antibiotics, ceftriaxone, after testing, and also you should have a senior endoscopic spine surgeon beside you to help if there are any kind of complication and to guide you a little bit. Always ask the side of patients and name of the patient. This is also a major mistake which will happen in the beginning. For example, left side, right side, and so on, because the patient is in general anesthesia. Control the operating nurse for any errors and mistake, because when you are starting the general, usually the operating nurse also starting this kind of surgery, it is very different, and you should control the mistakes also of the nurses also. When they're changing, for example, the saline and so on, so it should be like really sterile. So you will not have the infection, spondylitis, discitis after the surgery. So warm to body temperature, the saline, and also add adrenaline like 0.51 milligram per liter, and it really helps to reduce the bleeding of the soft tissue when you're opening, and also the bone bleeding, because it will constrict the very small vessels and you will operate in clear view. So during the surgery, the priority should be, as we've said, the quality hour fast or being quicker. My first cases was 3.5 hours. For 10 to 30 cases, always do the AP and lateral views. For example, nowadays we don't use the AP views, we just go to the lateral, but first cases always you should consider both of them. And also puncture with scalpel is enough to cut the skin and the fascia for the interlaminar approach. And you should be very careful in very thin patients, because when you cut the 2 centimeter and it is already on the ligamentum flavum. So during the surgery, the major issue is when you go to the surgery, the question is how I can handle the bleeding. So of course the epinephrine solution, as we've said, and the soft tissue, you should manage this while it's small with bipolar cutter, so step by step you should use the clear view. But when you're experienced, like, you can just go on, but at the first you should stop every small bleeding. The bone bleeding, you can stop with bone wax using the dissector, very small dissector. You can put the own bone wax and place it, and also you can compress the bleeding bone with the tip of the kerosene. Uncontrollable bleeding, it is last resort. It never happened to me before, but in recent days it has happened. So you can place an obturator to the working sleeve and stop the water, stop everything, and wait for 10 to 15 minutes. So uncontrollable bleeding, you are not having, cannot find the source. It was a patient with hemoglobin 117, which was reduced after surgery for 80. So it was very severe bleeding. We stopped this with an obturator, and patient discharged without any kind of complication after surgery, because the bleeding happened after this herniation removal. And dural tears, it is also a very important thing when consulting. Of course, you should avoid it. I had only one dural tear, but it was very interestingly we've seen this after surgery. When we were looking at the video, it was very big, but the inner layer of the dura was not damaged. So we were seeing the actual roots, but they were not herniating outside. So usually you should avoid this. If there is a dural tear less than 2 millimeters, you can just put the Surgicel and close it. But if it is a bigger, you can converge to open or ask a more experienced endoscopic spine surgeon to suture this. I have a couple of colleagues, fortunately they can fix this kind of problems also. So do not bite or cut what you don't see, of course. The post-surgery, one thing is important that, of course, the antibiotics and NSAIDs, the brace for 1 month, we limit the weight lifting up to 5 kilograms next 3 months, and we restrict driving. This is very important in first month. Do not, and also, this is also very important, never do an MRI for no symptom patient, especially for example, in our country, they report this as a disc herniation when there is only like annular fibrosis or posterior longitudinal ligament and so on. If mild paresthesia due to traction, you can prescribe dexamethasone for 3 days and then you can taper this down. So, for example, this is a patient, one of my first patients. This patient is very obese with like 130 or so kilograms, L4, L5 herniation, wide base herniation, predominantly right side with right side pain. After surgery, we removed due to traction and also increased return of blood flow. There was a paresthesia and also urinary retention. So we've prescribed the dexamethasone for 3 days. After 3 days, the patient was okay, and also the diaries also returned, so discharged completely well to home. So this was a patient. This is after surgery, like walking and so on, after 3 days. So this is the next case. It is a 34-year-old male presented with left side L4, L5 radicular pain, suffered for years. So we can see this is the cases we can pick in the beginning. So this is a patient from Tajikistan. So he returned after 1 day. So it is like next day he was walking and going home without even like letting me know. So that's it. This is the next case. This is a 45-year-old patient from Bukhara, actually from here. He came with a radicular pain in the left side. We removed. Next day he returned home without any kind of neurological deficit or anything. So this is the next cases. I think this is enough. 10 minutes passed. So thank you for your attention. Any questions and so on. Thank you.
Thank you very much. Savollarni keyin gaplashamiz, вопросы потом будет, наверное. Я хочу поблагодарить доктора Душанова. Хотел сказать, он является...
Colleagues, the Q&A session will be held later. I would like to thank Dr. Dushanov, and indeed the most important organizers of our conference is the ProfMed Service Clinic, and this particular clinic was, I would say, the clinic which pioneered the development of spinal endoscopic surgeries, and we wish this clinic success and all the best. And yesterday we have seen the its Bukhara affiliate, and we do hope that it will develop in Bukhara also.
First of all, thank you, Dr. Timur. It was excellent presentation. I agree with all of his saying, but I have one objection. Following endoscopic surgery, please do early postoperative MRI in every case. This is very important. Why? There are 2 reasons. One of them, you can evaluate yourself. What did you do? You can see in postoperative MRI. Second one, of course, our countries are different. We are living in Turkey. I am doing postoperative MRI also to protect for me in the legal issues. Because following the discectomy, the patient can have early recurrence. For example, one week later. But if you did postoperative early MRI, you can say that I did it. Recurrence is not complication. So I want to say only thing. Thank you.
Следующий доклад. Доктор Турсунов, мадам Инжан, представитель Андижанской школы узбекской
Now we would like to give the floor to Dr. Tursunov Madamin, who is representative of Andijan School of Spinal Surgery. My report will be delivered in English, and I will deliver my speech in then in Russian. So why I started my title of my speech with the words "New Horizons," because this intralaminary school, I mean, methods started here in Uzbekistan in 2005, and this patient still is alive and happy and living good quality life. And the new method since 2016, would it be PSLD or PLD? These methods have not changed. I mean, its philosophy, its technique has not changed. So talking about TILS methods, they are
Включается новая философия, новые инструменты.
We are using new methods and we are searching for new philosophies explored. Therefore, I guess here the major issues for us, for endoscopic surgeons, is what are the opportunities for us, because today's transforaminal endoscopic discectomy is quite different from what Anthony Young has initially proposed. 7 years ago in Andijan, we have started these operations, and actually we have been learning about transforaminal surgery, and I have my teacher here, Professor Ivan Volkov here, and we have moved to intralaminar, and now we will have intralaminar, transforaminal, and PSLD, and now we have managed to fusion also, jump to fusion. But for us, a transforaminal technique is the most, I guess, feasible and appropriate for us. Let me explain the reason behind. You can see that this transforaminal endoscopic, well, Hijikata started this transforaminal operation with no endoscopes. We have been 20 years ago using it, and the Center of Neurosurgery was conducting the same procedures. So you are reaching the disc. You have been removing this nucleotomy, then you have been doing nucleoplasty and annuloplasty. It is called disc and fix. Well, in case of protrusion and minor herniations, it's quite safe. It can easily be learned and practiced. Probably 2 or 3 times you will show it to your fellows, and surgeon will learn it, and quite low risk it poses. And then, well, came so-called percutaneous transforaminal discectomy with arthroscope. We are having visualization with arthroscope. Well, the technique was the same. And he also developed some so-called Cambian triangle and his own philosophy of this. And 20 years ago, Anthony Young, he developed for the first time in the world fully endoscopic transforaminal endoscopic spine surgery, which is called so-called YES method. And our colleague from Turkey actually described us this particular transforaminal endoscopy technique, and you can see the advantages. You are removing herniation under visual control. You are removing paramedial, lateral, foraminal, and paraforaminal herniation. You can remove them, and it's quite easy to learn and to also, it also gives you a better safety levels comparing to nerve structures, but it has some, of course, deficiencies. First of all, you cannot fully revise the vertebral channel, and especially this issue, you can face it in case of hypertrophy of articular processes, and especially for the lower spine for L1, S5. And of course, it also limits you in case of migrating herniations, and you cannot remove these calcified herniations. And in 2004, Thomas Hoogland developed transforaminal endoscopic spine system, TESIS. He ended remorse. So you will do foraminoplasty, you will enlarge the foramina. You will start the access not from the disc, but from the foramina. And you will use the special remorse. So you will access the channel using tubes, and with remorse you are having this foraminoplasty. Then you're reaching the disc, you're removing the sequester, and in case you will have an opportunity, you will reach the disc. It is called outside in. So from outside you are moving inwards. And what are the advantages of this method? Actually, it supplements the yes methods. You will remove all the types of herniations, paramedially, laterally, foraminally, paraforaminally, and even in case of migrating herniations. And when you also can open up foraminal channel in case of foraminal stenosis, but the limitations is L5S1, and in case of ossified herniations and centralized stenosis. And of course, the key issue for us is a training curve, because majority of surgeons they go for intralaminary methods because it's easy, it matches the human anatomy, so everyone prefers go intralaminary. But after our, I would say, learning curve, let me be very fair, I undertook 6 cadaver courses to test this. And I can tell you that the surgery can be conducted under fluoroscopic control. You need to check each of your steps, and these accesses according to JoyMax. So these TESIS methods developed by JoyMax company, they have intralaminar, like LASIS methods. It's like intralaminar disc ectonomy. We can have transforaminal access like TESIS. You can have it like transpedicular or posterior lateral. And its philosophy is that you are doing the small incision to get bigger part of the herniation. It is easily to do it, of course, if in case of if it's easy to accomplish it intralaminary, you can do it intralaminary. In case if it's easy to accomplish transforaminally, you can go for transforaminal approach. So it shows you which way is more preferable in certain types of situation. So in 2018, a team of surgeons under Shok Shiba professor, they have developed so-called endoscopic methods, also transforaminal access, and all of these accesses can be divided into 3 generations. Yes, TESIS, and the 3rd generation is EndoSurge. What are the differences between them? The philosophy of 3rd generation is new tools, new techniques, and new philosophy of surgical operation. Talking about kits, we are using such tools as bigger endoscope. In TESIS, we had 6-millimeter endoscope, and at EndoSurge it has a 9.5-millimeter, which gives you a better picture, and you can easily decide a high margin, upper and lower margin of spinous process, and would it be easily you can also check this facet joint gap as well as foraminal foraminal part. So we were not previously we have been using so-called X-ray assistance. Here we were being just guided by the human body's anatomy. Quite a huge working channel. Here it is like 3.7 millimeters, and sorry, it was expanded to 4.7 millimeters, and we are having two tubes, T-shaped tubes, and previously it was only one tube, but now we are having two tubes, and while surgery you are working like using both of your hands. So, and talking about external cutters, reamers, we have been using indeed X-ray assistance, but now it gives us, first of all, a safer operation. We will have less problems in training, and of course it shortens the training time. What are the advantages? First of all, we can easily remove all these herniations because everything is visual assistant, and we can easily check channels. I mean, the spine channels, and of course it gives us a better opportunities to conduct successful surgery comparing to the second generation operations. Sometimes even if you're conducting microscopic intralaminar surgeries, you cannot receive better results. It reduces the load, and you can have and the leaf and the pleef and the leaf. All of this operation can easily be performed, and here are the stage of the surgeries, and we are touching the foramina. We are not penetrating it, we are just touching foramina. We are checking it with X-rays. There will be only two shoots, two pictures taken, two images. So we are first of all putting the channels, then expander, then we are installing our U and T shaped working ports, then we removing dilators and installing endoscope, and we are also identifying upper articulose process of the above located vertebra, and we should also be guided by vertebral arc, and you can see the foraminoplasty under visual control. I have selected the easier and the shortest way. When you are using the pump, you can see you have the bleeding here, and when you are using pump, we are reducing the bleeding, and we are cleaning the field of our view, talking about foraminectomy. In case if you can stop bleeding with coagulator, this is the way, but in most of cases it is not required. So here we are having ligamentum flaviae, so we can easily twist the reamer. And after, I would say, removing reamers, you can clearly see the ligamentum flaviae. Then we will are opening ligamentum flaviae with caries and punch. You can easily see the herniation, which will be now removed. We will revise the vertebra channel, spine channel. And with this pathology, you can easily see that even if it's a migrating herniation, it can be accomplished. Would it be a central herniation with bilateral symptoms? Because sometimes it gives bilateral symptoms. That's why when you're having or transforminal or interlaminar access, you cannot see the other side and you cannot be able to have, but in PCLD, you can easily, I mean, in case of regular herniation, do we need to, I would say, have over-the-top access? So you can look at these methods and you can penetrate under the ligamentum flavia and to see the other side. And also you can have stenosis with hypertrophy of facet joint and ossification of the disc, herniation, and of course it's not now included in the my discussion, but anyway, I would like to draw you just one example. We had a degenerative dystrophic vertebral disease, ossificated L4, L5 disc herniation with lower migration, and you can see that we have conducted bilateral decompression of L5 roots, and we are trying to reduce it. We were trying to reduce it. We failed. Then we have been using chisel, and you can see it's transforaminal, not interlaminar access. And we are removing certain part of the, I would say, soft tissue of the herniation and disc. And this is the remainder of the ossificate, which we will try to remove. And as a concluding remark, I would like to tell you that EndoSurge techniques will give us, I would say, open-minded access so that you will use the minimum of X-ray to be based on anatomic benchmarks of human body. Of course, you need to be intuitively from microsurgery to endosurgery access. Thank you so much for your kind attention. And there will be a lot of questions. Thank you so much for your interesting report, because you know each, I would say, school has a lot of, I would say, their own priorities and advantages. You are closely cooperating with our friends from Novosibirsk, and for them transforaminal access is, I would say, top priority. Just one thing which I would like to tell you, Europe is working on LD, but our Asian school works intralaminary, and we are doing like PCLD. So intralaminar access, it gives you a broader, I would say, scope of opportunities comparing to transforaminal one, which is more limited in terms of many parameters, and around 50% of degenerative disease are made of stenosis. So and transforaminal access is not the way to help in case of stenosis. There's the only option is intralaminar access. Therefore, intralaminar access is quite widely used in Uzbekistan. Also, we are based on the PCLD techniques, and Asian school by Dr. Lim is also mostly focused on intralaminar approach, and even US school is now developing, and Professor Lim and his, I would say, scholars, apprentices are also guided by PCLD technique, and actually our conference actually is to reach certain consensus in which areas and in which cases which methods would be more feasible to apply. I do not want to get into argument with you, sir. Just one example which I would like to draw you here, that in China they have told you that they have conducted transforaminal surgeries, I mean the number, they reached the number of the other surgeries in other techniques. So we have our guest from Cambodia, Hoi Plerom, please, sir.
Okay. Good morning, everyone.
Добрый день.
I'm from Cambodia. It's my flat. Today it's my great honor. So I would like to speak in English. I cannot speak Russian and Uzbek. Sorry. It's Cambodia. It's here in Uzbekistan here. So if you want to go to Cambodia, maybe you have to spend 2 months for walking, but I don't recommend you to walk. You can go by fly, even though it doesn't have a direct flight. Here is Angkor Wat Temple in Cambodia. You see, it's one of 7 wonders in the world. It's a beautiful temple. It's more than 1,000 years old. And we have a lot of temples in my country. It's also beautiful. And maybe you spend 1 week to see the temple. So after a long journey, and I also have my journey with endoscopic spine surgery. In 2020, I started to use MED, microendoscopic discectomy, and also in 2023, from May, I start to do PSLD, and also the same time in 2023, I also perform UBE. So in my case, I collect from May to January 24, I did 92 cases of PSLD and 42 or 43 cases of UBE. Here is my journey. From July 2020, I did MED. I performed 2 level for 1 skin pod for MED, and also in 2023, from at May, I also performed PSLD. I use jumping technique, 3 level decompression with 1 skin pod. It's a jumping technique of Professor Lim. And here is what I set up in my condition. As you know, Cambodia is not a rich country, it's a developing country. I perform without pump. I just use the continuous gravity flow. So I use the IV tube, and also here's my setup in operation room. I am a left hand surgeon, so for me, it's not for me only, but if you right hand surgeon, maybe change a position a little bit. But for me, if I stay on the left side of the patient, maybe the monitoring video maybe at about the patient. So everything is beside to another side from surgeon. It's what my style. Sorry. And here is the picture of after I already set up. So in my endoscope spine surgery, I do for lumbar this hernia, lumbar canal stenosis, lumbar spondylolisthesis, and also fracture osteoporosis, and also thoracic flavum ligament ossification. And during 92 cases, I also have some complication during operation and after operation. The bleeding is more common during operation. Dura tearing, and I have several dura tearing, neuropraxia transitional, and also incomplete decompression, hematoma, and early recurrent. So for 92 patients, it's I have 46 male and 46 female. It coincident. So the sex of my patient is older, it 17 age, and the youngest is 19. So this is the level of my study. I have L4 and L5. One level is 35 case, and 3 level it's also mostly it 13 case. And also I have 1 case of compression fracture of osteoporosis. So this is my period duration of operation. For 1 level, I spend 82 minutes, and 3 level is 203 minutes. I remember when I start the first case, 1 level, I spent nearly 2 hours. It's too much time. And this is hospitalization. Mostly patients stay 3 days, but average of the patient include all the complication patient or anything, it's 4 day minimum, mediums, sorry. So here is my complication when I meet during 92 cases. I have 8 patients, it's equal 7 patients of dura tearing, and 2 recurrent, 1 neuropraxia. Here is the video of decompression. I can do decompression bilateral with 1 skin pod. And also I perform discectomy. Okay, it's a huge this hernia, and also discectomy. It's very thick, so I try to remove many times. And it is my complication for my patient. It's dura tear. You see nerve root. It's come outside the dura. And here also, sorry for the blur vision. You see, it's the whole of dura. And here also, it a huge dura tear. I remember this case I make a diarrhea at nearly 1 centimeter of diarrhea. And also the diarrhea at the lateral side of the diarrhea. And here also it huge. Oh, sorry for the quality of the image. But you see the nerve root try to pull out. So I try to manage the nerve root also. Here is my opinion. I mean, for endoscope spine surgery, PSLD is not a big deal for young spine surgeon. You try to learning curve of the endoscope spine, so it make you more comfortable and you can do it. But the important thing is you have to make a right diagnosis and make a right decision of indication. It's important. So endoscope spine, it's also the gold standard of spine treatment for spine degenerative because it has small skin incision, clear operation view. It looks like we go inside the spinal canal of the patient. And less pain. One day after operation, the patient can wake up and walk very well. I have patient that I do two-level decompression, just only 5 days. He is a driver, so he go back to work only 5 days. When I call him, okay, you have a appointment day. So he said, oh, I take my customer to province. 100 kilometer driving is not a big problem for them. And fast recover, preserve the stability. After I did PSLD, the case of PLIF or fusion case in my hospital is decreased because grade 1 of listhesis I rarely do stabilize. I just do PSLD. It's enough for the patient, even though patient overweight. And short hospitalization. At least 3 days for my study, but 4 day average because of the complication patient, but at least 3 days the patient will leave home in my hospital. Yeah. Here, after I performed last year, May, so my colleague in my hospital, I have 9 colleagues in my hospital, they also can perform. We can do all together. So it means not only me, it means not only the old spine surgeon, just young spine surgeon, they can learning curve and practice, so they can did very well. But important thing, as I told, it's right diagnosis, right indication. It's very important. So here is my hospital. It's we call Khmer Soviet Friendship Hospital. It was built by Soviet Union since last 60 years ago. So thank you so much for your pay attention.
Thank you very much for your interesting presentation.
Yes.
Доктор Пернес, спасибо вам за то, что издалека приехали к нам.
Thank you so much, sir, for coming from such a faraway place to here. And of course, we have heard that in Cambodia, spinal endoscopic surgery is on rise, and we do hope that together we can reach better results. And now we would like to give the floor to our colleague from Uzbekistan, from Prof Med Service Clinic. Please, Mr. Kandimov, floor is yours.
10 минут максимум.
10 minutes, colleagues, not more. Please do not exceed your time limits. We are not meeting our time schedule. Please let us keep with the time frame.
Assalomu alaykum, hurmatli ustozlar.
Dear colleagues, good afternoon. Dear my mentors, it is my pleasure to be here with you. And well, I would like to discuss our experience of PSLD in lateral herniation of cervical spine. We are well aware that according to the major standards of treatment of cervical herniations, we are mostly based on ACDF methods, which proved its efficiency, but together with its efficiency, it is also conjuncted with potential risks of vascular plexion, esophagus injuries, and pseudoarthrosis development, as well as adjustment segment disease development. And we are really aware that the only alternative way in terms of lateral herniations of cervical spine is a posterior foraminectomy, and we are well aware that we can, due to the development of new technologies and methods, we can employ endoscopic methods for cervical spine. And if we will look through the medical publication in cervical spine, in recent 7-8 years, we have over dozens of publications which highlight interest towards this topic, and you can see that the clinical results on backside decompression under lateral decompression is equal to ACDF, and we have no accompanying traumatization and hospitalization of the patient. And here you can see posterior lateral or foraminal disc herniation patients associated with foraminal stenosis or facet joint cysts, and sometimes it might be a residual radicular syndromes after ACDF. So all of them are related to instability of segment and kyphotic deformation in cervical spine. And in case of axial pain in cervical spine, we are using the PSLD methods for the surgery. We are using endoscopic 5-7 millimeters working channel, and outside the channel, outer channel is 8 millimeter, quite a simple Kerrison punch and hook and dissector. So in our clinic, you can see since January 2021 to December 2022, we have conducted 44 of such surgeries on herniations of foraminal stenosis in cervical spine, and you can see the demographical data. And also, I would like to share some cases from our practice. You can see the 37 years old male patient who was complaining to severe pain right side, and according to VAC score, it was 8-9 points, and also numbness as well as weakness, especially in terms of a flexion of his joints, hand joints, and while preparing him for surgery, if we are placing them in prone position, we are using so-called Manfield's frame to fix patient's head. And talking about level marking, we are doing in right lateral position, and we are instead of, I would say, medial line, and also at the place of meeting of these two vertebral arc. I mean, would it be anterior, posterior, or lateral disc position? So how we are planning to, I would say, target this V point. We are trying not to diverse both medially or laterally. And we have found the V point, so we are starting decompression from upper positioned lamina. Then we are removing ligamentum flavia. We are identifying the root and the lateral margin of a dural sac. We are identifying location of sequester. We are removing it, and sequester is, you can see, released using hook. You can see the location of sequester. And post-operative pain. Here, the patient was fully recovered from post-operative pain, and weakness was resolved in 3 months after neurotropic therapy. And the second case, which you would like to draw your attention to, female patient, 54-year-old. She had two-level problems. It was a C7, C6, and C7, TH1. It was a soft herniation. So we have been using the sliding technique, and this technique, I mean, we had used the one entry point for decompression at both levels. And you can see one level, and this is the upper level, which is now shown on screen.
МСКТ после операции.
So this is after the operation. You can see at the high level we have been doing this operation to conduct the decompression at a higher level. So also based on the international literature review and based on our own practice, we do think that the PSLD methods is PSCD methods is quite safe methods and quite a good alternative to AC ACDF, and it has some advantages over ACDF in terms of small invasiveness. I would like to express my sincere gratitude to Professor Lim Kantek and Professor Shatur Suna for their kind support and for mentoring us. Thank you so much for your kind attention. Yes, indeed. Thank you so much for your very interesting presentation. And now I would like to give the floor to our speaker from India, please, Sir Tejasvi Vadiamani. Thank you so much. We would like to call you on stage. Thank you so much for your visit.
A very good afternoon to the respected dignitaries, my colleagues and my friends out here. So I am Dr. Tejasvi Vadlamani, consultant neurosurgeon from Hyderabad, India. I first of all would like to thank the organizing committee for having me invited here and arranging a talk. So I would like to talk about my journey of first 5 cases in PSLD. I had taken training in the field of PSLD from Dr. Sai Dilip in Visakhapatnam, India. Which was in June of 2023. Following that, in the last 8 months, I have done over 46 cases in PSLD itself. So the journey is not a very simple journey. It is getting converted from a hand combat to becoming a sniper as such. So initially, I used to do open surgeries. Following that, I did very few tubular retractor system and microdiscectomies. And from there to journey of using fully endoscopic in the approach of PSLD was not an easy journey. So what are the requirements before going to start a PSLD? We should obviously know the basics and anatomy, which will be easier for a person who does open surgery because there is no significant difference in anatomy as compared to a transforaminal endoscopic surgery. We need a good mentor definitely from whom we can pick up the endoscopic view of approaching a PSLD. Reading the images and planning as already highlighted by my preceding speakers, especially Dr. Temur, it was really good, sir. So my work is reduced here. I will directly go to the rest of the talk. So procurement of instruments. Initial few cases, 4 to 5 cases, I had used the instruments which were sponsored from company, but later I tried to procure my own instruments because you need to have your own armamentarium to become a sniper ultimately. So we also need to train our anesthetist as well as the OR staff and the circulating staff so that they get adapted from open spine surgery to endoscopic spine surgery. This, according to me, is the most crucial aspect of transformation. And finally, are you there? Well, let me describe through my journey. So case 1, the result was oops. So why was this? I took a case of L45 stenosis, which Dr. Temur said is not the right case to choose, but because I had no proper equipment and I had no good cases in the first 2 months, I was really frustrated and I just wanted to go in and explore the endoscopic journey. So I did not have a good sequestrated disc or a extruded disc, so I took up a case of L45 stenosis. The anesthetist was unhappy because he did not expect the surgery would go on for 3.5 hours. What went wrong? So I did not take enough time to talk to my anesthetist and my OR staff about the what are the things that happen in an endoscopic spine surgery. I just told them that we are doing an endoscopic spine surgery and they thought it is just as simple as an open spine surgery, a 1-hour procedure. So the assistant had absolutely no clue what step is coming next. And the circulating is tired of getting so many NS bottles. We use 3-liter NS bottles in our OR. So the first case took around 14 NS bottles and he was tired of getting them again and again. So this is what happened. So I think the problem was from my side. There was no good communication with my anesthetist and OR staff. So overall experience after first case, I was pretty happy because I completed the surgery. The OR staff were feeling like we don't want another surgery like this. Open feels much better. The patient was very happy. So this is what motivates us to go on to the next case. And definitely Rome was not built in a day. So I had no problem in taking up another case. But this time, what next? I had got a separate OT person who assists me for endospine. I took some time in training him to understand all the endospine equipments, what are the steps of going through in a PSLD case, And then, I also taught him about sterilization as well as cleaning of the equipment, which is also very important if you own a system of your own. So next, I showed him the surgery videos as well so that he can get an orientation of what comes next. And then I took some time to, inform the anesthetist also, like what are the ways of giving the anesthesia. Definitely my first 13, 14 cases were all under GA because, the time factor, even I was not sure how much long I am going to take for the surgery to complete. And also I took feedback from my mentors time to time to, in order to take nuances about improving the duration of surgery and, getting things to work. Second case, I thought we are all set. It was a simple case of L5S1 PIVD, no bone work. It took 2.5 hours, of course, because I am a slow surgeon, definitely. It was a decent work. I used only 6 to 7 NS bottles. The circulating is quite happy. The assistance was pretty good. I don't say it was excellent, but it was much better than the first case. The anesthetist definitely was interested in taking up the third case now. But the problem was that the screen that was available in the OT, it was a pretty decent screen, but it got blurred after 1.5 hours, 1.5 hours of, going ahead with the surgery, and I experienced a lot of fogging. So what next? It's the same repeat. So I went back to my mentor, I had a call with him, and then he gave me some suggestions about maintaining the temperature of the saline and, proper draping of the scope in order to reduce fogging in the next case. The recording in my first few cases was over phone, but later I had ordered an HD endoscopic system with a camera and light source of its own. And from then on, my recording and the video outcome was also pretty good. So case 3, 4, 5, roughly I took around 2 hours for a single level work. The assistant gets smarter and stronger with each case. This makes my work pretty fast and easy. The anesthetist is very happy. And after taking around 12 to 13 cases, we started doing high-risk cases, especially elderly with stenosis under epidural analgesia from case 14 onwards. And we thought, and I attended conferences and CMEs from time to time so that, I can get more equipments which are like customized for my personal use. So this is the set I maintain. I think Dr. Temur had given a good demo of all these things, and this is how we autoclave. I keep a cushion in the bottom of this because I carry these instruments in my car, so I don't want them to get damaged. So this is the sort of cushion I maintain, and it is autoclave safe. These are the instruments. I guess all these instruments were already described, but this is my personal favorite. This is an angulotome, just like a 15 number or 11 number blade you use in your open surgery. This is an angulotome, and in my video I will show you how it is being used. So this was the first case I took up. This is a case of critical L4-5 stenosis in a 45-year hard-working male. He had no comorbidities and had severe claudication pain with a claudication distance of less than 100 meters. So this was the end point of decompression. It took me 3.5 hours, and this was shot on a mobile phone. So I don't think the video clarity is so good, but yes, that is the cranial end. I was on the left side of the patient. This is towards the left side of the patient, going through the foramen, checking the patency of the foramen there. The foramen seemed to be free. And this is the caudal end. Now going to the contralateral foramen there. So cranial to caudal, the thecal sac is looking free, and bilateral foramen had been free. That is the contralateral root there. So this patient was quite happy. 80% of the pain reduced the next day, and subsequently he was pain free in the next 1 month follow-up. So this was my fourth case where I attempted a 2-level stenosis with left more than right foraminal stenosis in a 65-year-old elderly 140 kilo obese female. So these were the results. The first is an L4-5, end of decompression at the level of L4-5. Again, standing on the left side of the patient. 9 o'clock is cranial, 3 o'clock is caudal. So this is the root, and you can clearly see the axilla and shoulder there. The axillary pad of fat being seen there. Checking the contralateral side. So this is the L4-5. End of decompression at L4-5, and this is at L5S1. In this case, I used 2 separate incisions because it was a fat lady, and I probably felt that the jumping technique may not work well in her. So this is the end of decompression at L5S1. Now this is my 5th case where I had a young male with L5S1 extruded disc with severe left radiculopathy symptoms. So the root retractor has been in place, and this is the root which has been retracted, and this is my favorite instrument, the annulotome, with which after using an RF I make incision in the annulus, and you can see that the disc is coming out under pressure. So after making a good wide annulotomy, the disc fragment itself is popping out because of the intradiscal pressure. So you can see the recording is getting better here because of the 4K endoscope with the self-recording system. Taking out the fragment. It was a huge chunk and the chap had a good relief in pain. So what was the experience like? It takes great effort, not just from the surgeon's side, but also from the entire team to accept, especially for the anesthetist as well as the OR staff. So it is always better to have a separate person who has training in spinal endoscopy, especially PSLD, so that he can not only assist you well, but also take care of your instruments in the post-op period. We need to show the results to keep the team motivated. So what I used to do was that initial 1, 2, 3 cases, I used to take the videos, share in the group of the hospital so that, the anesthetist as well as the OR staff were quite motivated, show the size of the incision. And now I have my OR staff attenders and their relatives itself coming to me for PSLD surgeries. Separate scrub person, I already mentioned. Inform the anesthetist and OR staff about the procedure and preparing them. Good preparation of the entire team is must, especially in the first few surgeries. Once the team is all prepared, the next case you need not inform anything. They just ask simply you want a GA or a epidural analgesia. And a good mentor for constant support. I would like to thank Dr. Sai Dilip for always being a call away for helping me and giving me continuous guidance. So what are the lessons learned in the initial few cases? It takes some time and a lot of hard work and perseverance especially to adapt for endospine surgeries. We need to choose the right patients initially, which was a mistake I have done, and now I am more choosy about my patients because we need to show results and that is what motivates us. And we also need to have right people at work. Instruments, I don't think we all need to have a good company instruments. We need to have a good scope initially and decent instruments that work well. Later on, once your numbers increase, you can buy all good equipment. Regular mentor feedback is the most important aspect of the entire journey. Regular updates and conferences, the annulotome that I purchased. So these type of instruments are available and you can get updates about the techniques from conferences, and these things keep you updated and you can do next surgery better than the previous surgery. A satisfied patient always motivates you to do more, and we have to offer them the best. Every case teaches you more. I am still learning. To date, I have done 46 cases of PSLD and I think it's a very small number. I am just waiting for my next case to teach more rather than looking back and understand what mistakes I have done. And this will never be an ending process. The process of learning is constant. So thank you for your attention, and I would like to thank Dr. Lim for motivating an entire army of young neurosurgeons and spine surgeons to take up the field of spine endoscopy. And to the right is my personal mentor in PSLD, Dr. Sai Dilip. Thank you for your attention.
Thank you very much for your interesting presentation. Я хочу сказать, из Индии.
Well, I would like to mention that from India we have quite a huge delegation, and we closely cooperate with them. And in 2017, 2018, we started proactive cooperation with the Indian surgeons, and we had a lot of transforaminal surgeries in 2017, 2018. So I would like to wish you, dear Indian counterparts, colleagues.
Следующий у нас доклад из Российской Федерации, доктор Малахов.
We would like to give the floor to Dr. Malachov from Russian Federation.
Уважаемые коллеги,
dear colleagues, dear esteemed chair, My report will be dedicated to biportal surgery as an option to treat the spinal restenosis after TPF. Well, you know that the number of people is growing who need spine surgeries. This issue is very relevant both in Europe and Asia. And of course, they require minimal invasive methods. And we are using these TPF methods because we are facing listhesis and other pathologies which require fixing system. But these patients within 3 months to 10 years are coming with recurrent syndromes that they're facing new symptoms of stenosis of the spinal canal. So in case of 10 years follow-up, they come to meet and come across these stenosis, restenosis. So in case of predictors of unfavorable stenosis and recurrent stenosis, these patients are also 70 plus years. They had other surgeries. So you can see now the, I would say, conventional wisdom. We have embraced 14 patients who underwent TPF, and all of them faced recurrent stenosis higher than operational level. And after TPF at 3, 4, 5 level, our patient faced the L2, L3 stenosis, and she couldn't walk more than 50 meters. And when we have checked, the heads of screw is located at the level of stenosis, and the distance is less than 6 millimeters. So we have been starting discussions on treatment this category of systems. So we were trying to prolong these, for example, screws, but the key issue is that they're having a lot of comorbidities. They are obese patients, so of course it complicates the treatment. So you can see that all of these screws are locating at the stenosis level. So what is specific about this? We cannot use monoportal systems because I mean, we might have a biportal systems, and so we were trying to find the port for endoscope and port for the tools, and what we are coming across. You can see when we have been using these biportal systems, it will help us to clearly visualize the problem. We will now show you the video that after installation of screw, we are facing restenosis. And our patient underwent surgery several years ago. And at this video, we can clearly see the location of screw at the surgery intervention area. When you are using monoportal system, you might face the problem because they might limit your surgery area, and you can use radiofrequency ablator to remove soft tissues, and it will enable you to remove with no risk, I would say, excessive soft tissue.
Что еще? После завершения этапа
So, as biportal decompression is finalized, we easily visualize lateral margin of roots at TL1, L2. We are facing these screws, and we cannot use monoportal system, but if you are going for a B portal access, you can easily visualize dural sac and lateral margin of roots, and it means that your surgery will be conducted successfully. What about the result? The patients with various multi-lasers have underwent the surgery. We have been selecting the portal system, which enabled us to reach the screw from up and downside. We face no issues or complications while using decompression. We face no conflict of tools, and once again they are obese, diabetes mellitus, arterial pressure, and of course the comorbidities, the age of patients. So the technique especially good for them to improve their quality of life. So, dear colleagues, thank you so much for your kind attention. Yes, thank you so much, Mr. Malakhov. Indeed, you have raised very important issue to the floor. In our country, in our practice, we also have patients whom we need to stabilize, and of course, whom we need to find some endoscopic recurrent surgery. And we have a lot, I guess around 20% with TPF, and we are trying to find a good results to treat them, and it's quite nice seems. So we will have, I guess, next speech by Dr. Chicherina. Yes, please, we will give you the floor. I mean, out of the order. If I have managed to cope with endoscopy, probably I will cope with connecting my equipment.
Приветствую вас, друзья.
Dear colleagues, I would like to welcome all of you. It's my pleasure to see all of you here. Thank you so much for your invitation. I would like to share my experience in endoscopic surgery. I am a traumatologist, orthopedist. I'm under the Mr. Yumashev school. And in 2016, I came to know what endoscopic surgeries on spine are, and I would like to show you some interesting cases which can be taken into account for, I would say, young patients. And actually, we have been discussing both bars, biportal, transpedicular, translaminar, intralaminar, foraminal access. But anyway, dear guests, let us start. And from the very start, I have started with a TESIS methodic, and this technique actually is dedicated for foraminal herniations of discs, but I came to understand that there's no difference actually for me where this herniation will be located. Would it be extra paraforaminal, extra foraminal, or anywhere it might be located? I'm not now promoting certain types of access. You need to know how to conduct both intralaminar and transforaminal access and the B-portal access. You need to know how to conduct each type of surgeries. You will have to learn everything from A to Z. Then you can judge whether it is suitable or not in each particular case. So talking about recurrent herniations, we had microdiscectomy surgery, things were quite fine, but in 2 years, the patient once again approached us and he was complaining about recurrent herniation. And of course, as a surgeon, I can tell you that it is not that easy, of course. And but anyway, this is our patient before surgery. You can see that the quality of life deteriorated. You can here assess the traumatization and what are the result. We are not facing any, I would say, scar. We easily reaching and right after surgery in several hours, our patient is happy. So hospitalization takes 16, 18 hours. We are doing surgery only for the patients who underwent outpatient treatment, who underwent all the lab tests, and the next day we are letting them out of the hospital. So you can see the MRI results before and after surgery. So you can remove herniation in any manner convenient to you. You can do it intralaminar, you can do it in any other manner. It depends on the preference of the surgeon. And after the surgery is done, I mean, I was completing surgery with sequester, but then I was very puzzled that the frequency of recurrent surgeries was growing and growing. So I was now checking this post-operational area and cleaning it, and you can see the final result. It helped me to reduce recurrence rate drastically, and you can see that this operational space is okay. So the patient before operation, he couldn't literally walk. And in several hours after operation, now our patient is easily walking. So the patient flew from Irkutsk. It's quite like far away located from Moscow. So he can easily move, he can easily sit, he can easily walk. So this is quite interesting case. This is the patient with Parkinson disease. He had 2 surgeries in Germany. Then for L4, L5, they had X-leaf and 4 screws, but he faced the issues, and we would like to show you the pictures now. So this is a sequester herniation with a caudal migration of the disc, and this is the way we fix the screw, and you can easily see that they have been incorrectly installed, but the patient was unhappy with his right leg, not with his left leg, and he faced the problem with the right side movement. So these are the screws installed. Twice in 6 months he underwent the surgery, and then for the 3rd time he reached us. He is the patient with Parkinson disease. And what was our opinion? Or we should, I would say, dismantle and reinstall it. But I decided to take a risk, and I decided to do it transforaminally. You can see our microsurgery equipment. It is located in this herniation area. Well, it is not easy. It can no. If any of these screws are not interfering, you can easily reach the point of your destination. But you can see that I'm trying to finalize this surgery with pincers, and you can see what is the car, and the patient easily moving, and he's quite happy. You can see it's like totally different person now. And I'm personally feeling that for the patient with Parkinson disease, it is better to do it not sagittally, but do it in endoscopic manner. And here, this is unique case. It's not just the localization of disc, but please look at this girl. She's pregnant, and we have a baby inside, and she cannot resist the pain. And so she's using dexamethasone and promedol, and she cannot resist, and she was waiting for this baby for too long, but now they were proposing her, the doctors, to go for abortion as an option. And colleagues were telling like, you were not thinking about your fetus, and we have decided to go for X-ray rather than to go for abortion. And she's now very happy. So next time, hopefully when we will meet, I will show you your picture with your child. And now let me show you now this thoracic spine. We do not have so much who is doing it intralaminary. I can tell you that I'm not the one who know how to do it. And sometimes we are having it transforaminally up to 6 centimeters. We can easily do it. And we are coming to each of these layers of access step by steps. And our disc is at 6 hours position. And now we are facing issues with drainage. We have added pressure. Now the calculation will take place, and we will clearly see, we will have a better view. And now it's quite comfortable for us. You can see the results after the surgery. And we are, you can probably easily see that all of these herniations are calcified. They're not soft tissues. And I will not claim that the patient jumped right after the surgery and being very happy. It is not true, of course, but in 1 month she came with crustals for follow-up check, and I'm very satisfied with your result. You can see before and after pictures to compare. And the stenosis of spinal cord, the only way is to do it intralaminary by uniportal surgery. And I'm not, I would say, the magician. I'm just learning how to make miracles happen. So you can see that we are, first of all, identifying these two roots, and we are coming for resection. And of course, after decompression, you can see that the entry point is just 1 centimeter. It is not more than 1 centimeter. And also we have been in Bukhara, and And I am very happy to know that this year we have a lot of, I would say, a lot of reports on cervical spine surgeries. It's very good, really. So it doesn't repair, I mean, it doesn't repair what we are happening. So we need to also help to our soldiers. I mean, the reality is so I would like to share the a case with trauma of combat trauma of first and second cervical spine. 1.5 hours after the combat trauma, he was taken to our hospital, and there were some other options, and I decided to, go cranially because this is the right way. Since surgery is conducted in, I would say, a water environment, and we had no necrotized. Well, I have been using the equipment, and look at this. We couldn't take it through the port. So also you can see the combat trauma, and it was not such a major injury, but anyway, we have tried, and we had no spinal cord trauma, but still the vertebra channel was decided, and I also went using this injury channel. And now you can see that we are using this wound channel. In this part, I'm using a delta for this surgery. Also, I'm going right to the wound channel.
Тоже хорошо заживает.
Yes, and by the way, let me tell you that it will, I mean, the patient in 3 days will get better. I mean, that as a concluding remark, of course, we cannot embrace all the issues within like 10 minutes speech, but I can tell you that we have the schools, medical schools, which are promoting interlaminar or transforaminal surgeries. Some are talking about sagittal balance and the TPF, but I do not know. I mean, no one was even could have even imagined that I will be dealing with endoscoping spine surgeries, but all the methods, I mean, up to our selections for what we can use, in future. So I can easily see a lot of doctors who are having pragmatic approach, who are having warm hands and burning heart to save their patients. Let us proceed in doing our good job, keep up with the good job. And I am very happy that I came here and that I have a lot of I came to meet a lot of people, and I'm learning from each of you. Thank you so much. May you stay in solid health. Thank you so much, dear Professor Malahov. Wonderful speech. Sorry, I'm Sechennik. I'm very sorry. But am I right to hear that you're from Yumasha's chair? Yes, I am thinking that I'm representing Yumasha's school. Well, and Well, I have been doing my PhD at the first university, and when I was doing my PhD on ossification of a posterior longitudinal ligament of cervical spine, and I was the first one who came up with the stenosis idea. And for this, I was actually, with this idea, I was eliminated from the PhD studies. And in 3 months, I have explained it to my to Professor Yumashev, and I came that in the library named after Lenin. I came up with, I mean, I have managed to find the instructions, and in this, their German orthopeds have explained the principles on using stenosis diagnostic. So I have managed to do my PhD. So it was my pleasure to hear you, you, and to know that you're representing this school. Greeting you, and hopefully we will meet you. And please come to our country more and more. And talking about endoscopic technologies, it's a new, totally, absolutely new direction in using in surgery. So we should not forget our history. So to resolve such, I would say, minor issues, minor, I would say, malignancies, for us to find these small, I would say, pieces, we have been managing to, I would say, unfortunately, we had no option but to doing open access, and that's it. So I can tell you that here we in this room now everyone is discussing about endoscopic trends, but some of us have already managed, and they are, I would say, the guys behind this method. And also I can tell you that some issues might be caused by stenosis or by anatomical disturbances, which might cause the issues of issues, or I would say these disturbances. And we have some other also issues, and I can tell you that it will give you a transforaminal access. And we have people here who have already mastered this method. They think that there's no actually priority directions, but and all of the methods are quite good when you have professionals who are mastering, say, excellent. So I'm wishing the successes to all of our endoscopists, surgeons, who are coming with their advices how to resolve the consequences of osteochondrosis. Previously, it was called the degenerative dystrophic lesion of spine. But anyway, I can tell you that it will not change, but I think that the key reason is that it might be a pressure on the spinal cord. So I'm thankful to all of you, and we will be awaiting for new achievements in this area. So thank you so much. And now we would like to give the floor to representative of Kyrgyzstan, Shavurov Bekbolat, please. Our colleagues from Kyrgyzstan, our friends, I would say, please.
Здравствуйте, уважаемые коллеги.
Dear colleagues, good afternoon, my dear mentor, dear organizing committee. I would like to express my sincere gratitude for giving me the floor at such an interesting international conference. I would like to deliver my speech in Russian. Well, my speech will refer to endoscopic surgery in Kyrgyzstan, historical aspects. Well as we are well aware, endoscopic spinal surgery started developing since 1983 when Parvez Kambin developed so-called the Kambin triangle, so-called safe access points, and starts his surgeries in 1990. Anthony Young under the irrigation started his transforaminal surgeries, and in 2000s, early 2000s, Sebastian Rutten from Germany started surgeries on spine using endoscopic technique by intralaminar access. And you can see that we are having intensive development of endoscopic spinal surgery development. We have uniportal, as you can see here, transforaminally and intralaminar access, and in decades we are having biportal methods, which are referred to different authors, and we have quite intensive competition in open spinal surgery. It was not easy to compete with surgeons who have 20 years of experience. So together with my colleague, I came to know that in Tashkent we are having endoscopic spinal surgeons, and we came to Tashkent and we came to meet Mr. Shomansurov and Mr. Yakubov, and we are taking part in surgery. We are learning more on endoscopic surgery based on PSLD methods, and we came to understand that this is very prospective direction for future. We are trying to learn, and we were seeking for permission to master our knowledge, and we were said, yes, come and learn more. So we underwent a training in ProfMed service clinics, and I would like to express my gratitude to the administration of ProfMed service clinic, because on daily basis they're having at least 5 surgeries, and we were puzzled that surgeries are conducted in 20-30 minutes, and the next day patient simply is standing, walking and sitting and facing no pain, prostop pain. It was not easy for us to start, and we have started endoscopic spinal surgery because we didn't have no tools, I would say, but we have managed to convince investors, and in September 2022 in Kyrgyzstan we have started endoscopic surgery based on PSLD methods under the mentorship of Professor Shotur Sunov, and this is our first surgery. And this is the first surgery with our mentor's participation. And you can easily see he supervising how we are using the tool, the appropriateness, and here you can see how we are trained step by step gradually. Here you can clearly see on the videos that we are learning how to use equipment, how can we use a carries and punch, how to manage ablator or scopes, how can we use these forceps. So the professor is here teaching us. And for several times, Mr. Yakubov visited us to conduct master classes and trainings. So you can clearly see in master classes, trainings. So they were trying to share their knowledge, to teach us whatever they know, so that we will not face any complications or mistakes. And moreover, Professor Tursunov actually he helped us to ensure influx of patients to our clinic. And according to the statistics, degenerative lesions of vertebra in Kyrgyzstan since 2010-2015 were encountered in over 19,000 of patients, which means we have around 3,000 of patients annually. And according to the statistics and graph, you can see that we are having the patients starting from 30 to 40 years, but the patients are getting younger. And I would like to share my clinical cases. Male 90 77. You can see that he has a herniation L4 L5, and also the CT scan was taken in 4 days after the operation, and we had the second operation after 8 hours after the surgery was conducted. And you can see that he has lesions, he has monoparesis, and he incontinence, and he faced no symptoms and issues. And the same thing you can see in 6 months. I have tried the MRI from different periods of time. So this is MRI in 1 month after herniation was removed. You can see the root. I'm trying now to remove the herniation. So you can see what we have removed, and you can see the results of the surgery. So according to my statistics, we had less males rather than females, and we had over 247 patients, and 45% of patients were male, and remaining were females. And you can see the disbursement according to the levels and the lesions. In 2023, we went to South Korea to meet Professor Lim, and we have learned how to make surgery for stenosis. And since 2022, we had over 247 surgeries. 80% of them were surgeries for herniation. In most of cases, complications were for dural sac injuries, but in most of cases, it's not complication. In most of cases, they were not meeting up the regime, not compliant with the regime. So we think that the endoscopic surgeries are the most prospective and ways of treatment, and it will, of course, require further cooperation with our colleague from the other countries to master our excellence. Thank you so much for your presentation. I also would like to mention that indeed in your country, people are proactively engaged in spinal endoscopic, and we are very happy to have our colleagues as Mr. Saburbek, but they are the representative of older generation of spinal surgeries who are more fond of open access surgeries. They are not, I would say, that the bigger surgeons make a bigger incisions, and the younger generation like you are working on a small incision. So we would like to wish you successes in your endeavors and hope that spinal endoscopic surgeries will be efficiently developed in Kyrgyzstan. Now we would like to give the floor to our last speaker. Before we will go to lunch, please, Sherali Begzot from Uzbekistan.
Будущее бухарской школы эндоскопистов, да?
So this is the future, I would say, forthcoming, yet to be developed, Bukhara School of Endoscopic Surgeons. Good afternoon, dear colleagues, dear participants of today's event. So I will be deliver my speech in Uzbek. So we will be discussing endoscopic surgeries and of course indication and counterindication to endoscopic surgeries. In case of before I will dive into contraindication and indications for endoscopic surgeries on spinal cord. First of all, let me mention that in coming 20 years, these surgeries are improving, the techniques are improving, and new methods are developed, and it helps us to reduce the hospital stay period, and they are less invasive procedures with less risk of infection, as well as opportunities to use local and epidural anesthesia. And talking about endoscopic surgeries on spinal endoscopic surgeons, it can be accomplished by two ways of access. As I have already mentioned, we can do it transforaminary or intralaminary. So, and in our surgery, in our clinic, we are both based on intralaminar access, and recently in my, I would say, practical in my practical assistant, intralaminar access gives a better access and better opportunities comparing to transforaminal access. And we can also see it, I witness it on MRI scans of our patient, and in intralaminar access, when you're conducting surgery, it becomes more and more popular recently. And transforaminal access, well, it has its own, I would say, positive and negative points, shortcomings. But anyway, talking about the stenosis of a central channel, of course, there might be a stenosis of a channel, and moreover, we can have stenosis in two segments. Therefore, interlaminar access is more feasible to use, in my opinion. So, talking about this treatment of herniation of a spinal cord, it is performed in the same order as open access surgeries, and we are doing for sequester, we are doing for conservative treatment. I mean, if the patients fail to obtain any results under the conservative treatment, then this is one of the indication to go for this. And talking about the disc, I mean the herniations, you can see there are quite big amount of big number of, I would say, contraindications for this. And we are, I mean, if we fail to achieve any result in conservative treatment, then of course the only option for us sometimes is to go for open access, even surgery, not for endoscopic one. And the last thing which I would like to mention is, of course, fusion and spondylocystitis. So if you when it might postpone the surgery or be a contraindication for endoscopic surgeries. So this is the way for us to deal. And sometimes there might be, I would say, herniation. In the place of herniation, there might be inflammatory disease. And we have faced, unfortunately, this situation in our practice. And talking also, there might be some malignancies of the place of the herniation location. Sometimes there might be some other contraindications like anemia and etc. And talking about spondylolisthesis, it is also very important. And so in case of these regimes are, I would say, mutually conforming each other, we can
Bu aktif fazada mı yoki pasif fazada? Agar aktif fazani analizlar tasdiqlasa, endoskopik ameliyot bajara olmaymiz. Spondylolisthesis ikkinchi kartinada.
And you look at the second picture. We are facing a 5 mm displacement. This the only way is to have open access and TPF technique use. And of course, there might be some contraindications. So there might be some problems of endoscopic practice. How can, I mean, what factors can temporarily impact and postpone the surgery? For example, due to the chronic pain, and patients have been using a lot of anticoagulants or strong painkillers, and so we cannot, I mean, we had no option but to postpone it. And sometimes we cannot clearly see the respective organs, and before the results of coagulogram will show us the better results, a better view, the menstruation period, and number, I mean, the amount of hemoglobin, and of course, is in case of no thrombosis revealed in legs of the patient. So these are the standards for our patients. So we are testing it, and in case
orada.
risks of thrombosis is revealed, then we can proceed with the operation in case if conservative treatment failed.
Bu vaqtincha
So this is a temporary, I would say, surgery, but the factors which I have mentioned, they are hindering only on temporary basis from conducting surgery. And talking about endoscopic interlaminar microdiscectomy, we have put in place these methods for 6 months. We are using it, and now we are working on endoscopic surgeries. Talking about endoscopic surgeries, we have already embraced 100 patients without surgeries, and we have achieved results. And talking about interlaminar microdiscectomy, we have managed to achieve sustainability of the patient's situation, patient state. And I would like to explain you that when we are reaching, when we are accessing, we are having 6 millimeters. You can see it, by the way, the 6 millimeters incision. And what shouldn't we do? You know that we are putting our cannula, and after cannula penetration, we are starting operation. And after the incision, before we will reach this interlaminar space, we have no chance, to do it. But anyway, before we will reach this interlaminar cavity, in order to expand it, therefore, after the surgery, when we are expanding icrolaminar space, we are having our ligamentum flavia, and we are having our dissectors. It will be, the incision will be 4.5 millimeters. So we are showing you the video from our surgeries. We had no actually problems in our patient. So our patient is a 72-year-old female, and one day after surgery, she went home. We let her out of the hospital, and talking about surgeries which was conducted here, we have placed everything on this slide for you to see, and you can see this sagittal incision. Then our patient within 1 day was resolved from all of the complications. And we had the MRI also checking, and you can see that it fully compressed the spine. And you can clearly see that we are having caudal sequestered herniation. So after the surgery, we are having the fibrosis, and you can clearly see that all of the, I would say, problems, all of the complaints were resolved. So thank you so much. Just one proposal. So, we should not showing the, I would say we need to show the endoscopic results which we are achieving with this surgery. So we are conducting surgery, you are conducting surgeries for 6 months. This is a period of time. So we are conducting these surgeries for years, for decades. Let you work on yourself, and then you will be able to show us what way is the better way to have a surgery conducted. Thank you so much. And also, that our program has ended plus 1 hour. Now we will go for lunch over here. If it's enough for 30 minutes, we will go, and we will proceed so that we will be able to meet it. 2:30 we will meet here.
better?
Yeah, right.
Are you having this? Yes?
Yes, yes. Here. Here.
Good afternoon, dear colleagues. You know that our afternoon session delayed, and I am opening the afternoon session. Also, there is some change in order of the speakers. First speaker, the topic is UBE, Extended Indications and Popularization, Dr. Yang Hee-sok, Korea. Please, doctor.
Thank you. Good afternoon. I'm Dr. Yang.
Уважаемые коллеги,
On the topic, UBE extended indications and popularization. Everyone is very familiar with the story of Columbus' egg. 1997, the paper Arthroscopic Microdiscectomy was published. The development of endoscopic surgery into full endoscopic surgery and bipedal endoscope surgery, I think, is similarly very innovative as Columbus' egg. Now, bipedal endoscope surgery can be seen frequently, but if you are curious about the beginning and the history in Korea, you may refer the section of brief history chapter in following textbook. Bibliometric analysis is a scientific computer-assisted review methodology that can identify core research or authors as well as their relationship in specific topic or field. In 2020, bibliometric analysis about the UBE were published, focusing on authors, major authors, and various topics. Even without such analysis, the numbers of papers and related topic provide strong evidence about today's topic, extended indication and popularization. Another important factor is the rapid development has placed past 3 years. Why? Or what is the reason for rapid development? I want to emphasize the learning curve and safety. First, look at the learning curve. I found 5 papers. 2019, lumbar decompressive laminectomy. 2020, interval diffusion. 2022, ULV discectomy. And 2023, posterior cervical laminectomy. And 2024, TLIP. All suggesting the learning curve is around 30 to 50. Everyone here may agree with these figures. And let's talk about the safety. No technique cannot be popularized if stable results are guaranteed. Initially, we can have some concerns how these techniques reliable, but with the experience that have make some assurance and accompanied with the literatures. 2020, there are some papers check the epidural pressure with several surgical contexts. They are emphasizing the importance of water pressure control and the use of cannula. In 2021, there was another paper. 2020 paper checked the epidural pressure at cervical level, and 2021 paper checked the epidural pressure in the surgical field, also emphasizing the importance of the use of cannula to maintain safe epidural pressure. And the 2023 paper discussed the safety use of radio frequency around neural structure. With a controlled condition, short duration, low power, good saline irrigation, we can have stable, safe surgery. Noting that care must be taken with using radio frequency because they make some injury. Let's talk about the extended indication, lumbar, thoracic, and cervical separately. With the previous slide, there are lots of numbers of papers published. They have some main theme like fusion, comparison study, systematic review, meta-analysis, and RCTs, expansion of techniques, complication, and errors. The extended indication could be categorized broadly with 3 points of view: approach, revision, fusion, bleeding control, complication management, and technical instrumental issues, and comparative meta-analysis RCT with scientific academic issues, and popularization and globalization. 2016 to 17, there are technical notes preliminary result about discectomy, recurrent disc herniation, and lumbar spinal stenosis. There are also technical report about lumbar interbody fusion. 2018 to 19, there are several contralateral, paraspinal, and various foraminal lesions, and some randomized comparative study and early RCT were published. 20 to 21, there are several basic researches, meta-analysis, systematic reviews, and some expansion to Asia and Europe. And there are also reports about the technical report emphasizing large cage during fusion. 20 to 23, it could be considered Renaissance period, regionally, technically, academically. Lots of papers published with comparative study, systematic analysis, and RCTs, and there are several technical attempts, such as expandable titanium cage, were reported. Let's move to indication for cervical and thoracic. There are also more papers published recently. 2017, the first paper published about the posterior percutaneous endoscopic cervical foraminotomy using UBE. And 2020, there are some papers, cervical inclinatory foraminotomy, that is placed opposite side. And 2021, there are some reports about cervical myelopathy using UBE. 2023, paper discussed about the learning curve about posterior cervical foraminotomy. They are suggesting around 20 cases. Also, sliding techniques, that is multi-level, can be operated with a single incision, and some attempt for high-level cervical as a C23 reported. And also, systematic reviews were reported, and some papers comparison with different techniques. 2024, there's some report about cervical open door laminoplasty with using UV technique for cervical spondylolytic myelopathy. For thoracic region, 2012-20, there's some paper about arthroscopic discectomy and interbody fusion about thoracic spine. They are presenting about cases during 1995 to 1998, but maybe this technique couldn't be popularized at that time. Then, 12-22, there are reports about the bipolar endoscopic decompression for ossification of a ligament problem, thoracic area. And 2023, some reports, including some cave-in decompression, that is some severe OPLI case. They approach 2 steps, make some approach and decompression like this. From 2023, there are several reports. They are showing a stable techniques for thoracic laminectomy for ossification of ligament problem. 2024 also, there are some reports about thoracic interbody fusion with the UV technique. This is my conclusion. For cervical and thoracic area, there could be some more cohort study and comparison study are needed. We are approaching golden age of UBE through extended indications and more popularization, globalization take place. Thank you for listening.
Thank you, Dr. Yandis. Excellent literature search. Is there anybody for asking question or contribution? Okay, but I have one question, please. Literature is okay, but I want to learn your experience also. What do you think about the extraforaminal herniations, and particularly for L5-S1 extraforaminal herniations for UB? Did you have any experience?
Yeah, sure. Extraforaminal region, L5-S1 is very unique because they have a long track compared to another level. Therefore, depending on pathology, we have to make some longer decompression is needed. For short region, we can approach with the full endoscope. But if there is some longer region needed for decompression, it could be more easier with biportal because we can change some angles and use some another instrument. Therefore, very difficult case for L5-S1 foraminal region, but we can choose some more easier or some proper techniques.
Thank you, Doctor. I would like to invite the second speaker, Dr. Gupta from India. The topic is Introduction and Nomenclature of Endoscopic Spine Surgery. Dr. Gupta, please.
Thank you. Respected chairpersons, teachers, dear friends and colleagues. So today we'll discuss about introduction and nomenclature of endoscopic spine surgery. Before I speak on the topic on introduction and evolution of spine surgery, let me tell you about myself and how I was introduced to the endoscopic spine surgery. I did the neurosurgery training under Professor Ramani and Professor Atul Goyal, where I was introduced to the open spine surgery. I was trained as an open spine surgeon, and soon my senior Dr. Sumit Pawar joined the institute back after learning the endoscopic spine surgery. He showed me and he paved the pathway to learn the endoscopic spine surgery. Then Professor Ramani sent me to do the fellowship in endoscopic spine surgery, and I started my career with the transforaminal endoscopic spine surgery. Soon I was lucky to be trained under Professor Lim, where I learned the versatility of the PSLD surgery, and I loved this technique so much. I came back to India, bought all stenoscope and started doing the surgeries. And Dr. Sai Dilip was quite humbled to give me the mentorship very closely in almost all the cases, in first few cases. And he visited my center, he taught me how to do it and do the micro level, little bit here and there issues, and improved in all my endoscopic spine surgeries. So let's talk about the topic back now. Traditional spine surgery used to address the spinal pathologies, but with the cost of collateral damage. As understanding of biomechanics of the spine increased with technological advancement, endoscopic force evolved and is now driven by the surgeons, patients, and healthcare economics industry, as it is less comorbid surgeries and faster recovery is there and shorter hospital stay was there. So how this endoscopic spine surgery evolved? The first Crows and Oppenheim first did the lumbar discectomy in 1908, but they had complications of CSF leakage and segmental instability. So era moved, Yassergill and Casper separately introduced the microsurgical approach, And soon it became the gold standard technique for the discectomy worldwide. Later, Camvin and Sampson in 1973 and Hijikata in 1975 introduced the posterolateral approach, where they used only fluoroscope and they did the discectomy through a cannula. So this is a Camvin triangle that we all know of, which is a safe working zone for the transfemoral surgeries. So 1983, Faust and Hostman, they first used the modified arthroscope to attempt the discectomy. Later in 1988, Camvin et al. Directly visualized the disc through using the endoscope. Hermentin compared the video-assisted arthroscopic microdiscectomy to traditional open microdiscectomy, and he found there was higher satisfaction rate among the patients, and there was short length of hospital stay and less narcotic use postoperatively. So in 1990, we all know Young first developed the fully functional endoscopic system that we call YES system, and he showed successful surgical outcomes in case of disc herniation. In the parallel time, Foley developed the tubular retractor and initiated the microendoscopic discectomy, which became quite popular as MIS technique. In 1996, D. Anthony et al. Introduced the biportal endoscopic spine surgery, which was widely accepted due to the familiar surgical view and allowing the surgeon free dexterity. So in 2006, interlaminar endoscopic lumbar decompression for L5S1, there were two groups of surgeons who did the studies from Korea, Choi et al. And German, Rutten et al. Choi et al. Did their surgeries in local anesthesia, and they had 90.8% of favorable results with more than 1.5 years of follow-up. Rutten et al., they had good surgical outcomes with recurrence rate as low as 2.4% in 2-year follow-up. In 2007, Rutten further utilized and designed the optics instruments to seek the migrated disc. He needed to do some bony work, and in 2009, Rutten et al. Further reported the prospective RCTs for surgical treatment of lumbar recess stenosis with full endoscopic interlaminar approach. In all this evolution, the working diameter was increasing of the endoscope. Comp et al. In 2011, he used interlaminar endoscopic decompression for central spinal stenosis using the third generation endoscope system and burrs as large as 5.5 millimeter in diameter. And he first reported lumbar endoscopic unilateral laminectomy for bilateral decompression. He could finish the surgery in 44 minutes in one segment. So complication rate was also low. So we can see in this diagram how these endoscopic spine surgery evolved with the first transforaminal surgery. Then the focus moved towards the interlaminar approach, and as the experience grow and the instrumentations develop, we could see the contralateral decompression also. And now the era is endoscopic lumbar interbody fusion is being attempted quite regularly. So there are two RCTs which is quite famous that Rutten et al. Did the for lateral recess stenosis, and they compared the endoscopic spine surgery with conventional microscopic interlaminar decompression, and they found similar symptomatic recovery with lower rates of revisions and complications in endoscopic spine surgery patients. And Hyo et al. Compared 3 different sets of patients, and they also appreciated the full endoscopic spine surgery complaint, less of postoperative pain, with better clinical outcomes, shorter length of hospital stay, and fewer complications and fewer revisions. So this is the diagram which shows the normal spine and what we used to do in open spine surgery, that we used to do a lot of collateral damage, remove almost do the laminectomy, do the partial fasciclectomy, remove the flavectomy, and remove as much as a disc. But as our understanding increased on the clinico-radiological correlation of the pain, we started targeting the exact pathology like disc, like osteophyte, like ligamentum flavum hypertrophy, like superior articular process impinging on the exiting nerve roots, or the patient having all the pathologies, and we started dealing with the endoscopic spine surgery. So as of now, with transfemoral approach and interlaminar approach, we can do almost all kind of degenerative stenosis and herniations, and it further helps in preservation of the bony anatomy, bilateral facet joints, and because of the high resolution, endoscopic spine surgery had better results compared to the tubular retractor surgery or the conventional discectomy surgery. Now the era came for the lumbar interbody fusion, and MIS TLIF with tubular retractor was quite popular due to the minimal disruption and the faster recovery. Endoscopic decompression, discectomy, and ipsilateral or bilateral facectomy was described, and to create the working space for end-plate preparation as a case insertion. And with uniportal endoscopic fusion, patient has better recovery, less demand for opioids, early mobilization, and shorter length of hospital stay. So as with the experience or expertise increased, endoscopic laminectomy is quite oftenly being done for cervical myelopathy cases. Anterior and posterior full endoscopic cervical decompression was being done for discectomy cases. So even with full endoscopic ACDF is also been attempted with great success. So posterior full endoscopic cervical foraminectomy and discectomy had similar clinical outcome as compared to conventional ACDF, but has advantage of less blood loss, shorter operation time, and shorter hospital stays. So what we are looking at technology further to incorporate neuronavigation, OARM, intraoperative computed tomography, augmented reality and virtual reality, and robot-assisted surgery. So ultrasound 4K endoscopes are being developed with 3D applications. What they offer us? They offer us the higher accuracy of pedicle screw fixation to find the exact location of surgical instruments for safer and more accurate deployment of the intervertebral cage, and reduce their radiation exposure to the surgeon and the patient himself, to reduce the operative time, and to help overcome steep learning curve. So almost all these spine pathologies are being treated as of now, and in coming times, CVJ anomaly, extradural and interdural spinal tumors, and the deformity surgeries are being targeted. So now, how the evolution of the endoscopy in the spine has occurred. First generation, only discectomy, mainly transfemoral approach. Second generation, we introduced the interlaminar approach for the disc only. As Rogers modified, we introduced the Burr, working channel increased, we could do the laminectomies, foraminectomies, and the stenosis part. And now the fourth generation, where we utilize uniportal or the biportal, we do the endoscopic lumbar interbody fusion, spondylolisthesis cases. Now, when we search and look towards the literature, there are different terms for IELD or PSLD, like full endoscopic interlaminar access, full endoscopic interlaminar approach, interlaminar access for percutaneous endoscopic lumbar discectomy, percutaneous endoscopic interlaminar discectomy, percutaneous endoscopic discectomy. So with all these techniques, there was a lot of confusion what to search. So to simplify this, AO Spine, minimally invasive spine surgery curriculum task force, devised a nomenclature to help the surgeons, to help the patients, to help the insurance company people, and they defined 4 points like anterior, which corridor that you are using, then mode of visualization, either it is endoscopic or endoscope assisted, spinal segment that you are treating, and the type of procedure that you are doing. So like if we are doing anterior full endoscopic approach, cervical discectomy, or posterior or interlaminar full endoscopic lumbar discectomy or lumbar foraminectomy or lumbar lateral recess decompression, you have to go step by step. First you have to write the corridor, then visualization, then the segment and the procedure. So this is the complete guide that shows the different procedure that we should write and explain to our patients and for the insurance purpose. So takeaway message is the concept of functional preservation and enhancing post-operative recovery is a main point in the modern era. endoscopic interlaminar window is like the door to almost all kinds of pathologies. And the improvement of endoscopic tools and expertise drives the evolution of endoscopy spinal surgery further. Thank you.
Thank you, Dr. Gupta. Stay
Yes,
there, please.
yes, please.
Is there any contribution or question? Yes, Dr. Gupta, if you give me permission, I will have a little contribution.
Yes.
First of all, our spine, also I am using our spine classification, but still there is a discussion about this issue. There are some objections, but I think that today we have to use this classification. I agree with you. Second contribution is combined triangle. Combined triangle is a dark area in the literature. Every people is defining different. For this reason, we search 40 articles from combine. Actually, combine is describing two triangles. One of them, you said, the concrete docking triangle. But second one is imaginary, the passing area.
Quadrangular triangle.
Passing area. Actually, there is a new requirement, new contribution about this issue. Thank you very much for your excellent presentation.
Thank you so much.
So I would like to invite the third speakers from Uzbekistan, Dr. Abdullayev. He will talk about their practice. Please, Dr. Abdullayev.
Assalomu alaykum, hurmatli hamkasblar. Здравствуйте, уважаемые коллеги. Наш учитель Абдуллаев Диканович сейчас умра сафарда. Мой учитель. Я его ученик. Я тоже нейрохирург. Акмаджан Азбекович. Наш доклад, как мы начали бипортальной эндоскопии позвоночника, UBA. Развитие эндоскопии создали область минимальной инвазивной хирургии позвоночника, которая перемещает точку визуализации от глаза хирурга или микроскопа и помещает ее непосредственно в месте патологии позвоночника. Современное положение в области эндоскопии хирургии позвоночника является результатом двух направлений эволюции: от большого к малому и от малого к большому. Эволюция эндоскопии позвоночника, трансфораминальным доступом унипортал, интерламинальным доступом и эндоскопической декомпрессии стенозов позвоночного канала, endoscopic lumbar interbody fusion, унипортал or бипортал. Что такое UBA? Односторонняя бипортальная эндоскопия – это новая форма малоинвазивной хирургии позвоночника. UBA включает в себе два портала в одной стороне. Один портал предназначен для оптических инструментов и системы вращения физиологических растворов, другой для хирургических инструментов. Оборудование и инструментарий для UBA – это же камера, источник света, монитор, бур и шевер, РФ-генератор, 0 градусов артроскоп, керосин и кахатон. История. Период разработки метода UBA в 2003-2013 году в Южной Корее концепция позиционной особенностей хирургической анатомии, вращения показаний. Рассвет метода с 2016 и больше. Доступ для интерламинарной декомпрессии видно, да? Две палочки. Почему мы выбираем UBA? Первый. Декомпрессия нервов при дегенеративном заболевании позвоночника равноценной микрохирургии. Более четкая визуализация при чем микрохирургии. Второе. Минимальная инвазивность. Сохранение мышц, минимальная кровопотеря и ранняя реабилитация. В принципе, UBA. Первый – это триангуляция. Второе – созданы рабочие полости, working space, и циркуляция воды. Преимущество UV. Первый, это маленький разрез 5-7 миллиметров. Второй, минимальное повреждение мышц и связочный аппарат. Третий, минимальная кровопотеря. Четвертый, низкий риск инфекции. Пятый, минимальный рубцовой спаечный процесс. Шестой, отличные видимости, минимальный срок госпитализации и экономически выгодны, чем монопортальные. ЮБ – это современные новые процедуры с инновационными использованием эндоскопа или артроскопа в хирургии позвоночника. Наибольшее отличие от традиционных методов существует значение для результатов операции на позвоночнике. ЮБ обеспечивает адекватный контроль декомпрессии и более широкий хирургический обзор, чем однопортальный эндоскопический позвоночник, что обеспечивает удовлетворительную безопасность и эффективность. Повышение квалификации Южной Кореи, Турция, города Бурса, мастер-класс в городе Фергане, профессор доктор Хаяти Айгун и кандидат наук Абуков Дахир в России.
And talking about endoscopic surgery and biportal access, first of all, we would like to especially mention that we are now conducting these surgeries in Fargana and trying to contribute from our side to development of these type of surgeries in our country.
Спасибо за внимание.
Thank you, Dr. Abdullayev.
Yes.
In Russian or Uzbek language, please.
Спасибо, хороший доклад. У меня маленький вопрос, я только учусь же.
Thank you so much for your comments. So I'm since learning, please guys, since I'm just jumped into learning this portal surgery, please teach me what might be the, I would say, specific things and what are the specific features? Well, what are the specific features of benchmarking from right and left side? Well, from right or left side, well, let me think it over. I guess the major part is that we need to triangulation and also so please kindly give me the mic. Well, the major issue is that we must face the problem with spinal laminar junction. I mean, this is, I would say, the start point, and we will have to open the further access. That might be an issue. And yes.
Yes.
Well, talking about working portal, we have to if you are working from the left side, you need to have the mid-pedicular line, and if you are working from the right side, you will be having the carrying tube, it should be a bit, I mean, it should be moved some other side. So, yes, we should put it closer to the disc. Yes, just 1 centimeter.
Yes, my dear colleagues, I promise that in next absolutely I will talk in Russian language or in Uzbek language. I will learn it. Don't worry, but for today I am very sorry. Yeah, I want to invite the next speaker is Dr. Yakubov, and he will talk about the endoscopic decompression of the thoracic spine.
Assalomu alaykum, ustozlar, hamkasblar,
Good afternoon, dear colleagues, dear auditors, dear our friends. We are very thankful to see all of you here. We're talking about our report on thoracic spine. Well, I will not tell that it's just the young surgeons who have jumped into conducting these surgeries. It is also the seniors who are also learning. And you know, when you're talking about the thoracic spine for us to avoid complications, well, the surgery for us, it is very important to
spinal canal stenosis. What is the advantages there and what is the risks? First is indication for surgery with all of approaches, which size of kerosene we should use, is water pressure, calcified disc, everything. This question is, I will give you answer. Thoracic part we know is a neurosurgeon, orthopedic surgeon who is doing his spine. Is the dangerous part of spinal vertebrae if compare cervical and lumbar spine. Indication for surgery of first is myelopathy. There is myelopathy, very severe compression spinal cord, and pain in the lower back, tingling, numbness or weakness, decreased fine motor skills, balance or coordination, abnormal or increased reflex in extremities, difficult walking, loss of bowel or bladder function. Everything is for indication for surgery. Because many who before is done open surgery, during surgery risks of spinal damage of risks of the damaged spinal cord is very high. In endoscopic surgery also there is some risks. If you do a correct decision, and which instrument is instrument also very important. Everything is position, instrument, is everything we are going to talk about it. Approach is like his lumbar spine. We should do skin incision is just parallel as this disc level. And we don't need because some surgeons maybe use AP view, but sometimes AP view and lateral view is not correct. You can say AP view is interlaminar space, but when you see as a lateral view is maybe you put your dilated cranial or caudal. That's why is better is lateral view. Just landing point should be the spinolaminar junction, right or left. This is your decision. Is important thing is if spinous process is slided on the right side, your approach should be on the left side. If send it on the left side, your approach should be the right side, because this always we should approach which part we have bigger space. Kirsten size is dorsal decompression very important because there is narrow spinal canal, and if like this too much compression, see this here is under spinosis process, only 2.8 millimeter space we have. It means we can use only 1 mm or 2 mm Kirsten. If you use 3 or 4 mm Kirsten, we easily damage spinal cord. Here also is only space, is landing point should be the spinolaminar junction. From here we should remove a lamina, and here we have space for Kirsten to remove, to make enough space for our Kirsten, and this calcified, totally calcified ligamentum flavum is a very small space for spinal cord. Sometimes this some surgeons maybe during surgery confused, because here is two-layer lamina. Yes, if you remove lamina, under the lamina again one lamina you can see. That's why sometimes before surgery we should analyze the CT scan, MRI, and like this totally calcified ligamentum flavum. First with high-speed drill we should make it thin, this calcified ligamentum flavum, in just easy we can remove Kirsten 1 or Kirsten 2 punch without damaging spinal cord. This water pressure also very important. If in even lumbar spine, if you use if you do is surgery time more 1 hour, patient because under local anesthesia, patient is having his neck pain, because water pressure in cervical part, epidural pressure also increasing. Dorsal in cervical, I recommend don't use pump, because if you use pump, it will damage also spinal cord. Just gravity is enough. Like this gravity, you can put more than 2 meters high is the level of this line, and by gravity you can do surgery. It very safe. It doesn't damage the spinal cord. Calcified disc, what some doctors says maybe should remove this calcified disc. Yeah, it can remove, but there is some risks also. You can go far lateral approach, and we can do is we can remove calcified disc. Is my opinion is not required to remove like this calcified disc. Just posterior decompression is enough. Any anterior decompression and posterior decompression, main goal is we should make space for spinal cord. That's why is just posterior decompression is enough without removing this calcified disc. This case is 2 levels, totally calcified ligamentum flavum. This CT scan shows almost 70% of spinal canal is closed. This is MRI, 2 levels minus this part, too much compressing inner foot. This result after surgery, if you see here is some part of spinal cord already damaged. This patient came to me with weakness. He cannot able to do walk without support. But following 1 year, now he's about 80–90% is recovered spinal cord. He is walking. See, this is also result. This MRI here is a very small space for spinal cord. This is totally calcified ligamentum flavum. This after surgery is totally free without damaging spinal cord. For spinal cord is enough space. This is also young patient is totally calcified disc. Is lateral and is sagittal in axial view. Is after surgery. Is just posterior decompression. This posterior decompression is saving both facets and making space for spinal cord. This is also 2 levels small disc bulge, and I do only ipsilateral decompression because when you see you are saying is right side is enough space for spinal cord. Is right side decompression is not required. That's why only I am done is left side approach and ipsilateral decompression in removing this disc material. Thank you so much.
Thank you, Dr. Yakubov. It was excellent. Is there any contribution or question? Yeah,
Akkor, it's an excellent presentation.
Thank
I
you.
just wanted to add few points for thoracic, as I was very much experienced in it. Thoracic myelopathic calcification of OPLL is definitely issue should be considered. Interlaminar axis is good, but discectomy still transforaminal approach is good. But I feel the same thing which our boss has told, the paraspinal approach or facet knockoff technique is the best way to do discectomy. So destabilizing one facet or removing one demifacet, depending on the level of thoracic spine, it is the safest way route to do discectomy without touching the myelin. So still for thoracic disc, I feel facet knockoff is the best option. Interlaminar decompression should be very careful because the attachment of dura to the calcified OPLL is very much common.
Yes, right. Sometimes I have done discectomy also. If there is soft disc material, just anterior decompression, removing this material is the best way. You can do is far lateral approach in one facet. Maybe you can damage, but you can remove disc materials, anterior decompression without damaging is posterior part of lamina ligaments. It's the anterior far lateral approach also sometimes is I do.
The facet knockoff surgery, rarely what it may happen is you may sacrifice the thoracic roots, but it may only give some amount of neuropraxia, but no motor deficits.
Yes, right.
So, but it is safer to sacrifice.
Yeah, right.
Is
Thank
there
you.
another question or contribution? I have a question, Dr. Yakubov. Did you have any complication due to cord compression during your operation? Did you have any complication or not?
In my practice, no. I had some weakness after surgery, after decompression spinal cord, but is not damaged spinal cord.
Okay, thank you very much. Thank you, doctor. Next speaker is Dr. Çeliker, step-by-step full endoscopic interlaminar approach. No, there is problem in this area because Dr. Saiful cancelled his presentation. Am I right? Yeah.
Good afternoon, dear President and colleagues. First of all, I would like to
thank to the organizing committee for inviting me this presentation. Dear participants, welcome all of you. The subject of my presentation is step-by-step full endoscopic interlaminar approach. I have been dealing with endoscopic spine surgery for about 7 years. In this slide is a surgical algorithm. There is a table I created showing the stage of the surgery as a type of anesthesia, and I prefer general anesthesia. All the table is here. The patient is in the prone position. Two pillows are placed, one on the chest area and the other in the hip area here. To reduce intra-abdominal pressure, the operating table is prepared so that the interlaminar window is opened wide. Here was CL5S1 interlaminar window in the fluoroscopy image. As you can see, neuromonitor cables are also connected to patient. I have been using a neuromonitor for every surgery for the last year. The level is checked with scopy. An incision of approximately 0.5 centimeter is made with a scalpel. This incision should be wide enough to pass through the fascia. Then it is deepened and dilated with the dilatator until the lamina or facet joint is fell. In this fluoroscopy image, you see that it has progressed to the level with the first cannula. Then a working cannula was placed over it, and the first dilatator cannula has been removed. The working cannula is here. In this slide, you see the working cannula and the X-ray image. See where the midline is. Here. The first moment you insert the camera into the working cannula, look, the monitor is in front of you here. The patient's preparative MR image is here. The scope should be here to take image at any time. The way you hold the endoscope is important. There may be pain in the wrist at first, but you get used to it over time. The first image is in this video, muscle tissue. I make an incision through the muscle tissue with micro scissors until a beautiful film appears. You can safely control bleeding with RF. This video, you will watch the ligamentum flaum being opened with the help of micro scissors. The scissors should be used with the blade in our field of vision. Look, epidural fat tissue appeared from here, and we move towards the lateral and expand the window opened in the flaum. I remove the epidural fat tissue little by little. It's not always this fat, but generally Turkish people are overweight. Look, the dura and the left S1 root are starting to appear. Here, here. In this video, by carefully rotating the cut-tipped working cannula, I try to exclude the nerve root and reveal the free disc fragments underneath. And I remove the disc piece with the help of kerosene punch just now. After this, removing the disc parts. Sorry. If I have time now, I will show a few case examples. In this case, interlaminar endoscopic discectomy was decided for a patient with L5S1 left and centrally predominant disc. Surgery was not decided on the L4-5 level based on the clinic. In this video, the nerve root is excluded with a cut-tipped working cannula, and sequestered disc fragments are tried to be found. I find it. Disc fragments are removed with the help of a punch. After this, removing the disc parts. You see the extracted the disc parts. In the neuromonitor membrane we received at the beginning of the surgery, there was a low amplitude in the L5 roots due to an upward migrated disc, especially the left root is even lower. When we check again at the end of the surgery, you see the improvement in the neuromonitor. Control here. Control lumbar MR image. Sorry. Yeah, control lumbar MR image 2 hours after surgery. I have a routine postoperative lumbar MR. I learned this from Dr. Hikmetulu. In this case, a female patient has a persistent left leg pain that does not go away with medical treatment. There is a suspicious image pressing on the left S1 in the lumbar MR here. The patient has a history of previous stabilization and decompression surgery. In the tomography taken, the image pressing on the left S1 root was thought to be a gas image here. The decision for surgery was made with the endoscopic interlaminar surgery. Look, you see the gas particles coming out in here. Very big gas coming here. It was observed that there was no gas pressure in the postoperative MRI. Take home message, it's important to get help from a mentor in the beginning. Doing cadaver work will contribute to the acceleration of your technique. Since the learning curve is long, the L5S1 distance should be preferred in initial cases. Full endoscopic interlaminar discectomy is a safe and effective method. Thank you for attention. It's great honor to present today in the land where the world's greatest medical science was born. As you know, these are the homeland of us Turks. I am very happy to be here.
Thank you, Dr. Çeliker. Your photo is handsome, is okay. Is there any question or contribution? I think that in last 10 years or 5 years period, the interlaminar surgery has big popularization.
Yes.
And indication is enlarging.
Yeah.
For example, the cervical area, our colleagues present us very nice presentations.
Mm-hmm.
What do you think about the tumor surgery?
Yeah, I had a tumor surgery, 3 cases. The thoracal 7 level in the metastatic tumor, extradural and intervertebral body tumor. I had operated the last year 3 patients.
Is there any colleagues that doing tumor removal, applying the interlaminar surgery? Full endoscopy. Please.
You know.
Tomorrow you will. Okay. I will ask you tomorrow.
Okay.
Okay, doctor. Thank you
You
very
know
much.
every work is the separation surgery is now.
Okay.
Separation surgery is coming.
Okay. Thank you, doctor. Next speaker is Dr. Islambek. If I say it wrong, please warn me. He speaks about endoscopic bilateral decompression for central stenosis of the lumbar spinal canal. Yes, doctor.
Здравствуйте, уважаемые участники сегодняшней конференции.
Participants of today's conference. Today I'm going to deliver my speech on endoscopic bilateral decompression under central stenosis of lumbar department of spinal cord. I'm from Osh City, Kyrgyzstan. I work in a private Kyrgyz-Turkish international clinic, and I would like to now focus briefly on definitions of stenosis of stenosis of spinal cord. It is characterized by stenosis of spinal cord lateral part or compression of nerves and roots and anatomic structures of spinal cord. You can see on axial cross cuttings, you can see regular, and you can see a stenotic spinal cord. You can see that we are experiencing hypertrophy of ligamentum flavia here, and it produced negative impact on spinal cord and outgoing root. According to etiology and epidemiology, the stenosis of spinal cord is 1.8 to 8% among all spinal pathologies, and in US plus 50, I mean 90% out of 100,000 of people are undergoing these surgeries, and in surgery in Zurich canton with 1.3 million people population, around 300 of patients undergo annually these surgeries. Therefore, it means that in the developed countries with higher life expectancy, longer life expectancy, these issues are indeed key issues, and it will be central and lateral. And you can see three types of stenosis, and they are producing negative impact on ossified ligamentum flavia. You can see the hypertrophy of facet joint and lateral lesions. So in most of cases, the patients in my practice, patients are coming to our clinic with a complaint on numbness and tingling in lumbar part, and they are feeling also neurogenic claudication. And by 2019, the issue, I mean, the stenosis issues can be resolved with laminectomy. It was my perception that the open surgery will help to resolve all these decompression issues, and it gives a better visualization. But unfortunately, it produces major injuries. It might produce negative impact afterwards, and result in post-op instability and post-op pain syndrome, which deteriorates the quality of patient's life. So, of course, you know, the people after 60, they also cannot, I would say, endure open surgery. So we were trying to render them minimum invasive assistance. So talking about treatment, of course, the treatment should be minimal invasive, minimal risky, minimal cost, with minimal costs and the longer lasting effects. And why we came to embark on endoscopic way of stenosis treatment. You know that the patients of an elder age, first of all, should be released from syndrome and improving quality of life by increasing walking distance. And in 2018, I had a chance to meet Professor Shotursunov. And at the moment, I'm undergoing treatment under him for several times. He visited our clinics, and we had managed to get a patient influx from patients with stenosis and herniation. So you can see our surgery room as well as our toolkit to reduce decompression based on PSLD technique. So the equipment which we are using, the equipment of Ankel, and you can see that we have the endoscopic optical devices. So I underwent training under Professor Lim last year in South Korea, and we jumped on to embarked on the surgeries on the stenosis, and here you can see the clinical cases of a patient, a male born in 1949 with complaints on claudication, and of course 100 and 200 meters walking distance, and the stenosis is at L4, L5 degree, L5 level degree according to Lee's, Professor Lee's scales. So here you can clearly see how we step by step are penetrating we are removing these bone structures and having our decompression done. And also you can see here stage by stage visualization of our activities. And our next patient, male, born in 1978, with complaints on severe pain in lumbar department L3, L4, and L4, L5. Number fourth degree according to Dr. Lee's classification, and you can see some hematoma here and at the second level you can see lateral restenosis, and the second level is here also. You can see our next patient, female, born in 1957, with complaints on severe pain in lumbar part and extremities, pain in extremities, weakness, practically cannot walk. We have the before and after surgery. After 1 day surgery, MRI has been taken, and you can see that there's a 2 level, L3, L4, and L4, L5. Degree 4 according to classification by Professor Lee. So here you can clearly see how we are removing only upper cortical part of the bone for us to be able to penetrate with a Kerrison punch. Then we are removing ligamentum flavia, and then, I mean, we are reaching the place of attachment of ligamentum flavia to the bone. Talking about our outcomes, we had conducted 50 surgery for lumbar decompression, and complication dura injuries, 2 persons with no complications and 1 recurrent surgery. So what are the conclusions which we can draw? Actually, no. We also can say that regarding this treatment, we think that this is quite nice, and we can also tell that it will help us to reduce the hospital stays, and of course helps our patient to get back to their work and revive their health. Now we would like to
talk about the over-the-top technique in the lumbar spinal stenosis. Am I right, doctor?
Assalomu alaykum aziz ustozlar, qadrli hamkasblar.
Dear colleagues, dear friends, dear participants of today's event, it's my pleasure to greet you here.
Bugungi biz dokladimiz bel umurtqalari markaziy
Today, our report will be the treatment of stenosis, lumbar stenosis by endoscopic surgeries, and we would like to discuss and surgeon a technique to treat these lesions, and also we would like to share some equipment. Talking about Unitech and the search is helps us to treat stenosis, spinal stenosis by using remal and endoscope. We are and still we are penetrating dorsally and dorsolaterally to ensure decompression, and it helps us to undertake a visual control over the movement of our devices. Well, what is changing? You know that the internal diameter of endoscope has increased up to 7 millimeters, and our port, I mean working cannula's diameter internal is 9 millimeter, and outgoing the diameter is 10 millimeter, and for reamer external is 8.8 and internal is 7.5. So talking about and its opportunities, what can we do by interlaminar approach? First of all, we can treat central and lateral stenosis. We can also treat stenosis laterally, as well as caudal and cranially migrating herniations, and we can get treated our foraminal stenosis and disc herniations, both lateral and ventral, and of course dorsal facet. There's major advantages of endosurge approach. It gives us a better view and a better working area. It helps us to undertake foraminectomy and foraminoplastics, and it helps reduce X-ray radiation, and it reduces operation time to 40-60 minutes, and we also ensure decompression of the spine cord up to 360 degrees. Well, talking about the process of decompression, I would like to show you Well, we had a patient, male, 65 years old. So he had a degenerative stenosis, two-level stenosis, L3, L4, L4, L5, and also hypertrophy of ligamentum flavii and parapares of lower extremities, and osteochondrosis in the lumbar department. So we'll not now focus on the result. Let me just share our conclusions that it gives an opportunity to ensure full visual control, exercises control, and talking about the foraminectomy and foraminoplasties, it gives you a better opportunity to exercise it, and it also helps to reduce the period for decompression, which I think is the major novelty of this method. And talking about our patient, within 1 or 2 days, we can let patient out of the hospital. Thank you so much for your kind attention.
Thank you, doctor. Any question or contribution? I think that there is none. Okay, thank you, doctor. And I would like to invite the next speaker is, Dr. Gansing. He will talk about the anatomical considerations in endoscopic spine surgery. Dr. Masrov, he is not here. Okay, there is writing here. He will present in online, but he's not here. Avar Samit Gansing. Sorry, he's writing to Dr. Gansing, and I am trying to say with surname.
It would have been very nice and easy if my father were a surgeon. He would have taught me at my cradle.
Is that Gansing or not?
Yeah, that's my father's name.
Okay.
Yeah.
Sorry.
It's okay. Nice to honor your father's name at such a podium. I thank Dr. Akror and Dr. Lim to invite me for this August meeting. With your permission, Mr. Chairperson, can I start the lecture? I'll be speaking about the learning curves that we had in learning the fully endoscopic spine approach techniques. Most of the topics have already been covered by an excellent gathering of speakers over here. We must remember that endoscopic spine surgery is not a revolution. It's not a one-off thing. It's not something that comes suddenly and then stays for some time. It's an evolution. It's a new technique of the thought process itself. It's a natural progression in the history of spine. So these topics are covered by Dr. Achal in his talk, and when he spoke about how endoscopy has started and evolved. There are two ways in which we can use the endoscopes. Either there is a separate trajectory for the instruments, or the instruments go through the endoscope channel itself. So when you have an arthroscope, or as EasyGo system or pituitary surgery, this is an endoscopy assisted surgery, whereas when the scope instruments go through the channel of the endoscope itself, it is a fully endoscopic system. So we have different techniques and which go through, use different endoscopes to go forward the decompression techniques. So in 2019, as an excellent lecture presentation in which Dr. Gunchoy divided the generations of endoscopes into 4 categories. This is the evolution of endoscopic surgical techniques, but I believe that even the endoscopic surgeon must go through all these 4 steps of evolution. First, we started with plain discectomies. There was a YES system, there was a percutaneous endoscopic lumbar discectomy, a transforaminal discectomy. Then came the second generation. When we had problems, we went to the interlaminar endoscopic systems. Then came the endoscopic decompressions. And finally, we have endoscopic fusion techniques. So Dr. Achal has covered this topic, how the YES system has come out. We had a classification for migrated disc, which were limiting us from accessing the zone 1 and zone 4 especially. The technique is fairly simple, in which we can do nice decompression of the interdiscal pathology. The setup is pretty easy. Technique is pretty straightforward. And when done nicely, the patient satisfaction is through the roof. You can see complete the discectomy annuloplasty in front of your eyes under vision and achieve good results. With patient on table itself, he will tell you that the pain has gone completely or not. The limitation of transforaminal surgery were essentially bony and neural, the nerve, exiting nerve, and the bone, the pedicle and the facet were limiting our movement in that area. To an extent, they were overcome by endoscopic drill by Dr. Choi, but still the L5S1, the high iliac crest and narrow canal, as we know, the foramen goes on reducing in its size as we go from top to bottom. We thought of developing into the next step of interlaminar approaches. The Descendo endospine system is an endoscopy assisted system with a fixed slots for your endoscope and your working channel. It is a fairly good system. It uses the interlaminar window. But you compare the field, this is an intradural detethering of cord in a pediatric child, in a small child that we are doing over here. But you can compare the field as all the videos that you have seen today, and you see this video over here, you can see a nice dural tube with the exiting nerve root has been exposed. We have opened the dura, and we have identified the phylum. We are stimulating it to confirm there is no nerve root attached to it. And finally, with a bipolar system, we are coagulating it, and we have cut it. The closure can be done by 3 mm titanium anastoclips, which obviate the need for putting sutures inside without compromising the dural sac significantly. So yeah, it's good, but is it the best? EasyGo system is also good. It's, as again, an endoscopy assisted system when you have an endoscope which is on the side and working channel through which you can do the decompression. It has been the workhorse. You can use the tubes with your microscope, your loops, or your endoscope, and it has been working very good. No problem with that, but the real game that changes is the third generation, when earlier spinal stenosis was a contraindication for endoscopic spine surgery. Today, it has become one of the biggest indications for doing endoscopic surgery, lumbar stenosis. It has happened due to these scopes, which are wider in diameter. The working channel is bigger now. You can use power instruments inside. You can use a drill system inside, which is shortening the time that you use for doing the bone work. You have excellent radio frequency probes, which are much thicker in size, which are again making your work faster. This is all that you require in your set to begin with. A set of 5 to 6 instruments, a scope, and a punch. That's it. You can start doing your case right away. So earlier, when you were doing an open decompression through this kind of a huge incision, now you just need to put the endoscope inside and decompress what is the pathology. Remember, the muscle, the skin, and the fat are not your pathologies. So this is the endoscope developed by Dr. Ganchoy and Dr. Lim. We use this entire system. There are only 7 to 8 instruments that we use. And you must remember the endoscope like the back of your hand. You know your hand so well. You must know your endoscope like that. You must learn to clean your endoscope yourself after surgery so that it helps getting the scope should be an extension of your hand itself. That well, you should be knowing it. The working channel, because every single drill that you're making or buying from your set over here, you need to know whether it is compatible with your endoscope or not. So setup is again pretty easy. Doesn't take much time. This is one of my first cases that I have done with endoscopic system. This is 5 to 6 years back. You can't see anything. Even I could not see anything. It was not. It was just very difficult to control the bleeding. After quite some time, about I think 1.5 to 2 hours, I started seeing the ligamentum flavum. I opened it. I started decompressing, and we completed surgery in about 3 hours. I show this video every single time so that the young endoscopic surgeon should not get disheartened if this is the first thing that they see. Over time, it becomes easier, it becomes better. You have a disc like this. You rotate your endoscope with the sheath this way to retract the thecal sac and the traversing nerve root to expose the disc in front of you. You have a relatively clean field. You can remove the entire disc that is herniated in front of you nicely. And patient can be mobilized as early as 2 to 3 hours after surgery and can go straight home walking like that. The size of incision is small. This is another case who came with a large disc herniation. She had a left-sided pain, which then radiated to right side as well. With the use of drill, the time that we take for bony work has reduced significantly. I think the video is jumping for some reason, but you can see that we are drilling the bone. This is a high-speed drill that we have modified for use for interlaminar approach. The bone can be drilled very easily, very nicely. Most of the endoscopic surgeons will observe that the moment you reach the point of the ligamentum attachment to the undersurface of the lamina, you will notice a kind of bleeding that comes from this side. And this point is something that we are publishing about as the end point of your bony drilling. You confirm the ligamentum opening, and then you remove the ligamentum. You go on the contralateral side because she also has right side pain, and you can decompress the nerve root on the opposite side. Once you remove the ligamentum, you get a large space for you to work around. This is the ipsilateral side. You can see the entire panoramic view of the entire thecal sac and the nerve root. With the internal rotator retractor, we can rotate and displace the thecal sac and the traversing nerve root, expose the disc in front of you. So without damaging too much or without causing much neuropraxic injury because of the large sheath that we earlier used to retract the entire sheath, now we are using much smaller tubes to retract, and the disc can be out in no time. At the end of the surgery, you confirm the entire decompression, the nerve root that is traversing till the middle point. This is the medial pedicle line. And you can ensure that you have done a complete decompression, a complete job before you can close. This is one thing that we were discussing, that as your cases, once your number of cases go on increasing, the time that you take to operate goes on increasing till a point about 24 cases. Then your time of surgery goes on decreasing. Again it increases because now you have become more confident, much more stronger, and you are taking more and more complex cases. When the time will again go on increasing. And once you navigate that hill is when time gets back to normal and you are able to do these cases much, much faster. This is sequence for new surgeons. I always say that start with a single level, single sided disc, then go to decompression, 2-level, multi-level, then redo cases, cervical case, and then finally go for fusion. This is exactly how your own evolution as a surgeon should be, just as a surgery has evolved in itself. Multiple advantages. Radiofrequency coagulation is very important because it is causing, at a very, very low temperature, it is causing coagulation of the tissue and avoids the bleeding. So to summarize, it's an important advancement in the armamentarium of a spine surgeon. You have conscious sedation, same-day discharge with minimal post-op pain. The learning curve is steep definitely for transforaminal surgery, but not so significant for interlaminar as an approach, and the angle is similar to traditional open approaches. Thank you so much.
Thank you, doctor. Any question or contribution? Yes, please.
Thank you for your nice presentation. I want to ask you, as you know that in many papers there are many numbers for the surgeries. For example, for transforaminal surgery, it's around 30 or 40 cases. For interlaminar surgery, 50 or 60 cases are enough for doing the surgery very well. What's your opinion? Is there any exact number? Do you believe that? Because it depends on the ability of the surgeon and the conditions of the hospital like that.
I fully agree with you, sir.
Also, I have another lecture like this topic, and I want to learn your opinion.
Definitely, sir. Thank you so much. I believe that the number of cases that it takes for you to learn the technique is an extremely variable and surgeon specific, your surrounding specific thing and what kind of cases you are presented with. It can be totally different for every single surgeon across the world. This is just an average that they have given. And second thing, the pain management physician who's doing transfemoral surgery can learn TF much, much earlier than any other, maybe a neurosurgeon trying to learn transforaminal. Because for me, I think interlaminar before I think from transforaminal. It's a totally new approach for me when I'm start thinking. Whereas in interlaminar, I don't even need to think. I can just put my dilator inside and I know exactly where I am even before taking the shoot, which part of the lamina I'm sitting on, whether I'm slightly medial, slightly lateral, slightly up, slightly down, whether I need to move before starting putting the working sheath itself. So it's going to be different for every single person.
Thank you.
It's okay. Another question?
Basically, for the learning curve, I'd like to comment. There is a paper on this. They say there is a learning curve trap. If you
Please,
are
a little bit close to me.
there is a learning curve trap for surgeons. If you are not doing one case per week, you will be trapped in that trap. You will not reach the plateau. So, at least one case per week you should do, then you can cross the steep and reach the plateau. And there is a M-FLAN learning curve which tells us you should go with L5S1 first, then L4, L5, then stenosis, then cervical. But at least you should have one case per week. That means around 52 cases per year to reach the plateau. Thank you.
Yes. Another? I am very happy that audience is leaving. Okay. Thank you very much.
Thank you, sir. Thank you so much.
And, I would like to invite the next speaker is Dr. Dakir. If I am wrong pronunciation, please warn me. The topic is opportunities of monoportal endoscopic surgery for degenerative diseases of the cervical spine. Doctor, you mean that with monoportal endoscopic, full endoscopic, you mean? Am I right?
Yeah.
Yeah, okay, thank you.
Yeah. Так. Я все правильно сделал? Ну? Вы же видите? А, только там пока. Добрый день, дорогие коллеги. Учитывая, что очень много...
Dear colleagues, good afternoon. And since we had today a lot of reports on monoportal endoscopy and the cervical part was also very well today discussed. So let me talk about B-portal one. So I have changed my speech. So I mean, in 1996, we were forced to obtain information and I would say on approaches on this, and Professor D. Anthony published the first article, and that was it. And in 2013, Dr. Solomon came up with a new portal surgery, which reminds what we are doing at the moment, and also talking about B-portal surgery, it became very well developed in South Korea starting 2016, and it's proactively developing, and even those who are dealing with monoportal surgery, guys like me, are now proactively introducing it in our clinical practice. So why we are talking about UBA? Well, the answer is quite simple, I guess. You are seeing the picture. So, as Kambin published article in 1998, and he titled it Biportal Decompression. So he gave the title to this method. And actually. So for people not to overlap with his method, they decided to call it unilateral one. Well, monoportal and biportal, what is the difference? So talking about monoportal, it means that you're using one port. Biportal means you're using two ports, and all of these ports are virtually existing. When you're having monoportal one, I mean, you are having endoscope with working channel and the camera itself, and optical channel, lighting channel, and irrigation channel. And if you're having biportal surgery, endoscope is, I mean, optical, light, and irrigation channel, and separately we have the working channel. So from working channel you can use whatever the devices and tools, for example the hammer, which I love it in case of degenerative stenosis. So we are having 5 millimeter incision, and we can proactively use such a nice hammer, which never will require any repair. So and these are the same principles of biportal surgery, like triangulation principle. And talking about endoscopes, I mean these two tools should come under the angle of 30 degrees, and endoscope and working tool, they should not create any, I would say, burdens for each other, and endoscope should always ensure visual control, exercising over the working instrument. And we are, of course, should change. And the second principle is irrigation through working channel of endoscope. We are having, I would say, small working area, working space, and here I would say on the bottom, in intra-arc area, with the water will flow down, and this working port is created by flow of water. I will show you now the video that water is simply coming to the working channel of endoscope, and it flows through our virtual port. What are the advantages of our UBA? I mean, we can have the intralaminar approach, which gives us all the surgeries which we can undertake. Actually, I mean, whatever can be done, it can be done. And talking about our median approach, we can also tell that it can be done through lateral channels, and this approach is used when we are in doing screw insertion after the decompression, and extraforaminal approach when we are having foraminal pathology approach. So we are doing a lateral scission, and we are doing on a lateral margin of both adjacent vertebra, and we can reach the zone which we would like to reach. And also I can tell you that we can use overall anesthesia, but still you should not, you know, the legs should not go down too much for us to avoid the hypertension. And the 1.5 hours long operation, it's optimal for such a surgeries. Otherwise, then the patient will not be happy for staying under the anesthetic too long, and it will give the better back muscles relaxation. And if the patient will move, you know that it will block the working channel. So the patient had some problems with pneumonia. The patient is 80 years old, and he has recurrent herniation, and after microsurgery anatomy is significantly changed. So within 30 minutes the patient was simply tolerating the surgery, and the next day we can release him. And here you can see this prone position, and I mean, as it is convenient for you, but still we should ensure epidural positions so that epidural veins will not prevent us from working. So we need to avoid excessive pressure. And here you can see 30 degrees angle between working port and between endoscope. So of course, the distance might be different, but still it is 30 patient, and fatter your patient, the more obese your patient are, more this distance should be. And of course, we have to, I guess, come up with this. I mean, it should be from 2 to 4 centimeters, the distance between them. And I guess I will answer one of your questions. And if you are right-handed and if your endoscope is below and working instrument is above, then we are coming with a bow port on the disc level and a lower port 3 centimeters below, as you can see. And also it depends on exact situation and condition. I mean, if we are dealing with herniation, we can change the port. It depends on situations. And but we are also facing the problems with fusions or no bones resection, and we have been reducing this formation, and we were trying to touch a lower margin of a transversal process of above vertebra. And so we are also trying to find the solutions. And access, you will have 2 entry points, 5 millimeters each. You do not need to do it bigger. And we are cutting this aponeurosis. It will be our working port for us to ensure water flow. And for endoscope, we simply should penetrate through the skin, and you can easily see what we have. I am not using crosspathermolysis, so traumatization is quite low, and you can see that after the surgery, after using our regulator, we are identifying our ligamentum, and we are not going beyond the bone margins, and then we can go to decompression. And I'm pretty sure that we need to prevent excessive bleeding. We're talking about irrigation. We can use gravity, we can use pump. I see no difference in case if you have ensured regular flow of water, there might be no issues. And also in the end of the surgery, we will have to stop the water flow. Let us stop the water flow and we will see the decompression. And so the issue has been successfully resolved. Therefore, we are not using any drainages. And talking about our major tools, we are using ablator and endoscope. So it's like a 0.2 degrees, and we are trying to use biportal technology. And we are also having various ablators, and we are having different conditions, different situations. So let us draw some clinical examples. We have quite a huge herniation here, and after transforaminal approach, we face the problem with its recurrence. It's quite big indeed, and we we have managed to remove it. And this is the picture after surgery in 1 month. So you can see what are the, I would say, traces left. So starting bilateral decompression, we are going a bit far from midline. So we're doing it step by step. We are decompressing it from the entry point. Then we're going around and we are focusing all the structures. Considering that we are running short out of time, we have 3 levels of stenosis with 4 incisions, 5 millimeters each, and the patient is let out next day. And in case of adhesion, when dural sac is closely related to the ligamentum flavia, we can use the hook and endoscope for visualization, and we can now extract the ligamentum. And we are conducting this resection. For extraforaminal approach, in severe foraminal stenosis, when you do not want to resolve, I would say, bone-related issues, we are reducing foraminal stenosis. We are identifying the root, and then around it, we are conducting decompression. First of all, we need to find this root, and then we have to conduct this decompression. And you can see that the muscles are closing the way they are doing it under monoportal surgery. So you can see that with these 2 incisions, we are meeting our target. And one of our, I would say, advantages, even here, you can easily see, even in such situations, that we can have, we can use these tools under 100% visual control exercise. We are we are preserving our nerve structures, and we can install the cage, and before its installation, we can ensure decompression, bilateral decompression, I mean, and some even clearly unseen traces are left after activation. And revision surgery, you can see it's very nice open surgery of epidural fibrosis, and we can use portal technology for us to prevent recurrent herniation. You can see the major, I would say, scar. We can clearly see the whole nerve, and you can even having this slope with hook, you can see this neural sac, and you can easily see what is going beneath the epidural sac. And here you can see the midline is here still. We didn't need it. From a couple of slides, and we are proactively using both monoportal and biportal surgery in terms of stenosis, and of course sometimes for visual stenosis and stabilization it's not comfortable, and we are also, in terms of monoportal stenosis, we are trying to, of course, ensure monoportal access for cervical and thoracic access. And if you are having 2 levels, means that you need to have 2 incisions, and we are treating it in monoportal way. This is one of our clinical cases. We are having stenosis, posterior decompression, which we're conducting monoportally. In such situations, it is indeed easier for us to ensure bilateral decompression. And you can see that it's not easy to ensure a contralateral access. Thank you so much for your kind attention.
Thank you, doctor. Any contribution or question? Okay, thank you very much. Next speaker, I am very sorry that I missed one colleague because of my list. Next speaker is Dr. Berdiev Suon. He will talk about the comparison between traditional and endoscopic techniques. Sorry, doctor, I missed you.
Dear colleagues, dear guests, it is my pleasure to see all of you here in Uzbekistan, and my today's research will be dedicated to, before we have started this endoscopy, what we had before, what were the practices which we have been using before we came to endoscopy, and then probably we will go to comparative analysis in brief. Well, let us compare, traditional. Talking about the tradition means that we were using general anesthetic. Now we are doing simply spinal anesthetics. We are doing very small incisions. We are ensuring intraoperational monitoring and, of course, aseptic treatment on daily basis. And we of course, post-operational period is 7 days. And in these cases, it's quite short. It's, in terms of endoscopy, it's just 1 day. And of course, the quality of life for if you're having endoscopy, it's much better. Let me draw some examples that because in previous times when we need to have this oxys spondylosis, indeed we have conducted it with quite big incision. When we need to have a stabilization of the patient, we also had it, but you can see that it's quite big area. So that's why we had no open to just to remove and stabilize this segment. We have done it, and through such a big incision. And here also you can see that we had 2 surgeries with posterior and anterior approach, and also in case of injuries. We have installed the TPF fixation, but it was also indeed quite high. So we had to conduct the surgery with a thoracal approach, and we have done a thoracotomy, and we have removed the disc and stabilized. So we had such cases, but the only way is to have it in open manner. And here it is all, and we had quite a big space for we had sarcoma.
Сначала удалили тотальную ламинектомию.
At the second L2, we have done a laminectomy, and but it goes up to the body of the vertebra, so total decompression, and then we have done it with TPF fixation. So here you can also see the open access.
Так. Сейчас вот в течение.
So within certain period of time, you can see our patient is easily moving. It was a very nice
Эндоскопии
for us.
мы начали.
And we have started endoscoping quite recently. And it was, I would say, a good solution for us. Because it helped to release us from the large-scale work with related associated with open access, especially for elder patient. It is not convenient, especially the patient with diabetes mellitus. And so the patient who underwent conventional types of surgeries and endoscopy, you can see the difference in incision.
Коротко, значит,
Briefly, if we have this traditional approach, we have been using the general anesthesia. We have been using a lot of drugs, and we have been wasting a lot of time now. Under endoscopy, we are simply easily doing anesthetics, and it is easy for us. And while endoscopy, we are moving to, I would say, a shorter surgery period. So this is the way anesthetics are introduced with anesthesia, and we of course are having maximum 6 millimeter incision, and also at the traditional conventional open access surgeries, you know that incision quite high is quite long and big. So regarding our monitoring, I mean, we need to monitor permanently, which is not that easy, and we are wasting a lot of time. We need to stop the surgery. We need to leave I mean, we are exercising this X-ray navigation. So you can see how we're using our septics. And if we are having our traditional surgeries, we are having this dessert, and we are using these silica lamps, and we are having, I would say, aseptic air, but still we need to do permanent irrigation with NS, and we are adding adrenaline and kanamycin for local impact. This produces, I would say, a barrier to prevent penetration of infection. And when we have been having these open access surgeries, the key issue was the lack of the patient, I mean, the patient, lack of comfort for the patient. Patient couldn't survive the pain. So we will show you the visualization of comparing to open access surgery. And you can see that it's open, it's quite red. Yes, it's it's not nice. And at the endoscopy, we are having clean visualization. And after surgery is conducted, we are having the revision of the disc itself, cranially and caudally. And after the surgery is done, we are using fibrillation, and we are using fibrillation. So that's it from our side.
на второй день после операции больные выписываются домой.
So patients are let out of the hospital. And in terms of traditional surgeries, they need to stay in hospital at least for 7 days. That's why I would like to express my sincere gratitude to Professor Shomansur, to Mr. Ahror, who have been insisting on me to use this endoscopic method. And I'm very thankful to all of you, dear endoscopy surgeons. Thank you so much for your kind attention.
Any question or contribution, please? Thank you, Dr. Berdiye. Yeah, the next speaker is Dr. Sunil. He will talk about the endoscopic discectomy in dorsal spine. Interesting and dangerous issue, huh, doctor?
I thank the organizers for giving me the opportunity to talk here, and I also thank the translators who have been doing an excellent job of translating all the medical jargon live as it happens. My name is Dr. Raghav Sunil. I am an orthopedic spine surgeon from Hyderabad, which is a southern city in India. Today I will be talking about transforaminal discectomy in a thoracic disc. The incidence is very low. As we know, it's less than 5% of all the disc ruptures, and of all the symptomatic disc herniations, it is less than 1%. And of these, I think only up to 2%, at the maximum, up to 2% of surgically treated herniations are thoracic herniations, which is much less than 2% actually. And the lion's share of incidence, that is about 80% of the incidence, is in the third and the fourth decade of life. The surgery in this thoracic disc herniations is rare because it's challenging, and only cases where there is morbidity associated with the thoracic disc, like symptoms which are not reducing, or if there is any deficiency, we kind of tend to approach it surgically. And the most important aspect of the surgery is to avoid manipulating the thoracic spinal cord, which can lead to disastrous complications. So various options which are available to us, one is laminectomy, which have been described, transpedicular approach, costotransversectomy, transthoracic, thoracoscopic or transternal approaches have been described in the literature. And these are the various complications which we need to keep in mind: dural tears, transient neuralgia, the need for revision surgery, neurological injury which can sometimes be permanent, and also the incidence of dural hematoma which can cause compression on the cord and subsequent complications. Regarding the standard of care, there is no clear standard, so it is time for us to set a golden standard, which can be complete or full endoscopic spine surgery, which has been described for the thoracic spine in literature, and more of us are doing it regularly. There are two approaches in this. One is interlaminar and transforaminal. Both have been spoken about, and we have been shown a few cases of interlaminar approach for the thoracic disc before by Dr. Akror. And both these approaches should be considered before we decide on taking up the case. So this is a case of mine, a 46-year-old sedentary worker with a sudden onset of pain in the back, radiating to the mid-back more on the left side. The patient was not able to sit and stand or sleep for more than a few minutes at a time. On examination, there was paraspinal muscle spasm, tenderness over the dorsal spine around D8, D9 area, and also she was showing upgoing plantars and increased deep tendon reflexes on the left side. The MRI showed a prolapsed intervertebral disc, D8, D9, more on the left side, with early myelomalacia changes. Patient was advised surgery. They initially refused, but came back after a month because in India, people generally don't go in for surgery immediately. They try all alternative methods, conservative, local, everything, including praying on it. Nothing else works, they come for surgery. Patient was counseled and taken up for surgery. So this is how the MRI was. There was a disc at the D8, D9 level, which was predominantly on the left side. Predominantly on the left side, causing compression, and there was early cord changes also. Why did I choose endoscopic surgery and why transforaminal? I was not very convinced about interlaminar in this case because I didn't want to manipulate the cord. The disc was also lateral and it was a soft disc, and there was early neurodeficit, so surgery had to be done. So the surgery, basically these are the steps. Patient was under general anesthesia. Patient was positioned over bolsters, prone position. I was more scared about the level also because it's at the mid dorsal level. I wanted to check, recheck. 3-4 times I must have checked the level before I took it up. I put in the knife, and previous to taking care of surgery, we had consented and for open surgery if required. So this is how I checked the level of the surgery. I counted from bottom up number of free vertebra. I marked it on the MRI and then I checked it on the C-arm also before I confirmed. Then the system I used was a Delta Stenoscope by Joymax because that is the only system I have. The outer diameter is 10 millimeter, working channel diameter is 6 millimeter. The length is 2.5 mm and the working length is 125 mm. The view angle is 15 degrees. So then I target with the needle. I targeted the SAP, landed on the SAP because bone is our friend. As long as we are on the bone, we are safe. So I always try to land on a bone before doing any procedure. Then followed by dilator and then the working sheath. And the point of entry was about 7 to 8 centimeters from the midline. And SAP was drilled, removed, then the thin flavum identified, removed. Basically, I did a facetectomy and dissected out the disc fragment. And you can see the dura, and my dissector is going into the disc space. Because of the angle I am entering in, I was very sure that I was not handling or retracting the dura. So I was trying to be safe in this approach. And at the end of the procedure, the dura was free and mobile. The post-op, the patient's symptoms improved. Patient had a little bit of pain in the upper mid-back because there was a lot of fluid extravasation into the muscles. If you can see the image here, you can see the bulge of the muscles. A lot of fluid had gone into the muscles. So probably because of that, there was a bit of pain which resolved in a couple of days. CT and MRI were done. So this is a CT. You can see the foramen which is widened up on the sagittals, and on the axials also you can see the facet removed, and the approach is very clearly visible. And the coronals also, you can see that hemilaminectomy has been done. And this is the post-op MRI. You can see that the disc is gone, but the myelomalacia changes were persisting. This was immediate post-op. We had to do a follow-up MRI after some time. You can see on the sagittals, the disc bulge is reduced significantly, the compression is reduced, and on the axials, the bulge is gone. This is the post-op edema on the facet. The challenges in the learning was basically, as much as possible, try to avoid handling the cord, and I believe the transforaminal approach in endoscopy is a safer way than an interlaminar approach in treating thoracic discs. Even a little paramedian disc also, medial disc also can be, midline disc also can be treated because of the angle you are entering. You can reach up to the midline of the disc without handling the cord as much. Thank you.
Thank you, doctor. Please stay there.
Yes.
Is there any question or contribution?
Thank you for your presentation.
Thank you.
Only one question. Why do you use Delta?
Because that is the only scope I have.
Another one, please. No? If there is not, I have 3.
Good.
And I will ask all of them, okay?
Okay.
First of all, how many cases you have?
I have operated 4 cases in the last 5 years.
Okay, thank you. And why you are using big endoscope instead of normal endoscope?
because I.
And it is connected to second question is, did you have any danger for Adamkiewicz artery?
For the?
Adamkiewicz artery. Do you know Adamkiewicz artery? Because it is
Artery of? No, I don't think there was any danger in that. I have chosen cases where the disc was soft. It was lateral. I didn't try to be very adventurous in this. All my cases.
In Turkey, we were discussing about this issue.
Okay.
Sometimes Adamkiewicz artery is very important now. If there is any problem,
okay,
a patient will go to paraplegia.
Okay.
And my question is, are you doing any preparation before the operation? For example, spinal angiography. Is it necessary or not?
I have not done it till now. Maybe I've been beginner's luck.
Okay. Thank you. Okay, doctor. Thank you very much.
Thank you, sir.
Next speaker, Dr. Raimonov. He will talk about the different herniations in different locations and choosing endoscopic access.
So as we and Shamshur has the same idea, when you're trying to perform in the lower thoracic spine like D10, D12, L1, that is the highest chance of you encountering artery of Adamkiewicz, not in the upper thoracic spine. So, and it is usually artery of Adamkiewicz is aberrant on the left side of the spine. So left part of the spine. So you.
But Adamkiewicz artery has a lot of variation.
Yes, most commonly is the left, and right side approach is makes you a little more safer.
Okay. Thank you.
Assalomu alaykum, hurmatli hamkasblar. Meni dokladim.
Dear colleagues, good afternoon. Well, my report will be on strategy of selection of endoscopic access in different localization of herniation of, well, talking about endoscopic surgeries history. We had long discussions already, so let me move to the topic straight to the point. Well, clinical data, you can see that, well, yesterday I have updated them, and you can see as time goes by that we are having much more publications, that we had over 6,500 publications on endoscopic surgery, and we have bibliometrical studies of productivity of endoscopic spine surgery. So China is the leader, Korea is ranked second, and then it's US, Germany, and Japan. So talking about terminology, we know what herniation is, and here are anatomic zones of herniation placement. Axial planes are dilated into central, subarticular, foraminal, and extra foraminal zones, and also the disc migration zone, upper and downward migration, and endoscoping methods of access: intralaminar, transforaminal, inside out, transforaminal, outside in, posterior lateral, extraforaminal, and transpedicular access. So when you are trying to do something, you need to select the way to access, and here are our results. So since 2019, by now we have conducted over 2,175 surgeries on the lumbar department, and you can see this is gender and age distribution and segment distribution. We are using endoscopic like lateral, transpedicular, and posterior approach, transforaminal approach, inside out. 57 and transforaminal outside in over 1,300 and intraforaminal over 700 of surgeries. We're talking about unilateral or intralaminar access. We are using it in terms of herniation in L5S1 in case of significant muscle window in L5 in case of herniation, hypertrophy of ligamentum flavia, and stenosis. We are trying to using this intralaminar access contralaterally in case of stenosis, hypertrophy of ligamentum flavia, and high sacrum ala and ilium ala, and problems with transforaminal access. So transforaminal access, we had over 61 surgeries conducted, and this is L1 and L2, L5, S1. I mean, these are the access area, and we are extracting the herniation from epidural space. I mean, we can have it tesis, we can have it pediculotomy, and for a lateral, and it is in case when herniation is located centrally and its basement is quite wide. And from inside out, we had 57 surgeries, and I have already explained you the indications like stenosis and foraminal stenosis, and you can see the L5S1 level. When the ala is located quite high, I mean the margin of ilium, and here you can remove everything from L1 to L2S1, and what are the contraindication is that we can have the stenosis of spinal channel. And when you are having this herniation, which is located centrally, and when you're having the protrusion with wider basement and stenosis of spinal channel, canal, and if you're having these migrating herniations in zone 4 and zone 1, we had only 18 cases, and extraforaminal approach, 15 surgeries. It's quite convenient to conduct them, and we have been conducting them. I mean, we had only 15 cases. It will take you 15-20 minutes from the very beginning till the very end. You are installing endoscope and you are removing it. We are not touching any bone structures. So these are our outcomes. We are reducing the pain in extremities and back pain according to VAS, and on Asvestry scale. We are also, I mean, ODI. Also, we are seeing drastic improvements. Colleagues were sharing all these achievements. I would like to share about the complications. That surgery will never go, with complication, and here we have already discussed it. I mean, we had dural injuries with no neurologist, 30 cases, dural injuries with neurodeficiency, 3 cases, and also injury of root, 3 cases, and earlier recurrences is like 6%, 130 cases. So we can tell you that the result of endoscopic results are equal to results of open approach. And here, what are the major conclusions? We can divide it into 2 directions. One is intralaminar one, and the second one is transforaminal one. and we can reduce this compression factor and ensure prevention of additional traumatization of neural nerve structures, and it will help us to reduce injuries of adjacent tissues and bone structures. Thank you so much for your kind attention.
Thank you, doctor. Any question or contribution? I couldn't see. Thank you, doctor. Okay. Next speaker is Dr. Sholoxino. He will talk about the advantage of the endoscopic spine surgery. Shadakhanov. Doctor? No. Okay, cancel. At that time, this is the last speech is Dr. Volkov. He will talk.
Shadakhanov here.
Yeah, okay.
Assalomu alaykum, hurmatli ustozlar va hamkasblar. Bugungi temamiz umurtqa pog'onas kasalliklarida endoskop jarrohlik mo'ljasining ahamiyati.
Dear colleagues, we are very pleased to be here and to report our results and on degenerative and dystrophic disease. Talking about degenerative and dystrophic disease, in most of cases, it might produce negative impact on children's degenerative, shaping of the skeleton. So 90% is for children and 85% for elderly, and 25% among general population. And of course, improper shaping of spine causes a lot of degenerative disease. And if you will look at the evolution, as we have already talked to you that previously it was open surgery, open access surgeries, and microdiscectomy, and now endoscopic surgery. This endoscopic surgery, it is very safe and state-of-the-art way to diagnose and conduct the treatment of spine problems. Of course, it leaves no scars. We are just having 5-7 millimeters incision on the skin of the patient. A rehabilitation period is quite short because we are not producing any impact on the patient's health, and the patient can be let out of the hospital in one day. So we are now, and the scope is very good device to show us, I would say, big and expanded view of the injured area, and the surgeon might use various techniques to access the lesion area. It can be transforaminal, intralaminar, extraforaminal, and in cervical part we can have anterior and posterior approach by using cannules. So talking about the working statistics for 23-24, we had over 433 surgeries. In most of cases, 91% of cases, it was herniation. In 4 cases, it were the stenosis and epidural abscess in 2% of cases. And talking about our patient, you can probably look at some of our cases. Now we had some problems on the right side. You can see that according to MRI result, it might be probably a tumor. It might be some probably herniation. So we need to decide it. And now look at the video from the surgery, how we identified what is the issue. We have penetrated using endoscope, and we can see that it's herniation. We clear this area out, and the endoscope helps us to get a bigger picture of what we have, and we are reducing this area. I mean, reducing the bleeding by using laser, and L4, L5, or L1, L2. We are having here the stenosis, and we have done endoscopic decompression. We are showing you some videos. So we have been using shaver, and we are now expanding the channel, the canal actually. And we can tell you that we are using kerosene punches, and it helps us to actually to reach the area, and you can see that there were some junctions which we have removed also. So this is the last case after the decompression. We have done it, it was both cephalite and caudal decompression. So just one more case. Several years ago, our patient underwent open surgery, and you can see that recurrent herniation is forming here. So we are taking this patient to a surgery, and we have identified the herniation, and we have resolved the issue. We are showing you now how we have been removing the scars also. So that's it. I mean, before and after operation. Thank you so much.
Thank you very much. Last speaker is Dr. Volkov. Your hearing is very interesting, doctor. To miss or not to miss?
Добрый вечер, уважаемые коллеги. Тяжело быть последним докладчиком.
Dear colleagues, it's not easy to be the last one to deliver my speech today. I would like to express my sincere gratitude to all of our organizers and those who are here in the audience with us. So my speech is dedicated to minimal invasive spinal surgery. So the title "To Meet is Not to Miss" comes from classical English literature.
Прошу прощения. Какая-то проблема.
Это же сайт какой?
У вас распределился экран, то надо сделать в режиме докладчика. У вас PDF?
Нет, почему PDF? Стоп. PowerPoint.
Пуск нажми.
Прошу прощения, тут какие-то внезапные сложности. Всё, спасибо. А туда пойдет? Ну ладно, вторая попытка, может повезет. О, отлично. Что такое МИС? Google дает кучу всяких ссылок.
What is a miss? Google gives a lot of, I would say, references, and miss. It's like resources which are oriented to patient like less invasive surgery and less traumatic surgery. Indeed, you're absolutely right, actually. But anyway, when we're talking about small minor injuries, talking about technologies which we're using, so we should come up with solution. But let us be very fair, sometimes it doesn't mean that they're too small. No, and those who are dealing with this the tea leaf operation, you are very well aware that not every time you can manage to have, I would say, such a easy surgeries and easy movement of muscles. And okay, let us go to the world of myth, which was initially was by Parviz Kambin, who was the founder of endoscopic surgeries. And you can see that the things are quite understandable and for us, because at that period we had no endoscopic shavers, and also Parviz Kambin developed a port. How can we have access to channel, and his Treflan were nice actually equipment who give a good opportunity for microscopic surgery. And you can see this how we have been treating this fusion. We are not doing here, we're not using the screw insertion, you can see. I do not know how he penetrated, how he inserted. Unfortunately, we do not have it on the video, but still endoscope is the myth. And it will have its own, I would say, its advantages, and of course it is not easy to penetrate with cannula into working port, but still talking about intraluminal access, it might take you 10-15 minutes, and when you can have this ligament of Flavia, and you will reach your purpose. And for endoscopy, the best thing is a visualization. On your left side you have microscope, and you on your right side have the endoscope, and it gives you a better lighting, and the quality of picture is also the top one. And the same actually we have when we are using a narrow retractor. And of course, talking about visualization, it is also very important. It is quite big. I would say it is at the maximum possible extent, and we should also keep in mind that it's not just the muscle, I would say, problems. We need to prevent issues. Sometimes we are destabilizing situation by injuring facet joint complexes. So when we're having intralaminar surgery, it is easy to penetrate, and for endoscopy it's quite easy, and for transfer surgery also you see no retraction of nerves. So what do we have? We have a 100% miss. We have no injuries. We have very small incision. We have very small traction of retraction contraction of nerves, we're getting better visualization. And now let us go to evidence-based medicine. And here, unfortunately, we are getting, I would say, cold shower. And the last meta-analysis conducted embraced 9 randomized clinical trials, and we see no difference between open and open and endoscopic discectomy. Would it be in terms of primary and secondary outcome assessment instruments? Of course, we're having less indication on muscles, dam injuries, but still, based on these clinical trials, we cannot develop certain, I would say, recommendations. Yes, of course, we are losing less, probably 50 milliliters of blood, but it's not a clinically, I would say, significant indicators. And talking about scientific data based on, I mean, which we can get according to evidence-based medicine, we can have minimal, I mean, comparing to fusion and to TLIF fusion, you can see that we will, in all of cases, based on the primary outcome assessment, we have nothing. And for the secondary outcomes, we do not feel something significant. Probably there might be no advantages, but the issue probably might be that the system of assessment probably is inefficient. Therefore, we cannot I would say, identify these differences. Of course, we can have open discectomy with a conservative treatment, and we can have endoscopic treatment. We have no differences, and I mean, in terms of surgery also, and we do not know even what surgery should be done, by the way. And for one tool, I mean, people are feeling less leg pain comparing to conservative treatment. So, stemming from evidence-based medicine, we have no evidence which are showing the differences between endoscopy and open access surgery. And of course, we need to get new tools to assess and to conduct new assessment, and we need to have better clinical tests. So we have other point of view, be or not to be. And so Hamlet's monologue from Shakespeare's trilogy of the 16th century is still relevant to and a lot of psychologists, philologists, and philosophers are assessing. So this is the issue to this is the issue of selection, the issue of choice. So options are well known, and the issue is what road to take. And this is the tragedy when the person who couldn't select it. But in our case, it's not a tragedy. If evidence-based medicine leads us nowhere, then we can make our own selections the way we do. So go by your side, and those who are at the side of endoscopy, may force be with you.
Thank you, Dr. Volkov. Is there any objection to Dr. Volkov? Any contribution? Okay, I didn't see. Sorry.
Спасибо за очень интересный ваш
A
доклад.
little bit close.
Thank you so much for your interesting report, and you are very famous surgeon in Russia. And talking about endoscopy, you are, I would say, mentor for us, and we think that we deem you as our mentor. And my question is, when you have been comparing open access surgery and endoscopy, what do you think? I mean, how feasible is for us to compare two types of access, interlaminar, transforaminal? So you know, the discussion is lasting for a long time. I don't think that we can compare it. They are not mutually competing. They are mutually substituting the weights. No, actually, I'm not the one to compare. Actually, here we need to be more creative, but based on the well-organized research. So one of the major purposes of my message at the moment is that we cannot compare, not because there's no differences, but that we cannot measure the differences because we talking about VAS, we're talking about ODI, but we have no indicators to compare in our hands. Thank you so much.
Is there another one? Dr. Volkov, can I ask you in English?
Yes.
Are you sure that? No. Are you sure? Because you are using the literature, huh? Okay. We wrote a textbook in this issue, and approximately we read 1,500 articles. And I saw that following the 2000 or 1997, I am not believing the articles. Do you understand me? That's the big, huge problem. If you search the article directed to any goal, you can say everything. For example, now, this night, if I work about this issue, I can say that endoscopic surgery is superior based on these and these articles. So, just a moment. I am coming from the very classical era, from brain surgery, brain macrosurgery. Okay, and my philosophy is, if you can do it, do it. If you do any operation, for example, for this herniation, if you use open surgery and the patient is okay, that's okay. Do it. What do you know very well? This is my philosophy, and I don't think that this is superior or inferior. Still, there are a lot of gray area. That's my idea. Okay. If you want, you can say something about this issue.
Позвольте, я на русском языке скажу, чтобы, может быть, более
Sir,
широко.
upon your kind permission, I will answer you in Russian. And, well, the question was, can we trust the articles which are already being published? I don't think that we can, but the evidence-based medicine is the only, I would say, tool which we have at the moment in hands to systemize something which we already have in hands. Well, thank you so much, Dr. Volkov. Yes, this issue is, I would say, issue for discussion. And probably in the coming years, we will try to find it. And probably you will be the one to prove us, to give us the evidence. Any questions? In case of no questions, so we are wishing you good luck. So our today's program has come to an end. I would like to express my sincere gratitude to all the participants, to all of our speakers, to our audience, and our program for today came to an end. Tomorrow we will have a very interesting program. We will have 2 surgeries, and we will be seeing them and we will be discussing them with Professor Lim, and also at 7 p.m. we're going to have our gala dinner. At 6:30 we have to be here at the hall of our hotel, and it will be held at the Sahid Zarafshan restaurant. So I would like to invite all of you, dear colleagues, see you there.
7 p.m. the dinner in Zahid Zarafshan. So 6:30 we will be in lobby of Varaksha Hotel. But who is not staying in Varaksha Hotel, who is nearby, can go. If somebody needs transfer, please tell me, because the restaurant is very nearby to the Zahid Zarafshan, 5 minutes walking from this place, it's like 7 minutes walking. It's very nearby. So if somebody needs transfer, please tell me. Okay. So we are closing the session.
I especially thanks all speakers, also all colleagues. Thank you very much. I am closing the session.